Not a new topic for most of you. You are all pediatricians assembled here, and you have been using the oxygen delivery system regularly. So, you know what are the indications for oxygen delivery, and the administration of oxygen for children requires selection of oxygen delivery system that suits the child's age, needs and size, clinical condition, and therapeutic goals. So it should be safe, easily available, and cheap. The other thing is, when you think of oxygen therapy, you always think of clinical scenario, and your pulse oximeter and ABG are the usual criteria for starting oxygen. However, most often we start with the clinical criteria, where we have increased respiratory rate or increased work of breathing is a usual common scenario where you see where you start oxygen. And the other thing is the saturation, which is lower than 94, and if there is any cyanosis. So there are two types of oxygen delivery system. One is the high flow and the other one is the low flow. Low flow is the cheap available thing, which is used commonly in the most of the emergency departments. And low flow, why do you call it as low flow? Because 100% oxygen mixes with the room air during the inspiration, and the room air is entrained, making the percentage of delivery oxygen oxygen variable. So commonly used ones are nasal cannula, simple mask. However, we used to use the oxygen tent and head box, which are of late not been used. And the requirement of oxygen for those is very high. Usually it is about 8 to 10 liters if you are starting a head box oxygen. So oxygen requirement goes up. And the other thing is there is rebreathing in it, and if it is not kept properly. So now the thing is, most of the patients are on either nasal cannula or simple face mask. So nasal cannula is a simple plastic tubing plus prongs over the ears for adjustment, and you all seen it. The sizing of availability is between neonate children and adults. So FiO2 increases about 1 to 2% with every increase in liter. The flow maximum you can give is 5 liters. So this is a picture of nasal prongs. This was it was prepared for not for the pediatrician. We thought it was more of a MBBS doctor. So please don't mind seeing it. So these are the various sizes of nasal prongs available, and so with 1 liter you are just going to increase the room air oxygen concentration from 21 to 24% maybe, and for 2 liters it's about 23 to 26%. 3 it is about 27 to 34%, and for 5 liters it's between 30 to 45%. So advantages is it is inexpensive, well tolerated, you can speak, you can eat and drink, and most children don't get scared of it, and you can also humidify this and give it. So the downside is the crusting of the secretion, epistaxis, drying of the mucosa. Sometimes the children don't tolerate this nasal prongs in the nose. That's one more thing. And there can also be bleeding epistaxis because of this irritation of the prongs. So coming to simple face mask, we all know that it has got a metal to contour the shape of the nose so that it is tightly fitting, and there's an exhaust point, and there's a entry point there for oxygen delivery. And simple face mask, you have to give at least 5 liters of oxygen for face mask, or else you'll be rebreathing. So 6 liters will provide about 35%, 7 liters is 41, 8 liters is 47, 9 liters is 53, and 10 liters is 60%, provided the mask is tightly, snugly fitting on the face. If there is leak, it may be more. It may be less concentrated. So the lateral perforations on the mask will help the CO2 to escape from it. You can also use humidified oxygen with it. So this is the most commonly used, but the advantages are simple, lightweight, economical, comfortable for the patient. FiO2 approximately around 50% can be delivered, and you can use humidified oxygen. Downside is the baby cannot speak, drink, and the lack of tight seal. Some children will be claustrophobic. They don't like the smell of the mask. Most often the children complain about the smell of the mask and they don't accept the mask on the face. So these are the common disadvantages with the face mask. So when you come to high flow oxygen, you have a fixed delivery of the concentration of oxygen. That is the difference between the low flow and high flow. Both the places you are giving 100% concentration, but there is variable because of the room air entrapment in the low flow oxygen. But whereas high flow, it is not so. It guarantees the amount of oxygenation given. So commonly used is non-rebreathing mask, high flow nasal cannula. Venturi mask is also used as a high flow, but with the COVID season, I don't think we should encourage using Venturi mask. However, there is no data about it, but may cause aerolization, so I have not included the Venturi mask here. So non-rebreathing mask, it has got a restraining strap to hold it on its face. Then you have an oxygen delivery tubing. Then you have one-way valve for exhalation and one-way valve for inhalation, and you have an entrainment valve. This is what it is generally. And when you are applying the NRM mask, the reservoir bag should be full. So usually you are starting with 10 to 15 liters of oxygen. There's nothing like less than 10 liters. Okay. It is indicated for high percentage of FiO2. Incorporate use of reservoir bag. I've already told delivers up to 100%. If one flap is removed, it gives about 80 to 85% of the FiO2. If both the flaps are removed, it gives about 80 to 85. And if one flap is removed, it gives about 85 to 90%. Both flaps are in place, it will give about 95 to 100%. So only thing is, if you don't put it properly on the face and if it is not snugly fitting, it can become low flow system because again the entrapment of room air gets into the mask. So advantages is you can deliver FiO2 more than 60% and oxygen inhaled from anatomical dead space can be conserved. So disadvantages are insufficient flow rate may lead to rebreathing, and claustrophobia, lack of tight seal can cause us low flow systems. So coming to the high flow nasal cannula, which is commonly used and it's been the part of COVID. So what we suggest is the most emphasis is on the high flow nasal cannula. However, during the pandemic, we had a lot of problem with the oxygen consumption. So many of the places they had removed HFNC for adults because the consumption of oxygen was very high, 60 to 100 liters. So they were all planning to they were putting on NIV. But children may not require so much. It can be between 20 to 25 or max is 60 liters of oxygen may be required. So this is one thing which can prevent or which can postpone your intubation, and that is why the emphasis is on high flow nasal oxygen. Cannula can be used as a high flow delivery device, and nasal cannula can be used. The oxygen flow rate can be adjusted between 4 liters to 40 liters or more in the adolescents. The flow can be titrated to provide additional respiratory and expiratory pressures, which help the patient's work of breathing, reduce the work of breathing. So this is an old picture. We have an airvo system, which is more sophisticated than what I showed in the picture. So these are the cannula sizes, and humidification temperature is about 34 degrees centigrade, and set flow rates can be 2 ml per kg. And for 1 to 4 years, it's about 20, and 5 to 10 years is 25, and above that it can be between 50 to 60 liters per minute. And the FiO2 can be given at 100%. So these are the various ways to pick a picture depicted to pick up your nasal cannula. So easily picked up. The pictures predicted. The pediatric one is a bird, and the infant is a butterfly, and the neonate is a bug. So you can make out from this and pick up the cannula size required for the connection of humidifier. So, well, the indications, most of these indications have disappeared in the last 2 years, except COVID. COVID has replaced bronchiolitis, asthma, pneumonia, which we used to see regularly. So or group. So it is more often COVID, crew, post-extubation and pre-oxygenation prior to intubation is what it is used. And the other indications hold good. Okay. So it delivers optimal humidified and warm gases and creates positive end expiratory pressure, and it decreases the work of breathing. That's how it helps most of the children. There are many studies which have shown that humidified high flow nasal oxygen has postponed or has prevented some of the intubations which could be extubation. Probably you can use some post-extubation also. It has prevented many of the extubation failures. So I think it is a very advantageous thing. Only thing is the flow rates have to be reduced, and it has to be monitored on a regular basis. Disadvantages are that abdominal distension will be there because you are giving through nasal cannula and it is high flow, so you need to put in a orogastric tube and decompress the abdomen. Aspirations are quite common. Barotrauma may be there. And again, there can be epistaxis, crusting, all these things can happen. But crusting is not well known with humidified oxygen, but there can be epistaxis and other things. So this is a slide which I borrowed from All India Institute of Medicine, Medical Sciences. This basically came out when we had a peak of oxygen shortage around the whole country. This was probably during the second wave peak during May or something like that. And in the midst of May 15th or something, it came out. The best way to optimize titrating HFNC is you can put anybody on HFNC, but you have to remember one thing: the child should be conscious and should have a spontaneous breathing. You can't put somebody onto the HFNC who's unconscious or comatose. And the other thing is there must be spontaneous respiration for HFNC to work. So clinically you can look at it, or you can correlate with the ABG monitoring. So you can connect this HFNC and see. Watch for 1 to 2 hours, see if the work of breathing is better, respiratory rate comes down, or the saturation goes up beyond 94%, then probably the HFNC is working. If it is not, if say the respiratory rate goes up, work of breathing becomes more, then probably you will have to switch over to non-invasive ventilation, or try to reduce the flow of HFNC, or probably what you need to do is go and intubate and mechanical ventilation. So when you are looking at this, how to taper this HFNC is one more thing. Starting on HFNC is easy, but how do you taper it? There are a lot of criteria to go about. There is one called as ROX criteria used by most of us. ROX criteria is respiratory rate with oxygen index. So when you do this SpO2 by FiO2 levels, if it is more than 300, you think that the child is getting better, and start reducing the FiO2s. So if the child is maintaining, or other way to do it is, if you are not having an ABG, the other way to do it is, if the saturations are more than 95, work of breathing has come down, respiratory rate has come down, then you can reduce the FiO2 by 5 to 10% and see how things go. Wait for another 2 hours and then further you can reduce. If the work of breathing is good and the respiratory rate has come down, the flows can be reduced by 1 to 2 liters in children per hour, and then keep monitoring. And if things are better, then if the flow rates come below the 8 liters and if the FiO2 is around 40%, then you can switch over to the low flow system. This is how we are going to wean the HFNC. So one thing is, the baseline disease should have been better, and it should be maintaining oxygen on a low flow mask. Then only you are going to remove it to a low flow system, or else you are going to hike it up if it is not better. If it's not tolerating HFNC, if the saturations are lower than 92%, please go and go to NIV or intubate. When you are putting a child on NIV also, you need to monitor, and I think Dr. Girish will be talking about NIV, so I won't touch upon it. So coming to strategies to optimize, I've already told that the child should be conscious oriented. And the other thing is, if somebody is on a prolonged NRM, probably you can try him on this thing. And initial HFNC settings, the flow rate is about 1 to 2 liters per kg and can go up to maximum of 60 liters. And so I've discussed most of the things what is displayed on the slide. That is, if the child deteriorates, what is the next? The signs of deterioration of HFNC is also been explained to you. The work of breathing and respiratory rate, which is very essential, and you get to. The thing is, you cannot put somebody on HFNC and walk away from that place. You need to sit there and monitor, and that is what is the basic idea behind all these things. Okay, so this again slide came from AIMS to how to conserve oxygen. So in case if you are not using the cylinder, please don't prefix the flow meter because it's going to leak through the flow meter. That is one. Tighten the screws and make sure that the leaks are not there. The second thing is the nasal prongs flow rate is about 2 to 4 and maximum FI2 is 40%. That is what they want to do. And mask is about 4 to 8 liters, not to go up to 10 liters. So maximum FiO2 is about 60%. And to reduce the oxygen as far as possible. For the NRM, they have suggested airflow along with the oxygen. And PEEP, the CPAP and BiPAP, they have reduced the oxygen flow depending on saturations. So these are things which we have to understand, that one is the awake positioning, which can help the lungs to open. So these are few things which will come up from the AIMS for during the COVID season. I hope most of you would have got it on the WhatsApp University, so I don't think I'm doing anything much greater than what you have seen. So endotracheal intubation is to maintain effective airway oxygenation and or ventilation. So you know all the indication, but the present indication could be COVID, and we will be dealing with it more aggressively. So whenever you are going to intubate a COVID patient, there is some guidelines that you have to wear a PPE, you have to wear a mask and a face shield before intubating somebody. So first is protection of yourself, then you go to treat your patient. Quite often what happens in the emergency is the younger doctors, they tend to be very aggressive and probably they forget about the safety of themselves. And we have seen a lot of our postgraduates becoming positive because of this during the intubation process. So I suggest please take care of yourself before you take care of somebody else. That is the baseline here. So we all know that it requires a laryngoscope, blade, laryngoscope handle, proper size cuffed endotracheal tube, resuscitation circuit, ambu bag, proper size face mask. So we all know how to figure out a proper size face mask. The nasal, it should be fitting on the nasal bed, not covering the eyes and not having a leak anywhere. So you have to have a tight fitting mask on your face to deliver proper ambu. So this is again the repetition of the same thing. So appropriate sedation and vasoactive substance. You need to have a very good IV access here before you start giving the medication, or you are planned for intubation. Please make sure the IV line is proper. Put up the monitors like to see the ECG and saturation so that you know where you stand. Start pre-oxygenation with 100% oxygen. If it is on humidifier, you can use humidified oxygen or NRM. To give more oxygen, or you can use Jackson-Rees circuit or a ambu bag to increase the oxygenation via wash of the nitric oxide, whatever is in the lung. And the vasoactive, you keep your emergency medications. Pre-medication with glycopyrrolate may help you. Atropine may not be used because very difficult to see if you have a problem during intubation. It will be difficult. So glycopyrrolate is the much used drug. Fentanyl can be used as pre-medication, and during the intubation you have to make sure you have So during the intubation you need to make sure that appropriate medications are kept. What paralytic agents you are going to use. Commonly used are rocuroniums. If you are in a hurry, succinylcholine can be used. And if you have a doubtful of getting the hold of intubation, probably because it is one of the shortest acting, but it is cannot be used in all the situations, because if there is a renal failure, or if it is a crush injury, or if it is a burn, you can't use because of hyperkalemia, and there are certain group of patients where you cannot use it because of hyperpyrexia. And so commonly used is rocuronium, vecuronium, etracuronium. Rocuronium dose is 0.6 to 1.2, vecuronium is 0.1 to 0.2, and succinylcholine is about 1 to 2 milligrams. In children less than 2 years, it is about 2 milligrams, up to 1 to 2 milligrams, and more than 2 years, it's about 1 to 1.5 milligrams. So these are, it is up to the person how he is suited to do this, whichever he or used. So most of us, I am very comfortable using vecuronium because I've been using for the last 10 years. That it takes about 2 to 3 minutes to work, about 120 to 180 seconds it takes to work. So that is the only downside of it, but it gives a good this thing for paralytic to intubate. Then coming back to your anxiolytics, it can use anesthetics or anxiolytics. What you want to use is midazolam is a commonly used. However, if there is hemodynamic instability, you can't use midazolam. So you can consider using ketamine here. The dose is 1 to 2 milligrams. Midazolam is 0.1 to 0.2 milligrams. And you can use propofol. It is 1 to 5 milligrams. Thiopenton can be used. Very rarely we use thiopenton. Only when we have head injury patients we use thiopenton to intubate. So coming to the blade, laryngoscope blades, Miller 0.1, 0 to 1 is for up to the age of 1 year. Miller 2 and or Mac 2 up to 2 to 12 years. And again, I tell you about the blade. It is your comfort to intubate. There is no hard and fast rule to use the same number blade for everything. It is your comfort. Whether if you are used to intubating Mac blade, you can use it, or if you are used to with a straight blade, you can use those. Most of the pediatricians are very commonly use straight blades for infants, and probably in the pediatric age group they use the curved blade. So this is what I have seen, but I may be wrong also. So coming to the tube size, we all know there is different sizes of tube available. So we have this formula, and we all know about the formula. I don't think we have to go about it. ET size into 3 is the fixation point for infants, and we have the other formula for fixation about 2 years. So coming to the size of endotracheal tubes, you have for 1 month-old child 3 to 3.5, 6 months 3.5 to 4. Up to 1 year it may be 4 to 4.5. After 2 years 4.5, and about 2 years you have the formula to calculate. The best way to go is the ring finger, and see if you don't know the formula, you forgot the formula during intubation, you can think of the size of the ring finger. Look at the ring, the last finger. And go ahead for the size. I mean, you can choose the size. This could be also okay. So procedure is, again, you have to take care of yourself, wash your hands, check the equipment, endotracheal tube, attach the blade. Make sure you wear a PPE with head mask and face shield before you intubate somebody. I know you all have intubated, and I don't think I have to go into, I think the crowd is only pediatricians or anesthetists. So I don't think I should be going into details of intubation. So just for your sake, infants, probably sniffing position is the best position to put a roller below the this thing, shoulder, so you get the good visualization of the visualization to intubate. So so usually what happens is, when you are intubating, what happens is you are intubating with your left hand, you have the blade, but sometimes what happens is, if you have not pulled the tongue properly, if you are not going through, you are most often obstructing your vision to the trachea. You cannot see the larynx properly if you are not positioned yourself properly. So make usually use the tube from the right edge of the mouth and go through and push it. What happens with most of my junior colleagues, what I see is they just try to put in, and when it is halfway through, they lose the vision, and it is most often a failure intubation. So this is one thing which we have to keep in mind while intubating. So, and if you are intubating a bigger child, you have to make sure that the blade is not anchoring on the incisor teeth, which can break and can cause legal problems. So please be careful while intubating a bigger child. So these are the few things. And so other thing is to our technique of opening the mouth is cross finger opening, which put your finger in and open it up, or you can use the blade to open the mouth. It depends on your comfort. Okay. So this is one picture. If you are using a curved blade, you just have to put the pressure below the tongue so that it opens up. If you are putting a straight blade, you have to pull up the epiglottis to visualize the larynx. This is what this is a picture for. I mean, I had prepared for not the pediatricians and the anesthetists, so please excuse me. So once you have to place the tube, you have to make sure that the tube is in position. So how do you make out the tube in position? Is one, you have the humidification, then the chest rise, but the gold standard is to use the ETCO2 monitor or a device which changes its color once you start bagging, once CO2 is seen. So better to use a ETCO2 to make out, and there should not, the air entry should be bilaterally equal, and there should be decreased air sounds, breaths or ambu sounds in the stomach. That is one way to make out. Other probably common problem is you are intubated, you are there in the trachea, but the problem is you are not able to ventilate. There is decreased air entry on the right side. When you auscultate while bagging, it looks all right, but it's not. I mean, if you don't take an X-ray post X-ray intubation, then you are into trouble, because you can have a. This is what the one on the shows the collapsed right lung. So after repositioning, it can open up. So so basically that is one thing you have to remember. And while if you are some people are always you are very much comfortable using a stillet, but while removing the stillet there can be displacement, because most often the stillet is used multiple times. It will be bent across the line, across the tubing. So make sure that the stillet is fine and you can remove it without a problem. So these are few things which I would like to bring to your notice. So advantages is to provide an unobstructed airway when properly placed, prevent aspirations of secretion, decrease anatomic dead space approximately by 50%, facilitate positive pressure without gastric inflation. So disadvantages are needed advanced training for putting it in, and probably in a few days you may have this visualized intubation video assisted. It was there for a few days, and now it is not not available, I think. You could intubate with that for about 5 patients. If you it used to switch on for 5 patients. So this is what probably a video laryngoscope which was there, but to get it out of the this thing from the laryngoscope to remove the tube was little difficult with those things. They said that they are going to fine tune and get back to us, but I am not sure what has happened to it. But it is a very inexpensive thing. It was about 2,000 rupees, and you could also video record it on your phone. I don't know whether it's available now. So thank you. Any questions, please? Okay, thank you.
ಕರಿತೀನಿ ಸರ್ ಇದೆ ಪಾಯಿಂಟ್ ಇದೆ ಇದು ಬೇರೆ ಪಾಯಿಂಟ್ರಿಗೆ Thank you, Raghunath sir, for your talk about intubation and oxygen delivery system. Now I welcome Dr. Girish sir to talk about non-invasive ventilation. He is pediatric intensivist in Manipal Hospital.
Vikram and Manipal.
Vikram and Manipal Hospital. Now he has changed.
Transition. Hi, good morning. I'm in between Vikram Hospital and Manipal Hospital now. We are in transition. Yeah. Yeah, thanks. So at the outset, I would like to thank Dr. Prashant and Dr. Bhanu Prakash and the entire management of BBMP for inviting us for this program. I am going to talk about non-invasive ventilation, and some of which may be a little overlap from what Raghunath has already spoken regarding HFNC. So how do you define non-invasive ventilation? So basically, if you are ventilating a patient without any artificial airway, that is non-invasive ventilation. So you are using patient's own airway to ventilate, then it is non-invasive ventilation. So there is no tracheostomy, there is no endotracheal tube, or there is no laryngeal mask airway. If you use any of these, it becomes invasive ventilation. So how do you classify non-invasive ventilation? One is by giving positive airway pressure, and the other one is creating a negative airway pressure around the chest. See, ultimately the way we breathe is we create negative airway pressure, negative pressure around the pleura, and which causes breathing. That's what we normally do. So you can ventilate somebody artificially either by creating negative pressure around the chest or by positive pressure at the face. Anyway, I'm not going to talk about this because this is hardly used, very rarely used nowadays. I mean, in Britain, I think still people are using it for neuromuscular diseases for a long-term management. But for COVID or for any acute care, it is hardly used. So I will not be talking about non-invasive ventilation where there is cuirasses which are put across the chest and causing negative pressure to cause ventilation. So what I'm going to talk about is non-invasive positive pressure ventilation. I think there is some. You have to press anything? Oh, okay. I think there's some loose connection here. Huh? Sorry, just. Okay. So I'm going to concentrate only on non-invasive positive pressure ventilation. So why do we need it? I mean, when we have invasive ventilation already, why do we need non-invasive ventilation? The most important advantage of non-invasive ventilation is it avoids the complication of artificial airway. So that is the only difference between invasive and non-invasive ventilation. In non-invasive ventilation, you are using the patient's own airway, complete, starting from the mouth or nose all the way up. So you are avoiding the artificial airway. So we know the complications of artificial airway. It causes airway injuries. It causes infectious complications. Anybody who is on ventilator for more than 24 hours, we know that they are at increased risk for ventilator-associated pneumonias. And also we know that airway is an irritant. So we end up sedating patients who are on the ventilator. So these are the advantages of non-invasive ventilation. You can avoid all these. Plus, what are the advantages over IPPV? Because we are leaving the patient's airway intact, and we know that, whenever somebody is on NIV, they can eat, drink intermittently, they can come off the NIV, they can drink, and they can go back to non-invasive ventilation. So these are the advantages of non-invasive ventilation. Of course, in India, we don't do much outside the ICU, non-invasive ventilation, but in the Western countries, nowadays, people are doing NIV as in the ward settings. Right? But it needs a lot of training. But that is one of the other advantage of doing non-invasive ventilation. And also, even in India, we do send the patients on NIV at home, BiPAP at home for neuromuscular kids. Why can't we do it in everyone then? Why should we intubate anybody? But remember, one of the most prerequisite for an NIV is a patient should maintain his own or her own airway. So that is a prerequisite. So we cannot be doing this when airway is at an issue. So airway has to be maintained by the patient. So when that airway cannot be maintained by the patient for any reason, we cannot use NIV. And also NIV, people can remove it. We cannot sedate the patient, so they can remove NIV when they are agitated. So if somebody cannot sustain without ventilation for few minutes or 10 minutes, 5 minutes, then they should not be on NIV. So we cannot do it in everyone. And also, if there are a lot of comorbidities, you should not be subjecting somebody to NIV. You should be rather doing invasive ventilation. So what are the contraindications for non-invasive ventilation? Of course, all these are listed here, but nowadays we are trying to push the boundaries. We are trying to use NIV in much more pathology than we used to do it about 10 years ago. But as you can see, one of the most important theme is if there is an airway issue, because you are using the patient's airway for NIV, if there is an airway issue, you cannot use NIV. If you have a major facial trauma, major upper airway surgeries, fixed obstruction of the upper airway, inability to protect airway, if they don't have a good cough and gag, you should not be doing NIV because they can massively aspirate. Impaired consciousness for the same reason. Confusion, agitated patient because they will be taking out the NIV repeatedly. You cannot be doing it really. It won't be useful. And bowel obstruction for the same reason, because some amount of air goes into the gut when you do NIV, because you are not bypassing the esophagus. Even your airway is, you are using the patient's own airway. And so these are some of the contraindications for NIV. You shouldn't be doing this when these things are there. So basically, to summarize, prerequisites for NIV is patient can be sick but cannot be moribund, because when there is a patient who is moribund and you put them on NIV, even another 5 minutes or 10 minutes they remove the NIV, they will be at higher risk for death. So you should not be too sick, but sick patients can be put on NIV. They should be able to protect the airway. They should be conscious and cooperative. They can be semi-conscious, but as long as they can protect their airway, you can still use it. Hemodynamically stable, because you cannot risk somebody who is in shock with an NIV, because you have already one system which is involved, hemodynamic instability, and you put them at risk with respiratory system, they cannot sustain. And no excessive respiratory secretions, because when there is a lot of respiratory secretions, it is probably a better idea to intubate them and try to address the secretions through that rather than putting them through NIV. And there should be few comorbidities. In pediatrics, it has been used in multiple scenarios. This is a list of where it has been used. And increasingly, as I said, we are using in many more patients than what we were doing 10 years ago. So increasingly, the number of NIV usage has gone up significantly in the last 1 to 2 decades. So non-invasive positive pressure ventilation or non-invasive ventilation, it can be CPAP. Already Dr. Raghunath has already spoken about HFNC. Though it is high flow nasal cannula, it does give you some positive pressure. We'll come to that. That is why you can classify it as an NIV. And of course, what we all know as a classic NIV is BiPAP. So these are the things we are going to talk about. So the central point in all this is positive pressure, CPAP, right? Continuous positive airway pressure. The reason we use NIV, either a CPAP or a BiPAP or HFNC, is to probably create a positive pressure at the end of expiration. So I just want to spend 2 minutes on this slide because it's important to understand the concept of PEEP. This is your volume, this is your pressure, this is lungs. Just imagine, I'm sure all of you at some point in your life have blown a balloon when you were small, right? So let us start with this. This is where the balloon is flaccid, so there is no pressure and there is no volume in the balloon. And we all know when we start inflating the balloon, what happens? We put a lot of pressure. You know that to start blowing a balloon, you require a lot of pressure. And this much pressure actually causes only this much change in volume. right? We all know that. But at some point when you achieve this critical volume, you know that it is easy to blow the balloon further, correct? So at this rate, at this stage, you blow the balloon and then it becomes extremely easy. So only for this much increase in pressure, the volume has gone up from here to here. So what happened here is by giving this critical pressure, you have improved the compliance of the balloon, right? Just by increasing the pressure to that critical volume, you have increased the pressure. And we also know when you blow the balloon to an extent, further inflating the balloon becomes difficult, right? You need a lot of pressure to further increase it. So that completes the pressure volume loop. So what is important here is this critical pressure you give at the initial part, which expands the balloon or the lung to a certain volume where it becomes easy for you to blow the balloon. So this is the concept of your PEEP or CPAP. See, PEEP is a modality, PEEP is a entity you set on the ventilator, but CPAP is a concept that continuous positive airway pressure at the ventilation at the beginning of inspiration is the one which increases your compliance of the lung. So whenever you are providing a PEEP or a CPAP, imagine this, that it is making you easier to blow the balloon when you give certain amount of background pressure. That is called PEEP. So how do you create CPAP, continuous positive airway pressure? You know that you can take any machine, for example, bubble CPAP or a ventilator. The concept of creating a pressure, there is no pressure without flow, right? There has to be some flow to create pressure. So basically there is an inspiratory flow, there is a flow of air or flow of oxygen, and you set a resistance to the flow in the expiration. That's what creates the pressure. So how do you create that resistance? Either by exhalation valve, that's what happens in the classic ventilators, or by a water column, that's what happens in your bubble CPAP, which you will see in the afternoon, when you see the bubble CPAP machines which we use in smaller children, or a flow generator. Eventually, there are ventilators which create they don't use the valve, but they use, when you have a flow like this, and when you create another flow like this, so it impedes the flow and causes the pressure. That is another concept of how you create CPAP. And flow itself can create resistance on exhalation. This is what happens in HFNC. When you create very high flow across the nose, and when patient is trying to exhale against that, it creates CPAP, right? So these are the ways to create positive pressure at the end of expiration. So a lot of these you will see in the afternoon, the machines. Basically, this is what we grew up in 90s. We used to make it actually at the bedside. This is how, at least I grew up. I don't want to date myself, but this is what we used to use, the red rubber tube, and make CPAP machines. It's very easy to make. It is not expensive. Take 2 bottles. So basically, oxygen and air mixture, it goes through the humidifier. We never used to have humidifier, unfortunately, but anyway. So this goes across here. Because it goes through the air column here, the two are there because as a safety valve, because if this malfunctions, if this tube malfunctions, this is a safety valve, but you can create with one only actually. And when the patient exhales against this water column, this is how much CPAP is generated. So by putting more water, you are actually creating more resistance, so more pressure. So this is the older system, and now it is all which costs about 1 lakh or 1 lakh, 2 lakhs. So you have this system, but the concept is the same. So this is what we use in babies, nasal bubble CPAP. So you have air and oxygen here. It goes through the humidifier, right? And then the air and oxygen mixture goes through here. And baby, this is the cannula here, nasal cannula. And baby breathes out against the water column. And you can adjust this depth of the tube determines how much pressure CPAP is generated. It's a very simple system. Same thing here, it's shown here. And also the reason I put this picture also is to show it is important to do humidification. So not only here it is an active humidifier, but there is also in the circuit you can have a heated inspiratory circuit, right? So these are again, when you add all this, the machine becomes more expensive. So we start with a simple system where you can create it with probably 400 rupees, 500 rupees now at present cost, and to a machine which costs about 1.5, 2 lakhs. Now, so this is just to summarize how it works, right? This is for your, already Dr. Raghunath has spoken about it. This is how does high flow nasal cannula helps, right? That is CPAP. What I am talking now is about high flow nasal cannula. So one is high flow and another one is you have humidification. So basically it is not HFNC, it is HFNC. That is high flow humidified oxygen, nasal cannula. One is the humidification part. When you humidify air, when you humidify air which you are inhaling, so basically it gives comfort and also it prevents drying up of the secretions, mucus. So it improves, it avoids microatelectasis and improves your compliance and decreases the work of breathing. Sorry, I need this to explain. I don't know what is happening. Sorry, I have to wait because I have to show in that. I can't explain it. So when you have high flow across the nose, so basically when you are giving high flow nasal cannula across the nose, one is you have to understand what happens during inspiration and what happens during exhalation, right? So one is humidified air. We talked about what the humidified air does, and now we will talk about what this high flow does during inspiration and during exhalation. Yeah. So there is a high flow. So what happened during expiration? There is a high flow going across the nose, and the patient is exhaling. So as I told you, whenever there is a when there is a resistance to the flow, this high flow resists the flow from the patient. So that causes PEEP effect. So that causes the positive end expiratory pressure. And also when there is positive end expiratory pressure, it causes alveolar recruitment. The lungs expand. And also it washes out the dead space. During inspiration, what happens? Because there is flow already, rather than patient making a lot of effort to get the flow from the air, because there is already high flow here, he draws from that. So it helps in the inspiration. And that also helps in alveolar recruitment. So both of these will cause improvement in oxygenation and also CO2 removal because of dead space washout, and oxygenation improvement because of the PEEP, positive end expiratory pressure. So both of these will decrease the work of breathing. So the patient will feel much better. His respiratory rate will come down, and there will be decreased intercostal retractions. So those are the things you have to clinically watch when you put somebody on HFNC or NIV. Now, why HFNC over NIV? I mean, so HFNC is a new kid on the block. We had CPAP before. Why do we prefer HFNC over CPAP? I mean, not that everybody prefers HFNC over CPAP, but if you have a HFNC machine, why prefer that over CPAP? Is because the CPAP cannulas are very stiff, whereas HFNC cannulas are soft. CPAP cannula has to be stiff because otherwise it cannot provide the pressure, right? So it is reduced rates of nasal trauma, reduced infant pain scores because it is easily tolerable, and also nursing staff, and for the nursing staff it is easy to set up HFNC than your CPAP circuits. Remember, HFNC also produces CPAP. In CPAP machines, basically you set the CPAP number, 4, 6, 8, whatever. Whereas in HFNC, you don't set the pressure. You just increase the flow, half liter per kilo or 1 liter per kilo or up to 2 liters per kilo. So for a small child, like 3 kilo child, we can give up like 6 liters per minute. Whereas an adult, you can use up to 60 liters per minute, right? So when you do that, as I said, when you have that much flow across the nose, and if the patient is exhaling, so it creates a resistance and causes positive pressure inside the lungs, right? But you cannot measure it. But definitely it creates some amount of positive end expiratory pressure for the patient. But you cannot set it and you cannot measure it unless you do some research and put a catheter in the throat and measure it. So it is unpredictable. The pressure generated is unpredictable and it cannot be set. And it is also related to the flow, prong size, and also the patient size. So though it creates, HFNC creates some CPAP, we don't know how much it is, but it does create some. So it has all the other advantages of CPAP, right? Now coming to NIV, that is BiPAP, we have to know three things: patient, interface, and the machine. Patient we already talked about, the patients where you should be using it and patients where you should not be using it. Interface we'll talk about, and the ventilators also. So these are the different interfaces. See, basically you have either the nose and the mouth needs to be covered, or both should be covered, right? So you have full face mask here. You have nasal pillows, what we call as nasal pillows. Basically it goes here. You have just the nose mask, and in fact adult nose mask can actually be used for full face mask for the child. Small child, the adult nose mask can be used as a full face mask. So similarly here, and also the mouthpiece, which is rarely used actually. That means you are giving the positive pressure only through the mouth, which is not very useful. We'll come to that when we talk individually about this. So these are the different interfaces we have. And also CPAP helmet, I mean in India it is not much used, but in particularly in European countries and particularly in Italy, it is a rage, right? People use this helmet where you entirely cover the face with this, with a tight interface in the neck, and then create a positive pressure inside. So full face mask, oronasal mask, basically you are covering both the nose and the mouth. The advantages is there is no leakage from the mouth because you are covering both the nose and the mouth. It helps in acute settings because it gives a better fit. There is no leak. But the disadvantage is particularly in children, and adults sometimes you can train them. You can tell them if you feel like vomiting, please remove the mask and then do. But in children it's very difficult to train them to do it. So risk of aspiration if the patient is not able to remove the mask if there is a massive vomiting. And also claustrophobic. Children don't like it, particularly younger children may not like it. Even adults sometimes they feel very claustrophobic with that. Nasal mask, there is no claustrophobia. Risk of aspiration is less, but as soon as you have a nasal mask, as soon as you start talking or opening the mouth, the pressure is lost. So it cannot be used in a crying child. It's difficult, right? You have to be, you can use it in adults. Adults nasal pillows are quite useful. You can ask them to shut their mouth, adults, but we can't do that in children. So it's difficult. Mouthpieces, as I said, it's simple and inexpensive, but again, leak through the nose is very common and it is hardly used. I have not used it at all. Yeah. So approximately 20 to 30% of failure in NIV is because of wrong selection of interface. So it is very, very important to select the interface properly. Right? Now ventilators, we talked about the patient, we talked about the interface. Now the ventilators, there are two types of ventilators: conventional ventilators which you use for invasive ventilation, and there are specialized NIV ventilators, the BiPAP machines, so-called BiPAP machines. Right? So you can use one of these. Conventional ventilators you can use because it is the same concept, basically giving positive pressure during inspiration and expiration. It can be used, but the problem is, let us come to the advantages first. The advantages are you can set the FiO2 just like your invasive ventilator machine. You can set everything. You can set PEEP, you can set FiO2. So all of those and alarms are there. There is a backup ventilation in case the patient goes apneic. There is separate inspiratory and expiratory limb so that there is no rebreathing. So all of these are advantages, but the disadvantage is these conventional ventilators are not made to detect, not made to react to the leak, right? Because we are using these ventilators for somebody who is on an endotracheal tube or on a tracheostomy. So the leak is very minimal, and we also use cuff tube. so the leak can be minimized. So these ventilators are not made for leak compensation so much. So that is a problem, and also they are usually bulky, whereas BiPAP machines, you must have seen, it is like a box, you can use it. And they're expensive, of course. I mean, BiPAP machines may cost you 2 lakh, whereas these conventional ventilators cost anywhere up to 8 to 10 lakhs. So the freestanding non-invasive ventilators, so-called BiPAP machines, what we call as, which we use also for the ambulatory patients, I mean patients at home. The advantages are they're cheap, flexible, portable. They have a good trigger sensitivity, and they're actually made with an algorithm to detect leak and to respond to the leak. So they're made specifically for situations where there is a lot of leak. So obviously when you use NIV, there will be leak. However much tight-fitting interface you use, there will be always a leak. So they are specifically made for that. So that is advantageous. And also they have a limit of 20 centimeter of water. So you cannot go beyond that. So it is sort of a safety thing. Disadvantages is particularly if they need oxygen, which in most of the COVID patients there will be a lot of leakage. So the lot of wastage of oxygen can happen. And because oxygen is at these things we will show you in the machines actually, but the oxygen here in regular NIV machines goes at the mask only. So really you don't know how much FiO2 you are giving to the patient, right? You can only set 5 liters, 8 liters, 10 liters oxygen, but you don't know how much actually the FiO2 the patient is getting. And there are not alarms backup is very little, and it is due to single limb circuit we use, not the double limb, so there is chances of rebreathing. Of course, most of the modern ventilators are actually hybrid ventilators in the sense the machines which are coming up nowadays, they have NIV modes. For example, Mackay or whatever you use, they will have NIV mode. When you put it on NIV mode, they become sort of it compensates for the leak, so it becomes like a NIV ventilator. So the most important critical thing is you have selected the patient, you have selected an interface, you have selected a ventilator. Now how do you initiate it? The most important thing is educating the patient, particularly older. See, that is the reason NIV is unsuccessful in smaller children, because we can't tell them that this is coming up, You just decide, I want IPAP of 10 and EPAP of 6, and just put them on their face. They will definitely kick you, because it is like blowing air into their face without their consent, right? Whereas when you intubate and somebody put somebody on the ventilator, that is a different case scenario, because you have paralyzed them or you have sedated them, so you have more control. Whereas NIV, first thing is make them sit up. Older children, you explain to them that there will be a lot of forced air coming to your face. Even adults, you have to explain to them that this is what is going to happen. And then start with explain the procedure, silence the alarms, because it will start beeping, because there will be a lot of leak, because you are not going to put the mask tightly right away. You are going to bring it near to them. There will be a lot of leak, there will be alarms, so they will go crazy, you will go crazy. So better to explain to them. Apply the headgear. Don't put it too tightly. Just bring it to their face. Let them feel how it is. And start with the low pressure. Just start with just 4 of positive and expiratory pressure. Not even any IPAP. Just start with a PEEP. And then tell them that you're going to increase the pressure. So it will take about 20 to 30 minutes to actually come to your settings. So that is why NIV is more labor intensive. You need more personnel to start NIV than invasive ventilation. Invasive ventilation is easy. Sedate, paralyze, put the tube, put on whatever pressure you want, and then you can walk away. Whereas NIV, you have to be next to the patient, explain to them, and make sure they're comfortable. So it is definitely more labor intensive. You need more nurses, you need more doctors, and you yourself need to spend more time at the bedside to start NIV, right? So gradually increase the pressures and as tolerated. So, and of course, as I said, oxygen has to be connected separately into the mask in NIVs. So you do that. Add humidifier. Consider mild sedation. Generally, we try to avoid sedating a patient in NIV because your airway is not protected. But definitely, deep sedation is contraindicated. You should not give them heavy sedation or heavy analgesics, but a mild sedation is okay to make them less anxious is okay. You encourage them, tell them that this is what you are going to do, and believe me, if it relieves their hypoxemia, patients are definitely cooperative. We have seen this in children even 5-6 years of age. Once they know that it is helping them, they don't take the mask away. In fact, we have seen in children with neuromuscular disease, when we take out for feeding or drinking fluids, after 10 minutes they ask for it because they know it is helping. So, but to come to that situation where you have to make them realize that it helps. So that is very important, so you have to spend time initially. Blood gases I have written here, but it's not really necessary. Nowadays we go by oxygen saturation, so not too many blood gases are really not required. So how do you monitor them? One is a subjective response. As I said, as they feel better, they themselves will tell you that it is helping. And we have seen with many of the COVID adult patients, they actually ask for it, when it is helping. They don't fight it, they ask for it. Physiological response, drop in respiratory rate, these are the things which you should be watching for. These are the signs of success. Respiratory rate comes down, decreased accessory muscle use, paradoxical abdominal respiration will settle down, it will become normal breathing pattern, and heart rate falls. And how do you monitor them? Continuing, that is clinical monitoring. Gas exchange is monitored using continuous pulse oximetry, very rarely blood gases, not necessary really. It's very difficult to monitor the CO2, end-tidal CO2, because there is a lot of leak. But you can try to do it with end-tidal monitoring, but it may not be very accurate. Now when they are on the ventilator, basically you want to look at three things. One is their oxygenation is good, their CO2 removal is good, and also if the patient is synchronizing very well with the ventilator. These are the three things you have to watch, and this we will discuss more at the machine in the afternoon to how to readjust the settings depending on the patient. But just to show you, one is patient synchronizing with the ventilator. If the patient is not synchronizing the ventilator, it may be because your IE ratio may be abnormal. There may be abnormal trigger or inspiratory or expiratory trigger set that needs to be readjusted, or his PEEP, positive end expiratory pressure, may not be adequate. Is ventilation inadequate? How do you assess it? Basically see if the chest expansion is good. If the chest expansion is not good, you increase the inspiratory pressure. Consider increasing the inspiratory time to give more tidal volume, and also rate if you are on a timed mode. And consider a different mode of ventilation, like if they are already on the spontaneous mode, try to switch it to time mode. All these things we'll show you in the machine in the afternoon. And PaCO2 improves, but PaO2 remains low, saturations remain low, then it may be related to less positive end expiratory pressure. Try to increase when I say positive end expiratory pressure, in BiPAP settings we call it as expiratory pressure, and IPAP is inspiratory pressure. Okay. So what are the goals of NIV? Short term is relieve symptoms, reduce work of breathing, improve or stabilize gas exchange, to achieve good patient ventilator synchrony, minimize the risk of aspiration, that is very, very important, and also avoid intubation. Long term we will not talk about because we are here mainly for COVID. Long term, when I say, we do send the kids with, say, Duchenne's muscular dystrophy or other muscular dystrophy on home BiPAP, right? So those are the long term goals, not applicable to the COVID settings here. So what are the complications of NIV? Most of the time, 30 to 50% of the time, it is perceived discomfort from the patient. That is either because we have not actually prepared them well for what is coming. So the preparing the patient is the most important thing. Telling them that it is going to blow air into your face for a few minutes, but it will help. So the preparing the patient is very, very important. And maladjusted mask, so those things need to be readdressed. Facial skin erythema is a major problem because it does cause nasal bridge erosions. So it is important to prevent it, because we have seen very bad ones with this. So nowadays we use some cream plus some even the regular tegaderm to protect the skin. So all those things should be taken care, not only on the face, but mainly on the nasal bridge. Claustrophobia, it is a psychological thing. Again, got to explain to them. Then it will, most of the time it helps. Nasal bridge ulceration, rash because of maybe they are allergic to the material of the mask. That is one of the side effects. Nasal congestion is definitely a problem because we are not bypassing the patient airway. Most of the times we don't use humidifier for NIV, and it is not necessary actually. But still, when you blow air into the patient's face with so much of pressure, it can cause drying up of the secretions. So that can be addressed by using simple saline nasal drops. Sinus and ear pain for the same reason, because you are blowing so much of air through the eustachian tube, it can cause ear pain. Eye irritation for the same reason, a lot of blowing air through the face mask, it can leak and it can cause eye irritation. So all these are remediable with these things. Yeah. Gastric insufflation, because you are blowing air through the face and mouth and the nose, it does cause some gastric irritation. So some people used to put NG tube routinely for all of those who are on NIV. It is really not necessary, because most of the patients who are awake, they do burp it out by themselves if you make them sit up 30-45 degree angle. So really not necessary to put a NG tube routinely for all NIV patients, but you can put it if there is a lot of distension which you are not able to rectify. So aspiration pneumonia is a major risk. Fortunately, it happens in less than 5% of the patients. So whenever you put this full face mask on a patient, whether it is an adult or a pediatric, you have to make sure them, and you have to teach them how to remove the mask when there is a vomiting. Or at least if it is a smaller child, we always tell the mother, see, if the patient vomits, what to do, where to look for the strap, because nurses are not there all the time at the bedside. So you have to show them which strap to remove so that they don't choke on their own secretions. So either you tell the patient directly, or if it is a child, you teach the parents what to do in case of vomiting. Hypotension, because you are giving positive pressure, whether you are an invasive ventilation or non-invasive ventilation, when you give so much positive pressure, always it decreases the venous return and it causes decreased cardiac output. So hypotension is one of the complications of NIV. Same reason pneumothorax, it is not that pneumothorax happens only in patients who are ventilated invasively, it can happen in patients who are non-invasively ventilated. So what are the predictors of successful NIV? Obviously, you have to choose a patient who is not moribund, who may be sick, who may be very hypoxemic. He may be even hypoxemic to the extent of 70% saturations. They do respond, but they cannot be moribund. So it has to be a lower acuity of illness. Able to cooperate, as I said, they're very important. Otherwise you fail right away in the first step itself. If you don't explain to them, if they don't take their cooperation, it is bound to fail. And able to coordinate breathing with ventilator. That is why in a smaller child, sometimes we find problem with NIV. CPAP is okay. Plain CPAP we do in newborns also. But BiPAP, in a very small child, sometimes we find it very difficult, because also they are breathing very fast. And if the PCO2 is more than 50, sometimes it may fail, except in neuromuscular kids, where we use it because the CO2 is high. Sometimes, because neuromuscular kid, the problem is the ventilation. So when you give BiPAP, most of them settle down very well. But in a patient who has lung disease, when they have a CO2 of more than 50, generally they tend to fail. And acidemia, of course, less than 7.35 and more than 7.1. And the most important is what happens in the first 2 hours when you start it. That is, so generally don't press it too hard. If somebody is going to respond to NIV, they do it in the first hour. In fact, in the first 45 minutes, you know whether this patient is going to respond or not. So don't push too hard. In 2 hours, if they have not responded, it does not matter. You try for next 4 hours, 6 hours. You are only going to postpone, and you are going to only push the severity illness of more, and you end up intubating them emergently. So it is better to assess them in the first 2 hours. So that's why, as I said, NIV is more labor intensive. Particularly first 2 hours is very crucial, not only to initiate and to monitor, and you have to decide at the end of 2 hours you want to pursue it or you want to just intubate them. So adjuncts or humidification, as I said, it is not necessary because you are using the patient's own airway. They have their humidification system intact. But definitely if you add humidification, it does help them in the as far as the comfort is concerned. Oxygen, as I said, has to be plugged into the mask. It is not like you can measure how much FiO2 is. Bronchodilator therapy can be continued during NIV. Nasogastric tube is not routinely indicated. It is not necessary that every patient who is on NIV should be having an NG tube. And sedation, only small doses, not to an extent as in invasive ventilation. You don't want to push them into so much of unconsciousness, they cannot protect their airway. So you can, for relieving their anxiety, little bit of sedation is okay. So the most important take-home message, NIV should be used to avoid intubation but not replace it. Assess them at the end of 2 hours. If they are not tolerating, go ahead and intubate. Don't push it too hard. It is not the therapy for respiratory failure. It can be used to avoid intubation but not replacing it. I think NIV in neonates has been spoken to, I guess, but I'll just give this as one slide to explain. NIV in small newborns, neonates. NIV support can be divided into constant airway pressure and variable airway pressure. When I say variable airway pressure, NIV can be used just like your regular ventilator. You can use it NIPPV or even high frequency ventilation with NIV. And constant airway pressure is one is the nasal cannula, HFNC does the same thing. And the CPAP, the bubble CPAP machines you are going to see, or the CPAP machines, neopuffs, those things are constant flow and variable flow CPAP machines. I think this will be spoken by a neonatologist later. So to conclude, NIV is a promising mode of ventilation in all age groups. Most important is proper patient selection and proper mask selection. That's very, very important. You should know the indications and you should know where you should not use it. As I said, NIV is more labor intensive. So you have to have more personnel, you have to have more time to initiate the NIV. Because every time you take it off for 10 minutes for the patient to eat, when you come back, you have to again talk to the patient, you put them on. So it is definitely more labor intensive than your invasive ventilation. And as I said, NIV is used to avoid intubation but not replace it. So when the time comes, when you know that NIV is not working, you have to intubate and do invasive ventilation. Thank you very much.
ಓಕೆ, ಇದು ಪ್ರಾಬ್ಲಮ್ ಇದ್ದಿದ್ರೆ ಆಗುತ್ತೆ. ಓಕೆ, ಹಂಗೆ ಮಾಡ್ಕೊತೀರಾ? ಹಂಗೆ ಮಾಡಿಬಿಡಲ್ಲ ಅಂತ. ಹಂಗೆ ಓಪನ್ ಮಾಡಿ ಅಲ್ಲ ಅಲ್ಲಿ ಪೇಸ್ಟ್ ಮಾಡ್ಕೊತೀರಾ ಅಂದರೆ ಮಾಡ್ಕೊತೀರಾ? ಇಲ್ಲ, ಆಯಿತು. ಇದು ಹಾಕಬೇಕಾ? ಇಲ್ಲ ಇಲ್ಲ ಬೇಡ. ಇದಕ್ಕೆ ಯೂಸ್ ಮಾಡಬೇಕು ಸರ್. ಹಿಂಗೆ ಡೈರೆಕ್ಟ್ ಇದಕ್ಕೆ ಇದೆ ಅಲ್ಲ, ಅದಕ್ಕೆ ಆಗಿದೆ. ನೀವು ಅಲ್ಲಿ ಇದನ್ನು ಮಾಡಿ ಸ್ಕ್ರೋಲ್ ಮಾಡಬೇಕಂದ್ರೆ ನೆಕ್ಸ್ಟ್ ಸ್ಲೈಡ್. ಒಂದು ನಿಮಿಷ ನಾನು ಹೇಳ್ಬಿಡ್ತೀನಿ. Thank you, Girish sir, for your topic on non-invasive ventilation. Now we will move on to invasive ventilation. Dr. Harish Kumar, consultant intensivist, will be presenting you about invasive ventilation. He is from Aster CMI, Hubbard. Welcome you, sir.
Thank you, Dr. Panu. Thank you all for giving me this opportunity. So I have been asked to discuss on invasive ventilation. Invasive ventilation as such is a very technically, intense chapter. But I was not aware of the crowd, and I thought it is all the general specialties are going to be involved. So I've tried to keep it as less, technically as possible. But as time goes, we can discuss on what is needed. But this basic understanding is very much important while handling a patient on invasive ventilation. So ventilator is like it's a machine, and it's like a car. So for car to move, what is the most important part? It's the driver. Driver is the most important part of the car for it to move, right? So it's like that. No matter what ventilator and how the technology works, the person who is making that ventilator work is most important. So if that person is sound enough, you use a simple ventilator and you will be able to save a lot of lives. So a schematic representation of the ventilator circuit. This is the child and this is the ventilator, right? So from ventilator, air comes through the inspiratory limb. There is a Y connector which connects the inspiratory limb to the child, and then from child there is an expiratory limb goes to the ventilator. There is an expiratory valve and all those things. Those are the finer things. So this is the basic circuits. So settings are done here, how much of air has to go in, how much of pressure has to go in, at what time it has to go, and what kind of breath it has to give. All those things we decide over here, and child is intubated, right? This is the simplest way to say. And in COVID, what are the sequence of events in which patient worsens? Initially, there is an inflammatory marker rise, right? Right from CRP to all the other things. Inflammation increases. Then there is lung damage. This inflammation leads to lung damage, alveolar damage and all those things. Then low PaO2. If you are doing ABG, you will be able to see the low PaO2s. And then more evidently in saturation, which is commonly seen by not just doctors but also the layman. So you have to do the appropriate interventions in appropriate time. For example, when the inflammation is going up, you may have to go on steroids and all those medications, anti-inflammatory medications here. Whereas once the lung damage is set in, you may have to hike up the steroids. Steroid doses are again categorized. So those kind of things. But later, once it is going here, there is a respiratory failure which is setting in, and then you have to decide. The people before me have discussed about right from oxygen support to non-invasive ventilation. So you choose your respiratory support to support this respiratory failure, and the last option would be to go for invasive ventilation, right? So the early the better, actually, invasive ventilation. Early intubation preferred for patients with most of the ARDS before the whole of the lung gets collapsed, because COVID pneumonia is similar to ARDS, but it's not exactly like ARDS, because ARDS is more of fluid in the lung, but here that ground glass opacity and those non-homogeneous whatever whitening you see, those are all the lung opacities like ARDS, but in between that there is also thrombus formation in the pulmonary vasculature. So that will add up to the problem. So, but still the basic principles of invasive ventilation we derived from the ARDS only. Whatever principles we use in ARDS, that will more or less hold good for COVID ventilation. And video laryngoscope is ideal because here you have to have a distance while intubating, and because if you peep and see, you're going to be at more risk. So ideal is to have a video laryngoscope so that you can be away from the patient, visualize it better and intubate it better. And you have to give pre-medications like benzodiazepines are the most preferred. You can also give fentanyl, ketamine, all those things were discussed in the previous. And in case of difficult intubation, if you're confident of intubating but the child is very much non-cooperative, you can use muscular blockers like rocuronium is most preferred because it has a very short action and then patient comes back. In case by any chance if you have not succeeded in intubating, child will come back to normal whatever little breathing it was doing if you use rocuronium. Whereas other vecuronium, etracuriums and all have longer duration of action. So we prefer to use these muscular blockers on a patient who is on maintenance ventilation. So pre-oxygenation before intubation is very, very important. You oxygenate giving 100% oxygen for around 5 minutes depending on time permits. If it is a super emergency, you may have to abort this in 2 to 3 minutes and start intubating. But whatever you can do pre-oxygenation, please do it. That will reduce the risk of crashing hypoxic events during the intubation. And while intubating, cover the head with this transparent sheet. This is simple and most available everywhere. So we can use this simple plastic sheets to cover, make a little hole for your bag to be connected here, and then you can do. For bagging, you need to use this sheet. For intubation, you need to use this sheet, especially intubation when you don't have a video laryngoscope. For extubation, you have to use the sheet. While you are doing suctioning, when the child is on a ventilator, use the sheet. So these are 4 or 5 places where you use this sheet to safeguard yourself, because there is a high amount of aerosol during this time. But overall, if you look at the aerosol particles in non-invasive ventilation and invasive ventilation is very less compared to non-invasive ventilation, because there is a lot of spillage in the non-invasive ventilation, HFNC, oxygen therapy and all those things. So as far as possible, use cuffed tube, because these micro aspirations and all you can prevent, and you will be able to ventilate better. If at all this lungs become very bad and the compliance of the lung is very, very poor, then you may have to use high pressure. So to use high pressure, if you have a cuff tube, you will be able to transfer that pressure from the ventilator to the patient. If the tube is not cuffed, then there is a significant leak which will have, creating challenges for you to give that amount of pressure while ventilating. Always prefer to use a closed suction, inline suctioning. Suctioning, there is a tube. I have another picture to show. Here also, I think you can see here. So there is the suction tube is in sync, covered through this thing, and I think people in ICU must have used already. So this is the video laryngoscope, and then intubating with the plastic sheet around. So use a lung protective strategy for mechanical ventilation as far as possible, because the disease itself is already damaging the lung. If our act of ventilation further worsens the lung damage, then we may land up in a problem later after ventilation, because there are so many of adults already who have gone to lung transplants and all those things, because they have gone for during the process of illness and the management, they have gone to a irreversible lung damage and they had to go for lung transplant. Lung transplant cannot happen from a live donor. It has to be a cadaveric donor only. And so getting a cadaveric lung donor for an adult is much more easier than for a child. So you have to preserve the lung while treating the lung. So that is lung protective ventilation. I will tell those things, a couple of things later. Permissive hypercapnia. Though the ideal PCO2 is around 40, 5 here and there. But then while ventilating, if you are giving a lot of pressure, you somehow start accepting a little higher PCO2 and a lower PO2. That is called permissive hypoxia and permissive hypercapnia. So you permit a little more margin for the carbon dioxide as well as little less margin for oxygen and then accept it rather than having ideal numbers and giving undue pressure to the lung. We prefer to use viral filters because there is a lot of viral load coming out. So viral filters will protect the aerosol transmission from the patient to the surroundings. So these are some of the ventilator settings. This is again derived from ARDS. Lung protective is what? Use the tidal volume. Usually the standard tidal volume is 6 to 8 ml per kg. But if the lung is very bad, we go even further down to 4 to 6 ml per kg. This is the tidal volume, 4 to 6 ml per kg. Plateau pressure should be less than 28 centimeters of water. Plateau pressure somewhere goes to that upper point, what Dr. Girish was showing you, the upper inflation point, after which there is no major benefit. So you try not to overshoot that. Plateau pressure should be kept below 28. PEEP is between 7 to 10 in a bad lung, but it starts from 5. Usually upper limit is around 15. Once you have reached around 15 of PEEP, then you're done. We try not to go, usually it's a very, very rare chance that we have gone PEEP above 15. And FiO2 is the best FiO2 to be given is below 0.6, that is 60% on the ventilator. And avoid fluid overload because lung is already bad. If you give more fluid, unduly more fluid, then that fluid is going to accumulate in the lung, and this is going to create problem later. As such, remember that any sick patient, there is a high drive of ADH. ADH is secreted more because of the stress of the disease and stress of the whole treatment. Even the positive pressure ventilation that we give creates a stress on the system. It stimulates the ADH secretion. Because of ADH secretion, there is a lot of retaining of water in a sick child. So whatever Holiday-Segar formula we use, 4 ml per kg per hour, that doesn't fit well for a sick child because sick child is conserving more fluid. So we are more comfortable giving half of it or 2/3 of that fluid all the time. And these children do well because they have that high ADH drive. So avoid fluid overload. Sedation, analgesia has to be used like benzodiazepines and all those things. Enteral feeding has to be started. It's very important to start enteral feeding on a ventilated child. On a non-invasive ventilation, you are still worried about the aspiration. But once you have intubated, the worry of aspiration is very less. But then child is very sick, you have to give the feeding. Feeding is very, very important. Even if the patient is on ventilator, sleep and food is needed for recovery. So make sure, because once the child is on ventilator, we are very insensitive about these things. We on ventilator try to give melatonin at times if the child is fighting in the night and switch off the lights on top of that bed so that child can rest well. Because you must have seen some articles in the WhatsApp and all that. Melatonin is an antioxidant. Melatonin hormone which is secreted in the night is an antioxidant. It has anti-inflammatory effect. So a child which sleeps well on the ventilator is going to recover well. A child who is going to be fed well on the ventilator is going to recover well. So transfusion may be needed. Any sick child, any child who is on respiratory support, ventilatory support, the ideal hemoglobin is to be maintained above 10. So, but then 7 to 10 is a gray area where you take your individual decisions, whether you want to give or you want to wait on that. For example, 8.99 and all, it is left to you depending on the situation. But then below 7 is not acceptable. Any hemoglobin below 7, please give off a packed cell transfusion. Early invasive ventilation may be needed many a times rather than pulling it to the last end. Intubation should not be done when the child is almost crashing and arresting. Then you will have very poor outcomes. Avoid HFNC and you can avoid HFNC and NIV unnecessarily, dragging for longer time. If at all, as Dr. Girish said, you will know whether NIV is working, HFNC is working in the first 1 to maximum 2 hours of time. And if things are not settling down at that stage, you have to go for invasive ventilation. Avoid nebulizations. Avoid nebulization in a generally nebulization produces a lot of aerosol. We avoid nebulization even in the right from the OPD care and all. But then on ventilator also, nebulizations have to be avoided. These are some of the parts of the ventilator which patient side. This is the HME. HME is more used in adults, like adult people have, but children we try to, as the child is smaller and smaller, we use those proper humidifiers. We prefer to use those things rather than this HME. So this is an adapter, inline suctioning. There is a suction port here. So ventilation will be going on, and then you can open this port and then do the suctioning from the lung. So this will not create aerosol, and it will also not add up to the infection to the patient. We are not giving infection to the patient while suctioning, and patient is not giving aerosol outside. So exhalation tube, Y connector, all that which I showed in the diagram. This is the HME filter. And HME filter has to be changed once in every 24 hours, because lot of moisture, right? It is like our, we are using this face mask. You know, after a lot of moisture, how it feels. So that is how HME filters are going to be. They're going to block and create a lot of resistance. So you have to change it every 24 hourly. So indication for ventilation, these are very, simple indications. The list is more than this actually. Absolute indication is apnea. If the patient is not at all breathing, there is no way you have to intubate only. Shock, patient in shock. Multi-organ failure, if there is a multi-organ failure, and especially in those multi-organs, respiratory and cardiac is involved, then you tend to intubate. Loss of protective reflexes, in case of encephalopathy, comatose child, where you are not sure, as Dr. Girish was saying, if there is a lot of pent-up secretions, that means the not able to maintain the airway, then you will have to intubate. Inability to oxygenate appropriately. Oxygenate means oxygen level maintaining is oxygenation. Inability to ventilate appropriately. Ventilate means drive out the carbon dioxide. So driving out of carbon dioxide is not happening. That means carbon dioxide is increasing in the blood in your ABG, and oxygenation is also inappropriate. In these circumstances, you will have to intubate. So when you are connecting to the patient, what do? First you select the mode on the ventilator. So either it is a controlled mode or mixed up. So CMV is a controlled mandatory ventilation, which can be volume controlled or pressure controlled. And there is a SIMV, IMV, SIMV. These are all mixed. Means in CMV, everything is done by the ventilator. Patient doesn't do anything. He doesn't start breathing. He doesn't decide how much to breathe. He doesn't end the breath. CMV is fully controlled by the ventilator. If there is a patient who is fully knocked off, then you will have to put on a CMV. But we prefer to use most of the time SIMV and with pressure support or something like that, because here it can give a set number of breaths. What we set, for example, it is according to the physiology of the patient. That number of breath and that number of pressure can be given in SIMV, but in between, if the patient is trying to take some breath, that can also be supported. So both, it is like a dual. So we prefer to use SIMV, because SIMV can also be used as a weaning modulator. You can reduce your settings and you can allow the patient to improve his respiration. So SIMV right from beginning to later, we are very comfortable with that. And more sophisticated than SIMV is PRVC, pressure regulated volume control mode, and pressure supports. All these are the common modes that we use. There are many more, but I have kept it only this much. If you can ventilate with any of these primary one or two of the modes, that's more than enough. Flow rates have to be adjusted. Generally, flow rates in an invasive ventilation is lesser than in non-invasive ventilation. Usually it is 10 liters or something like that. Alarms have to be set for every parameters like pressure, flow. There is a set alarm, pressure alarm, volume alarm. If the volume goes beyond that, then there will be alarm. Or if the pressure is going beyond that, then there is an alarm. So that change in pressure, change in volume depends on the change in the compliance of the lung. For example, if the lung is becoming very stiff, the pressure will go up, and then you will get the alarm. So whenever there is an alarm, what we need to do is we have to not only silence the alarm, but understand why that alarm has happened. Because many times these nurses are reflex to go and just silence it off. That is not the whole intention. You have to know why that alarm was beeping and then do the appropriate correction. So that is the most important thing. It will reduce our, this thing, monitoring stress. Otherwise, we have to keep on looking at how much can you look at apnea, because apnea alarm will tell you if there is apnea. Significant apnea is about 20 seconds. So basic ventilator settings, when we put the patient on ventilator, first start on FiO2. FiO2 preferably, we start from 100 and then gradually bring it down. And the best comfortable FiO2, as I told you, is less than 0.6, that is 60%. Tidal volume 4 to 6 or about 6 to 8 ml per kg. Never go beyond 10 ml per kg. More than 10 ml per kg, you are causing lung injury. Frequency or respiratory rate is according to the rate, physiological rate of that child at that age. Okay. Upper pressure, lower pressure, that is PIP and PEEP. So that has been spoken. Inspiratory time and expiratory time has to be decided. That is, and the ratio of IE ratio has to be managed. IE ratio is usually 1:2. So usually I kept on telling these things, physiological respiratory rate, and usually when we intubate, we keep around 2/3 of the pre-intubation rate. If the patient was breathing at around 50, so we may keep the respiratory rate on the ventilator around 2/3 of it. And higher rates in cases of bad ARDS. So keep the PEEP 5 and then gradually go up. But before intubating, if you already have the feel of the lung, that lung is very bad in terms of CT scan and in terms of bagging, your resistance was very high, then you can straight away go at 7 or 8 PEEP and then go up or go down depending on your assessment. Then but problem with keeping high PEEP is when your PEEP is very high, the venous return will be obstructed because you are always putting a constant pressure. The pressure in the lungs, thorax can go up and then go down. When it goes down, it has to go down to the baseline as much as possible, because when it is going down, the pressure here going down will allow the venous return to come to the heart. If you give undue PEEP, then you are impairing the blood flow to the heart. So start the FiO2 at higher and then titrate it. So strategies to increase the oxygenation. If the oxygenation is not happening, you have put on the ventilator and still the saturation is not picking up from 70, it has gone up to 76, 78, not beyond that, it's not becoming 88, 90. We intend to have a SpO2 of more than 90%. Usually less than 90% is what needs oxygen support. The ideal PALS guidelines says more than 94%, that is the ideal, but anything less than 90% you have to do some intervention right from oxygen or something. So we intend to have oxygen SpO2 levels of more than 90. In case if it is not picking up, what all we can do, increase the FiO2. You give the oxygen more so that oxygen is picked up in the blood. But then I told you more than 60% of oxygen when we give, it causes oxygen toxicity. Oxygen is a drug. Oxygen is a medicine. It cannot be overdosed. So give inspiratory pressure can be increased, and you can increase the lower pressure, that PEP, but the side effect of increasing PEP is may increase the PCO2. If you increase the PIP, it can decrease the PCO2. Okay, and increase the inspiratory time. But inspiratory time we usually do it at last. That's not the first preferred change. And what if the PCO2 has to be lowered? PCO2 is still at around 58, 60, 65, something like that. I said permissive hypercapnia, that is up to around 55, we are very comfortable. If it is going above 60, 62 and something like that, we have to bring the PCO2 down. So there what do? You increase the frequency. The more breaths, the more PCO2 wash out, right? Then otherwise increase the upper pressure, what you see in the above. You increase the upper pressure, the tidal volume increases. The upper pressure is going high up. So the scope for washing out the PCO2 increases. Or lower the PEEP if there is a scope for you to do so, depending on the compliance of your lung. So ventilator delivers the gas at a set rate. We set a rate and ventilator gives the air at that rate, but then it limits by the pressure or volume depending on what you have set, and it is cycles by time, volume, pressure or flow. What it means, I'll show you here. This is a schematic representation of a respiratory cycle. This is the PEEP, this is the baseline PEEP. It doesn't come to 0, it is around 5, 6, whatever it is. Then this is the inspiration. Inspiration is happening, and there is a plateau, there is a pressure support, pressure control mode. So this is how it is, and then this is cycle. This is the limit. After this limit, the pressure doesn't go high. This is called limit. This is the initiation, this is the limit, and then it is cycled. Cycle means what? It changes from inspiration to expiration. That is called cycle. So this is the point of cycling to expiration. So this whole thing is inspiratory time, that is Ti, the inspiratory time, and once it is going into expiration, this is expiratory time. So expiratory time is usually longer than the inspiratory time. Here you see it is 0.35 and 0.65. Usually it is this 1 is to 1.5 or 1 is to 2. That should be the usually IE ratio. So this completes inspiration and expiration all together, completes one respiratory cycle. So there is a trigger to start the breath. Usually in controlled mode of ventilation, the ventilator will start without any trigger. It just starts. This is the time to give and it gives, that's all. But whereas in those where patient can trigger in SIMV mode and all, what happens? There is a trigger at a particular. So here, when the patient breathes in, when the patient breathes in, it's going to sense that he has started breathing. So ventilator will match ventilator's breath along with the patient's breath. So there is no fighting. If the patient breathes at a different frequency and ventilator gives the breath at different frequency, there will be a tug-off between patient and the ventilator. So that is going to affect the lung in future, because lung damage is high if there is a problem there. So that is why we have to match the patient's breath with the ventilator breath, and that happens in SIMV. So there is a trigger. Trigger can be pressure or flow. Whenever the patient is breathing in, the pressure drops in. He is pulling the air, right, when he starts, and a little drop in the pressure will be picked up by the ventilator, and then it will start giving the inspiration. So this becomes the inspiration, and then this is the expiration, the same one which I showed in the last picture. So here again, this is the trigger, this is the limit. Limit is by pressure or volume. Here it is pressure, and then cycling. This is the cycle point, IE cycle, inspiration and expiratory cycle. And it will not come back to baseline. Usually it remains at PEP. So some alveoli will always be open. Don't collapse the alveoli of the lung completely. Then you will have to restart the opening of the alveoli. As such, physiologically, our alveoli do not fully collapse. There is a residual volume, right? So like that. So PEEP is needed to keep that residual volume of air in the lung. So I did this. The machine is controlled breath and patient is assisted. I'll pass on. This also I have covered. This is the inspiratory trigger. Flow trigger is better than the pressure trigger, because when it is flow trigger, when the patient when the ventilator is sensing the flow of the air, when the patient breathes, the ventilator senses the flow, then the patient has to breathe very less. The effort of the patient to trigger the machine is less in case of flow trigger. In pressure trigger, little more effort is needed by the patient to trigger the machine. So basic modes of ventilation we have been talking. So control mode, whether it is pressure controlled, volume controlled, intermittent mandatory ventilation, we don't use now in IMV. We use synchronized intermittent mandatory ventilation because it is synchronized with the patient. Assist control modes are there. Pressure support. What we do is, with this synchronized intermittent mandatory ventilation, we add the pressure support to this. And then there are some high-end hybrid modes or combined modes like PRVC, VAPS, that is volume assured pressure support, auto mode, and ATC, automated tube compliance. So compensation. So these are used very less. We don't use this. I have never used these last two, but then these we have been using. But this is more than enough. SIMV and pressure support can be enough too, because during management of pandemic, we have to keep everything as simple as possible. Then only we'll be able to do it at a larger scale and help many of the patients. So putting on the ventilator is not everything. You have to take care of the patient on the ventilator. What are the things to be done? Give adequate analgesia and sedation. So the patient is on a tube in the throat. We cannot imagine if I am fully conscious and a tube in my throat, how can I be comfortable? My stress is automatically going to be high. So to reduce the pressure, and this is a child, small child, so you have to give them adequate sedation and analgesia. Neuromuscular blockers you should avoid giving unless you cannot manage without that. But sedation, you have to be proactive in giving sedation, but be very much conservative when it comes to neuromuscular blockage. Nutrition is very, very important. Give the feed to the patient immediately after you have put the patient on the ventilator. Usually if the total calorie requirement is 100 calories are required, up to 50 you can comfortably give. Avoid giving the full calories also. They have seen that if you give total 100% of the calorie requirement, the outcomes are not very good. 2/3 of the calorie requirement, because a sick patient usually utilizes less amount of calories. Though the nutrient requirement may be more in case of burns and these exceptional cases, but generally the nutrient requirement comes down. So if you are stressing the metabolic, when you give more, you are activating the metabolic pathways. So your oxygen requirement goes up, your cardiac requirement goes up, cardiac output requirement. So to not increase it to an abnormal level, you keep nutrition to 50 to 60 or 70% of the requirement of that patient. As Dr. Girish said, humidification is not mandatory in NIV because we have this humidifier, the natural humidifier, our nasal and sinuses and all those things. But here, because we are bypassing our natural humidifier is a must when you do invasive ventilation. Physiotherapy has to be done. Many patients, because they are always in one position, you have to change the position, put pillow, move them to the left side, right side, all those things, so that there is no stasis of the lung content. Otherwise, hypostatic pneumonias are very common. Physiotherapy is very important, and tracheal suctioning, inline suctioning I discussed. So sedation wise, midazolam, fentanyl are usually preferred, and paralyzing agent, vecuronium and atracurium. So feeding, as I told you, as soon as ET tube is put, in NIV you don't have to put a NG tube, but when you put an ET tube and ventilate, you have to put a NG tube. Once NG tube is in, you can start the feeds. Sometimes you may have to avoid starting feeds immediately, like if there is some GI abnormality or NEC in this thing, or enteritis in bigger patient, or if there is shock, or if the child is needing a high inotrope, especially noradrenaline and all. There the gut perfusion is very less because of noradrenaline causes splanchnic vasoconstriction, so you should avoid giving aggressive feeds there. Still, at moderate to low to moderate inotropes, we prefer to give trophic feeds at least 20% of the total calories. Keeping at zero, it's very dangerous. So you have to prevent. One of the most important problem why we want to avoid intubation is because infection. That's why you have to use head end elevation, all this prevention of ventilator associated pneumonia. Keep the oral hygiene, keep the head up, and all those things. So suctioning has to be in line, and I said we will avoid giving nebulization. So in place of nebulization, you can use a inhaler. You can give inhalers even on a patient who is ventilated. On the inspiratory limb, this spacer and an inhaler port can be connected. This is available, so you can give inhalers. In those patients who have acquired COVID and there is a pre-existing asthma, there you have to relieve the wheeze, right? So that's why you can use these things. So cuff pressure, if it is a cuffed tube, every 4 to 6 hourly, make sure the nurse is deflating the tube, because constant cuff pressure will lead to tracheal erosion and subsequently tracheal stenosis. You may extubate the child, but patient will have stridor and then difficulty in breathing. So tracheal stenosis is very difficult to handle later. Tracheal reconstruction, hardly 1 or 2 centers in Bangalore are doing today, as of now, pediatric tracheal reconstruction. So very difficult if you land up with a tracheal stenosis. That's why avoid to have tracheal stenosis. That's why you keep the pressure, cuff pressure, even if when it is inflated, you can measure the cuff pressure to less than 20. Why less than 20? 20 mm is the pressure that is in the trachea, actually lining of the trachea. So prone ventilation, when you are not able to successfully ventilate in a normal supine, I think I am at the climax of the presentation. When you are not able to ventilate and requiring very high pressure, you try to prone the patient, because even in an awake patient we have advised them to prone, right? Why? The reason is, if you draw a line in the middle here, 40% of the lung is anterior to that line and 60% of the lung is behind, because the posterior recesses are very big. And if at all somebody is lying down always like this, he is going to accumulate a lot of fluid and other things. So air will not be going in the majority part of the lung. So once you turn him prone, then you will see that his oxygenation will immediately pick up with the same existing pressure. So this is one of our patient whom we were doing prone ventilation. So all what you do, you should have a cat-like observation and timely step up. In case if something is not working, you will have to step up. That is very important when you are doing this invasive ventilation. One slide on HFOV and ECMO. High frequency oscillator ventilation may be required. What are the criteria? If there is no clinical improvement with your all ventilatory strategies with high pressures, high settings, FiO2 requirement is above 0.6, you are almost at 90-100 FiO2 giving high pressures, patient is not improving. And mean airway pressure is more than 15 centimeters of water. Then you have to consider giving HFOV, and if you are able to calculate oxygenation index above 13 in 2 consecutive ABGs, 6 hours apart. How to calculate the oxygenation index is there below this thing. Same oxygenation index is used as a parameter to decide on ECMO also. Mortality risk more than 50 or oxygenation index more than 20. You have to consider giving ECMO, whereas if it is mortality risk is, sorry, this is a misprint, it more than 80. Mortality risk is more than 80 and oxygen index is more than 40. Higher the oxygenation index, bad is the prognosis. Then you have to definitely think of putting on ECMO if possible. So ECMO is nothing but, in ventilation, ventilator will take away only the lungs work. Heart has to do its job. In ECMO, it takes away both heart and lungs work. So it is a heart-lung machine actually. So, but there the brain has to be intact, and these lung damage, heart damage, whatever has happened, has to be a reversible cause. It should be potentially reversible. All we need to remember here is ventilator is a support. It is not a primary therapy. So all we are doing with all this ventilator is just supporting the system till the natural immunity and the medications do its job. So don't expect ventilator to cure. So though we have done all this ventilator, it is like takeoff. Putting on a ventilator is like takeoff of a air flight, right? And then this is the landing. If you ask a pilot which is going to be more difficult, landing is actually more difficult, right? So extubating from the ventilator is more challenging for us also in the same way. So for extubation, last thing is I'll tell the extubation criteria and close it. Extubation criteria, 3 systems have to be recovering or recovered. Neurologically, child should be active, conscious, should be able to maintain the airway. Second one is cardiovascular stability should be there. There should be pulmonary recovery. And the most important is the reason why you have put on the ventilator should recover. You have intubated because of lung reasons, then lung should be recovering. That is the most important thing. So other things are lung has to be clear, respiratory strength has to be there, and then there should not be edema. Maintain negative balance. If you have filled the fluid, if you have ventilated for 3 to 4 days, and then every day there is a cumulative balance, positive balance of 300, 400 ml in the system, then there will be a lot of edema. Edema not only in the lungs, also the chest wall. Then you will not be able to extubate. Extubation failure is very, very high. And you should avoid muscle paralysis because they will go for critical care myopathy and all. So while extubating, there should not be any inotrope, or it should be a minimal inotrope. And at last, try to give Dexona, especially if you have ventilated for more than 2-3 days. Dexona 0.15 milligram per kg at least 12 hours before, because to avoid the tracheal edema, because it is going to trouble you after extubation. So minimal settings have to be there while extubating, and after extubation also try to use inhaler as much as possible, because nebulization is going to be aerosol risk. But then adrenaline you may have to nebulize. While giving adrenaline nebulization after extubation, just put the sheet on that. And sometimes extubation may not be possible. Extubation failure rate reasonably throughout the world is 10 to 15%. 10 to 15% of your patients may go for extubation failure. And then you have to consider tracheostomy, ideally after 2 weeks, but start considering tracheostomy if somebody is on ventilator right after 1 week. And then on tracheostomy, you may have to also put on home ventilation and send them home. There are patients whom we have sent. Thank you.
Any questions are there? Sir, one second, sir. There is a question in online. They are asking where to connect the HMA filter. Connecting.
Between the Y and the ET tube.
Okay.
And there will be an adapter there. Sometimes there will be an adapter. After the Y.
Okay, sir. That was an online question. Thank you, sir. Thank you very much, sir. And now we will break 15 minutes for coffee and snacks. Please come within 15 minutes. We have 3 more sessions to go. We'll finish as early as possible.
ನಿಮ್ಯಾನ್ಸ್ ಅಲ್ಲಿ ಒಂದು 10 ನಿಮಿಷ ಇಲ್ಲೇ ಬರ್ಬೋದು ಅಂತ ಹೇಳಿದ್ ನಿಮಗೆ. ಇಲ್ಲೇ ಇರ್ತೀನಿ ಸರಿ. ಇಲ್ಲ ಸಾಕಷ್ಟು ಇಲ್ಲೇ ಆಗುತ್ತೆ ಸರಿ ಕೇಳಿಸ್ಕೊಳ್ಳೋದು. ಬರ್ತೀವಿ ಅಂದ್ರೆ ಬಾಯಿಗೆ ಬರ್ತೀನಿ ಅದೇ ನೋಡ್ತಾ ಇದ್ದೆ ಇಷ್ಟು ಬರ್ಬೇಕಿತ್ತಲ್ಲ ಬಂದಷ್ಟು ಮುಂದೆ ಹೋಗ್ತಿತ್ತು ಆಕ್ಚುಲಿ. ಬಾ ನೋಡೋಣ ಬಂದು ಫೋನ್ ಮಾಡೋಷ್ಟು ಇದು ಮಾಡ್ಕೊಳ್ತೀನಿ. ಇಷ್ಟೊಂದು ಬಂದ್ರೆ ಮುಗಿಸ್ಕೊಂಡು ವಾಪಸ್ಸೇ ಬಿಡ್ಬೇಕು. ನಿಮ್ಯಾನ್ಸ್ ಕನ್ವೆನ್ಷನ್ ಸೆಂಟರ್ ನಿಮ್ಯಾನ್ಸ್ ಆಡಿಟೋರಿಯಂ ಇದೆಯಲ್ಲಪ್ಪ ಅಲ್ಲಿ ಒಳಗಡೆ ಬಂದಾಗ ಅಕಸ್ಮಾತ್ ಬಿಸಿ ಇದ್ರೆ ಸ್ವಲ್ಪ ವೇಟ್ ಮಾಡಿ ಮಾಡೋದು. else was there? What else was there? Any conjunctivitis? We suspect MIS administration. Okay. Next program, next one. ಸೂಪರ್ ಹೆಂಗಿದ್ದೀರಾ ಎಲ್ಲಿ ವಿನಯ್ ನೋಡಬೇಕು ಅಷ್ಟೇ ಕಷ್ಟ
ಸ್ನೇಹಿತರು ನಿನ್ನೆ ಒಂದು ಫೋಟೋ ಹಾಕಿದ್ರೆ ನಿಮ್ಗೆ ಹಾಕ್ಬಿಟ್ಟು ನಿನ್ನೆ ಹಾಕಿದ್ದೀವಿ
ನೋಡಿದೆ
ಆ ಫೋಟೋದಿರೋರ್ಗೆ ಎಲ್ಲರಿಗೂ ಎಕ್ಸ್ಪ್ಲೇನ್ ಮಾಡ್ರಿ ಅದೇ ಹೊಟ್ಟೆ ಅಲ್ವಾ ಅದ್ಯಾ ಇವರು ಬನಾಪುರ್ ಮತ್ತು ಮ್ಯಾನ್ ಹೌಸ್ ಸ್ಮೈಲಿಂಗ್ ಹೌಸ್ ಎಂದಿದೆ ಯಾರೋ ಹಿಂದ್ಗಡೆ ಅಡಿಷನಲ್ ಡೈರೆಕ್ಷನ್ ನಮಗೆ ಇಷ್ಟ ಇಲ್ಲ ಅವ್ರನ್ನೇ ಹೇಳ್ತಾರ ಆಯ್ತಾ
ಸ್ಟೋರಿ
ಆಟ
ಮತ್ತೆ ಎಲ್ಲಿದ್ರೆ ಈಗ ಅಲ್ಲೇನಾ ಸೂಪರಪ್ಪ ಹೂವಾಗಿಲ್ವಲ್ಲ ಹೋಗಿಲ್ಲಲ್ಲ ಈ ಮೆಟ್ಕೊಂಡು ಕೇಳ್ಬೇಕ್ರೆ ಕೊಡಗಿಗೆ ಹೋಗಿ ಬಂದ್ರಿ ಹೆಂಗ್ ನಡೀತಿದೆ ಸದ್ಯಕ್ಕೆಲ್ಲ
ಮೇಡಮ್ ಫೈನಲ್ ಫ್ಲೂಯಿಡ್ ಮ್ಯಾನೇಜ್ಮೆಂಟ್
ಏನ್ ಚಿಕ್ಕ ಹುಡುಗಿ ಎಕ್ಸಾಕ್ಟ್ಲಿ ಪ್ರಶಾಂತ್ ಇದ್ರೆ ನೀವು ಇದ್ದಾಗ ಅಲ್ಲಿದ್ದಕ್ಕೆ ಇದ್ರೆ ನೀವು
ಅಲ್ಲೆಲ್ಲ ಆ ಮನುಷ್ಯ ಬರೋ ಅಷ್ಟೊತ್ತಿಗೆ ಆ ಮನುಷ್ಯರು ನಾವು
ರೈಟಲ್ಲಿ ಅಂದ್ರೆ ಸಿಕ್ಸ್ಗೆ ಬಂದು ಮತ್ತೆ ಅಲ್ಲಿಗೆ ಮತ್ತೆ
ಯು ವಾಂಟ್ ದಿಸ್ ಮೇಡಮ್ ದಿಸ್ ಒನ್ ಇದು ಪೆನ್ ಎರಡು ಇದೆಯಾ ಯು ಹ್ಯಾವ್ ಟೂ ಇದೆಯಲ್ಲ
Yeah, ಇದು correct. This version is correct.
In 2 minutes ಮೇಡಮ್ ಐ ವಿಲ್ ಕಾಲ್ ಯು ಪ್ಲೀಸ್ ಬಿ ಸಿಟ್ ಲೆಟ್ ದೆಮ್ ಕಮ್ ಎಲ್ಲ ಕಾಫಿ ಟೀಗೆ ಹೋಗಿದ್ರು ಒಂದು ರೌಂಡು ಎಲ್ಲರನ್ನ ಇಲ್ಲಿ ಕಾಲ್
So one photo take it. Thank you. It's okay, it's okay. ಇದು ನಡೀತಾನೆ ಇರುತ್ತೆ. Thank you so much.
Welcome back. We'll continue with scientific session. Now the next topic is fluid management and shock in COVID children. As we know, fluid management is very, very important in children. We should not overload or underload. So we have to maintain a balance in that. Madam Dr. Supraja Chandrasekhar will be presenting. She is pediatric intensivist in Columbia Asia Hospital, Bangalore. I welcome you, madam. Please take over the class.
Thank you so much for the opportunity. Good morning, everybody. I've kept this talk very basic because it is the basics only which matter when it comes to children, especially in the first hour. So let's have an overview. We're going to discuss what is the relevance of fluid management in COVID children, what fluid to use, how much, why, when, recognition of shock, and once we recognize the shock, what is the basic management we need to do? Because as you know, Dr. Karunakaran will be speaking about MIS-C, and MIS-C is all about shock and how we strike the balance right. Okay, so when it comes to COVID, we always think of respiratory, we think of oxygen, we think of saturation, all our patients will tell us that. But in children, there's a lot to do with circulation. So in acute COVID, as we all know, how did they present to us this second wave? What was the commonest presentation? Exactly, diarrhea and vomiting. So that had borderline dehydration and fever. How many of us have seen prolonged fever this COVID? Isn't it the adolescents? And we just give some saline and then they get better. So yes, there's a lot to do with circulation in the second wave in children. And we also saw a small group of children with acute COVID and myocarditis. So we need to recognize cardiac failure. We need to recognize that. Now, post-COVID, as we all know, is MIS-C, and in MIS-C, we have two distinct type of shocks, which we will talk about. So let's start off with a case. We have a 1.5-year-old child with history of fever for 5 days, high-grade runny nose, and also having abdominal pain. The child started to have profuse loose stools 3 days prior to presentation, vomited about 4 times on the day before presentation. By the time he came to us, child was drowsy since morning, refusing feeds, mother was not able to take care, father was in ICU, admitted for COVID. And the local GP had started antibiotics as usual. Now, when we examined the child had a heart rate of 157, sunken eyes, sunken fontanelle, drowsy, blood pressure was 72/56, cold peripheries and low volume pulses. The rapid antigen for this child is positive. This is how the child looked. So, what do we do next? Let's just focus on the fluid management. My question to you is, does this child have shock or does this child have dehydration? And we need to differentiate the two. So whoever says dehydration, please raise your hands. It doesn't matter in anything. Okay? And the reasons we say dehydration is because of sunken eyes, sunken fontanelle, and the child having loose stools and vomiting, correct? Now, who are the rest of the people who say shock? You can only say dehydration or shock, no other option. Okay, so very few people are saying shock, more number of people are saying dehydration. So I think it took me more than MBBS and then after that MRCPCH, and still I did not know the difference between dehydration and shock. So we need to get that very, very clear. So in shock, what happens? Where is the fluid getting lost? Which compartment? There are 3 compartments of fluid. One is intracellular, which is the largest compartment. Then we have interstitial, which is, near the eyes, all the tissue which is there. And then what is the third component? Perfect, intravascular, okay? Now it is the intravascular volume which is the effective volume. Now, in shock, where do you think the loss of fluid is? Perfect, it is intravascular. So when we lose intravascular fluid, what will happen? Does it have a hemodynamic compromise or not? Absolutely. So intravascular fluid volume loss, when we have, how do we replace it? Slow or quick? Absolutely, yes. If you have a trauma child, leg is cut off, it's bleeding, you're not going to go slow. We just rapidly resuscitate and stop the bleeding, isn't it? Because that is a classic intravascular loss. So shock is when we lose fluid intravascularly, not interstitial. Now what happens in dehydration? It is an interstitial fluid loss. So let's say you're having, you're sitting in the sun for a long time, not had any fluids, having loose stools, which is going on for 2 to 3 days. Then what happens? The body always wants to maintain the intravascular. So it will draw fluid from the interstitial compartment. That is why we are having sunken eyes, sunken fontanelle, correct? The skin turgor all becomes wrong. What happens if we don't correct it? You draw fluid from the interstitial compartment, put it into the intravascular compartment. At one point, there is no more fluid lost from the interstitial. Then what will happen? The loss happens from intravascular. So when we have severe dehydration, you will have all the sunken eyes and everything. And if it's not corrected, it moves on to shock. Exactly. So both groups were right. There is dehydration, which is so severe to have gone to shock. So it's very important that in this child, we recognize that there is shock and not just dehydration. So how do we replace the fluids here? Perfect. It has to be fast till the intravascular volume is filled up. Why do we replace fluids in dehydration slowly? Why can't we just give like 20, 30 ml per kg quickly for children who come dehydrated? What will happen? Volume load, overload can be even in shock. The difference is the vascular volume is already full here. It is only interstitial which is wrong. So when we have to give fluid, we give it slowly so that it equilibrates and goes to the interstitial compartment. If you give it rapidly, it causes electrolyte disturbances. Remember, dehydration is almost always associated with electrolyte disturbances. So when we have dehydration, which is recognized by dry mouth, dry tongues, sunken fontanelle, skin turgor being poor, but some amount of urine going, but the pulse volume will be good. There will be some amount of tachycardia, but not going into the shock range. Still, you don't have cold and clammy hands and feet, and the BP is always preserved, correct? So when you have all these there, then you know your intravascular component is fine. Don't rush with fluids, go slow. So most of the children who came to us in the second wave with some amount of vomiting and fever, they were actually dehydrated. So we didn't have to give them too many boluses. We just gave them fluids, maybe a little more, 10%, 5% correction, and they all got better. But there were a very small group of children who went into shock, hypovolemic shock. So in those children, as we have seen, we need to replace it fast. So now we are quite clear. Shock is when we lose it intravascularly, peripheral shutdown, you have low volume pulses, etc., which I'll discuss later, and it needs to be given fast, whereas dehydration is a much more slower correction. Okay. Okay, now next question. So now we are clear. In a shock, we give the fluid bolus, and how much of bolus do we give? Yes, PALS guideline says 20 ml per kg. Right now, the new sepsis guideline says 10 to 20 ml per kg. So it's perfectly fine for a 10 kg child if you choose to give 100 ml to begin with. How fast will you give it? Somebody says half an hour, somebody says 15 minutes. Okay, remember the golden rule. When the blood pressure is low, it is the last stage. In the next 60 minutes, this child can arrest if we don't correct it. That is the severity. So when the blood pressure is low, how do we replace the fluid? How do we give the bolus? What is fast? Put it with the, drip set. Push and pull, fantastic. So that is the only time where you do push and pull technique. Now, unnecessarily, if I do push and pull, even the blood pressure is preserved, what is going to happen? The fluid is going to leak out. And then you'll start having more wet lungs, etc. So we need to know in which stage we push the fluid and how do we do it. So first thing, we are clear. In shock, we give 10 to 20 ml per kg. And next, we are clear. We give that. If the BP is low, push and pull technique using a 3-way cannula. If the BP is well preserved, put it as a free flow. It will go in 15 minutes. Clear? Now, the next question. What is the fluid that we use? Okay, someone said NS. What else is left? RL, okay. Any other options? Why can't I give DNS? Osmotic. Any other words coming up? Hypotonic. Okay, so I never understood any of these words before. So we did some research. So let's come to it. So the first thing is we give isotonic fluids. So I'm just going to come to what is tonic and what is osmolarity, because once we have it clear in our mind, we won't make a mistake. Just hold on. I will come to the tonicity and osmolarity in a bit. But right now, the fluid of choice is simple normal saline. We will see in the workstations how do we do it. And they are called as crystalloids. What are colloids? Okay, what is the big difference between the two? Have we touched it? Have we touched albumin and FFP and all? How does it feel? Sticky and thick, correct? So it is like putting honey inside. It will not leak and it will all be like gum inside. So colloid is a substance, when we put in the intravascular compartment, it remains. Whereas crystalloid is a substance, when put in the intravascular compartment, about 1/3 of it remains. After that, slowly, it just gets metabolized and leaks out. But still, which is the fluid of choice? Is it colloid or crystalloid? Absolutely. Now it's very clear. It is crystalloid only, which is first choice. Do colloids ever have a role? Yes, they do. That is when we have perfect monitoring and when we are absolutely standing by the bedside and giving it, of course, we've used a lot, albumin, FFP, etc. But for now, we stick to crystalloids. Okay. Now, in this child, we decided there is shock. We give 10 to 20 ml per kg. Once we give a fluid bolus, what is the next most important thing we need to do? Perfect answer. Reassess. That's the only important point we need to remember. Because when we give a bolus, we have to see, has it got the child better? Is the child the same or is the child worse? Why would the child become worse? You're saying shock. You've given the fluid, correct amount, correct fluid, but the child is becoming worse. That means tachycardia, which was 156 in this child, has become 180. Child has become more tachypnic and just totally drowsy. Okay, so you're thinking that there is a cardiac overload. That means the heart was already not working very well. You gave the fluid and the heart almost got fully congested. Brilliant. So there is. So in that situation, what do we need next, logically? Perfect. So we need something to help the heart, not give more fluids. Very good. What else is the reason why the child might have deteriorated? Sepsis. Okay. Okay. So you're thinking that it leaks. Brilliant answer. So it's not just fluid overload. When we give a child fluid and the child worsens, it's not just because of overload, because the pump is not working, and it can also mean because it just leaks out. Haven't we seen that? Sometimes that is called as fluid intolerance. One is overload, one is intolerance. So both can happen. So what we need to do is when we give the fluid bolus, we need to reassess, look at the heart rate, look at the respiratory rate. We never count the respiratory rate. Look at the respiratory rate, see if the child is recessing more, the child is becoming more drowsy. That means something is wrong. Whatever fluid we've given has made it worse. How many of you work near ICUs or little bit of ICU, little bit of wards? Any of you? Okay, so there are a group of you, and that bunch of people have to have an ultrasound machine. Isn't it useful? Because you can just keep the probe and see whether the IVC is full or not. So you know, oh God, stop, we cannot give. So now we use a lot of ultrasound right in the emergency, even before the admission has happened. And we know clearly, okay, this is the amount of fluid we give and we have to stop here. For those of us who don't have ultrasound, it doesn't matter. Simple clinical things like respiratory rate, crepitations, work of breathing increases, liver size increases. How do you know the liver size is increased if you've not checked it before? So very important, when a child comes having evidence of shock, put your hand there, put the pen mark, so we know this is the liver size, and after the fluid bolus, what happened to it. Okay, so now in this particular child who had ongoing losses, what do we do apart from correcting the shock? We have to correct the ongoing losses because some amount of diarrhea is going to happen. So remember to have a 3-way or 2 cannula. One side, an isotonic fluid will keep going for the maintenance, and the other side, a fluid will go for the replacement as well as shock correction. Clear? Now, in a child like this who has both dehydration and shock, first we treat the shock component. That is, we give 10 ml per kg or 20 ml per kg, reassess, heart rate is coming down, pulse volume is felt better, then the child is opening eyes, starts crying, pulling out the cannula, then you know the shock part is better. Now what are we left with? Dehydration part. So for that, don't keep giving policies. Do it slowly, like the WHO protocol, 30 ml per kg and then 70 ml per kg. Do that whole 10% correction slowly over 3 to 6 hours. All right, so I think we're clear with that management. So the learning points from the first part is, if there is shock, recognize it and replace it fast. If there is dehydration, do it slow. And always use isotonic fluids. So now let's come to this tonicity and osmolarity. So what is osmolarity? Can someone just tell me what you think about it? Okay, if I take sugar or salt and mix it in water, it becomes a solution. So the osmolarity just tells us how much of sugar is there in that solution or how much of salt. It's just the concentration. That's all it is. So for example, someone said the high osmolar fluid. That means what? There is high amount of osmoles. What are the osmoles that you know of? Sodium, glucose, urea, all of these are osmoles, okay? Now, when they are there in our fluid, like, you know, you have DNS and you have dextrose, 10%, 20%, 3% NaCl, what does it all mean? It means all these are osmolar agents. The more you put, it becomes hyper. The less you put, it becomes hypo. Now, what is this tonicity then? The same osmolarity, if I put it inside the body amongst a semi-permeable membrane, that means I take 2 solutions with an egg membrane in between. That is a semi-permeable membrane. One solution has a lot of salt in it, and the other one has very little salt in it. Do you think the water will move across the membrane or not? It will move, right? So where does it move from? The water moves from? Correct. Wherever the sodium is very low, the salt is low, water is more, it's going to move and equilibrate so that the water component equilibrates between the two. Is that right? That's what happens in the body. So the osmolarity, when taken in vivo, is called as tonicity. So it's the same thing. It is the same concentration of solute in the fluid, but it is in vivo. So what else happens in vivo as compared to in vitro? There is metabolism happening. There is usage of glucose happening. So if I take dextrose normal saline, that is sugar and salt in water, mix it and put it inside the body, what happens to the dextrose? It gets metabolized. So what is left? Only the sodium. So the dextrose is an ineffective osmole, correct? It has got used up, so it will not help in keeping the fluid or pushing away the fluid. So what is an effective one is only the sodium. Urea is also an osmole outside the body, but when it puts inside, it can move across the membrane, so it becomes ineffective. So tonicity is nothing but effective osmolarity. It only means the amount of sodium which is there in the fluid will determine the tonicity. When we say isotonic, what do we mean? It is iso to the sodium in the plasma. So the sodium in the plasma, let's say, is taken as 145, then any solution which has around 145 of sodium is isotonic. That means what? If I put that solution and if I put my plasma and separate it by a semi-permeable membrane, will there be a fluid shift or not? Perfect. So there will be no fluid shift, and that is the fluid we need. We need a fluid which does not move across the membrane, which is isotonic. So now we understand what are isotonic fluids. Now dextrose normal saline, is it isotonic? It has dextrose, which is very high. Let's say the dextrose and the salt put together, the osmolarity is around 500. But what is the body's osmolarity? Some 295, let's say, serum osmolarity. So is it isotonic, dextrose normal saline as compared to plasma? Is it not isotonic or hypertonic? That's the question. It is hyperosmolar. But once it comes into the body, what will happen? The dextrose goes away. So what remains is only the sodium, and the sodium is the same as that of plasma. So it is hyperosmolar but isotonic. Is that clear? So all we have to do is to look at the sodium. If the sodium in a solution is the same as that of plasma, then it is perfect. It is isotonic. So give me examples. Normal saline. RL is almost there. It's 130 or something. Ours is 135 to 145, so that's fine. It's near isotonic. DMS, yes, correct. So all these are called isotonic. Now let's look at dextrose. If I put dextrose in water, I can get it about 300 osmoles. But is it isotonic to plasma? No, because how much of sodium it has? 0. So it is terribly hypotonic, and we don't use that. So this is the explanation here. The effective osmolarity is called as tonicity, and sodium is the most important determinant of tonicity. So we need to use fluids which are isotonic to that of plasma. This is what I meant across the semi-permeable membrane. So all these fluids here, 0.45 saline, that is half normal saline. Is it isotonic or hypotonic or hyper? Hypo, perfect. Why? Because it is half the sodium. It's as simple as that. That terrible fluid called EP, we never use it because it is so hypo, isn't it? So there's a chance that it all leaks out. So what maintenance fluid you want to use in your child is something which does not leak out. So what is the maintenance fluid you want to use? DNS, exactly. Okay. So this is a chart which says the same thing. Look at the last two columns. Here we have... here it is, osmolarity is so high, see 300, 500, 400, but they are all isotonic because ultimately if you look at the sodium, it is the same as that of the plasma. So when you pick up a fluid, if the sodium is almost the same as plasma, you are fine. That's the right fluid to use. You use dextrose containing fluid for maintenance, you use a non-dextrose containing fluid for resuscitation. Okay, so we've done this. Never give just plain dextrose water as a maintenance fluid. It's a crime because it is hypotonic and it will all leak out. Okay, so tonicity is the single most important determinant of fluid shifts, and for that we look at the sodium. So the learning point here, always use isotonic fluids for resuscitation and for maintenance along with dextrose. And obviously when we're using only fluids, we need to monitor our child. Now let's come to a little more about shock and its recognition. So let's start with this child. He is a 5-year-old with history of fever for 6 days, typical high-grade fever, pain abdomen, vomiting, puffy face, red eyes, red lips, hepatomegaly, and the local GP suspected dengue, which is right. And so he thought this is dengue fever and referred. Now look at this child. He has that typical puffiness. In this slide you can't really make out, but his lips were very red, his tongue was red, and his eyes were all red, which you can't really see very well. And heart rate was 185, saturating normal, respiratory rate is okay, blood pressure is 88/26, he's 5 years, remember. GRBS is fine, bounding pulses he had. The blood counts are low, lymphocyte is extremely low, CRP is supremely high, unlike any other viral infection. Dengue came rapid is negative, typhoid negative, and cultures we had just sent it. So what is the thought process here? We are in a COVID seminar. Yes, so we are thinking of COVID. This could be MIS-C. What else could it be? Let's move out from MIS-C and think. Perfect, it could be, but how many times have we seen Kawasaki presenting with shock previously? Very rare. Okay, what else can it be? Look at the blood pressure, very low diastolics, I'll come to that. Bounding pulses, red. Perfect. Toxic shock syndrome. Brilliant. So streptococcal and various other bacteria can actually cause something which makes you all red, which makes your pulses bounding, which makes you tachycardic. That is toxic shock syndrome. Good. So we got some differentials. And obviously our good old sepsis, anything can cause sepsis, MRSA sepsis, they can present like that. So those are the differentials we considered. Again, the ECG is not showing very well, but we clearly had STT wave changes. That means it's already affected the myocardium. There is a bit of myocarditis going on. We need to be very, very careful. We need to keep this child on continuous cardiac monitoring. So we thought of septic shock, toxic shock, and MIS-C, as you rightly said. And COVID antibodies were sent. All the other things were done. We added ceftriaxone and added clindamycin. It's okay to add vancomycin also. Why clinda? Because it has antitoxic effects and it also has a good gram-positive cover, so we did that. Now we gave the fluid bolus as per the septic shock guidelines, and then we got a lot of markers. All these are showing, I won't spend too much time, it all shows multi-organ dysfunction. COVID antibodies came as positive, so now we have a diagnosis. The fever with organ dysfunction, with KD-like features, association with COVID, this is classic MIS-C. Now, what are the priorities of management over here? What is the most important organ which was affected? Cardiovascular system, brilliant. So what is our priorities? How do you think we should manage it? So first would be? Perfect. So we start with fluids. Okay. So I won't go to what we did. I will leave this slide. And the child ultimately improved and went home. So let's just start with the basics of the cardiovascular system. So there are three important aspects. We have a pump, which is the heart. We have the tubing, and the tubing has a fluid. And any problem with any of these three will result in cardiovascular compromise, will result in shock. Correct? Now, when one of the beauty is when one component doesn't work properly, what happens to the other two? It compensates, isn't it? Brilliant. So the way we recognize shock is, one, there is a problem in one of the component, and also by the compensatory feature in the other two. Can someone tell me any of the compensations? What are the common compensation that happens? Tachycardia, the heart rate increases, and because of that, it tries to maintain the cardiac output. So one is tachycardia. What else? Excellent. Vasoconstriction. So when we vasoconstrict, we are trying to push up the systemic vascular resistance and maintain a blood pressure. So that is one of the compensatory mechanism. So then we should not get shocked. No, the body is so good at compensating. What happens then? There is a limit. Because if the shock persists and persists, let's say that child with COVID came and we didn't recognize the shock, we didn't give the fluid bolus, what is going to happen next? At some point, the systemic vascular resistance will become so high, the peripheries will become so cold, you can't even feel the pulses, and then the BP starts falling. The cardiac output is really going down. And when the BP goes down, that is called as decompensated shock, and that is a peri-arrest thing. So when blood pressure falls in a child, it is very, very serious. Okay. So under normal conditions, the various components work interdependent with each other, but as we know, they try to compensate. So what really is shock? It's a supply-demand mismatch. It is inadequate tissue perfusion because the substrate delivery, which is mainly oxygen glucose, is not able to meet the tissue demand. So ultimately, it results in what we call as tissue hypoxia. So we need to focus on preventing this tissue hypoxia and getting back to normal. So it can be pump failure like cardiogenic shock, it can be tubing malfunction, which is called distributive shock. Can somebody give me an example of tubing malfunction? Sepsis, yes. What happens in sepsis? Yes, all the peripheral vascular capacitance increases, the vessels all dilate, so it starts getting filled up with fluids and the fluids start leaking. So because of that, they need more fluids and they may also need vasoconstrictors. Okay, another example in terms of COVID, in MIS-C, we do see toxic shock-like presentation like this child, that also is having a distributive failure. What about fluid loss? Typical hypovolemic. So one is outside the body, you can lose the fluid, and it can also be inside the body. Example? The leak in dengue, the capillary leak happens in MIS-C also, where you have the effective vascular volume is lost and all the fluid leaks out. Okay. So now how do we assess the circulatory system? Quickly. Brilliant. So the first important thing that we have to see is the heart rate and the pulse volume. So how I tend to remember is when you have a child, when you're doing respiratory assessment, all of us do respiratory assessment, and then when we come to doing cardiovascular assessment, first you check what is the heart rate. We know the age-wise criteria for the heart rate, and if the heart rate is high, put your hand on the hand of the child and look at the pulse volume. Then see the difference between the peripheral and the central pulses, because the brachial is a central pulse. Don't just feel brachial pulses, femoral pulses, carotid pulses. No, it's important that we feel the peripheral pulses and compare it with the central and see, is there a big difference? Then yes, this child is already in early shock. But we can't take only one parameter. We can't say, oh, the child's hand is cold, this child is in shock. No, we need to see cold peripheries, peripheral pulse volume is low, the difference between the peripheral and the central pulses, then what is the capillary refill time, both central capillary refill and peripheral capillary refill. If it is more than 3 seconds, alarm bells. If it is by the time you release, it flushes back, what is that called? Yeah, flash capillary refill. That means all your vessels are all dilated. It is part of a distributive shock there also. And then lastly, we will do the blood pressure. So we will come to individual components over here. Not just that we see the cardiovascular, we also see what is the effect of tissue hypoxia on 2 important organs, the CNS and the kidneys. So if the child is very drowsy and if the child is passing no urine at all, that also is a feature of shock. So heart rate, ages, I'm not going to go to this. Pulses, I told you it's very important to compare central and peripheral pulses. CRP we know. Now let's come to BP. I think these 3 important numbers we have to. All my nurses, I keep drilling it into their heads. If they are less than a month, at least 60 should be systolic. Less than a year, at least 70 should be systolic. And beyond a year, up to 10 years, it is 70 plus age into 2. And at 10 years onwards, we need at least 90 as systolic. And these are PALS guidelines. I'm sure we all know it, but it's good to reinforce. Now, all of us know systolic blood pressure. How many of us know diastolic? So let's look into the diastolic. Oh, one important point I missed out is it's not just important to have the systolic blood pressure. If there is a fall by 10 points in the systolic blood pressure, let's say we started at 110 and then the child fell to 100 in no time, you should start thinking this child is moving on to shock. You have to think about why the systolic pressure is falling. Now, there is another thing called as mean BP. So it is kind of what is between the systolic and the diastolic, the effective pressure at the tissue level. And this mean BP is very, very important. And that is calculated as diastolic blood pressure plus 1/3 of the pulse pressure. Pulse pressure is basically the difference between the systolic and the diastolic. Now, the map is what we as ICU people look at. We need a minimum of, let's say, 60 map in most of our children and 70 in the older children and at least 50 for the younger ones. So this map will come when you use your oscillometric method, and that map does not usually get altered. It is quite reliable. So please look at the map and look at these magic numbers saying that are we at least reaching that. If the map is low, even though your systolic is high, that shows that you have a low diastolic. So coming on to diastolic blood pressure, usually it should be at least 50% of the systolic. If it is less than that, then it is low diastolic. So keep that in mind. And why do we need diastolic blood pressure? Not just cerebral, it's coronaries. That's where they get. So if you keep having a low diastolic blood pressure, which happens very typically when you have septic shock or toxic shock, they so vasodilated that your blood pressure becomes, diastolic BP becomes very low. Ultimately, they go into cardiac failure. Okay, now, how do we recognize shock? We know the symptoms. Child is listless, drowsy, not passing urine, cold peripheries. These are the warning signs we tell our parents. So we've seen all of that, dizziness. The older children with dengue, they come to the OPD walking and then they suddenly fall off because that is one of the features. They can have a vasovagal syncope, etc. But the signs, we cannot miss the signs. Now, this is very important. Starting with tachycardia, feel their hand. It gives a lot of information. The peripheral pulses, difference between the peripheral central pulses, capillary refill time, compare, is it colder as compared to the rest of the hand? Is the peripheries cold? That cool peripheries is a warning sign. So we need to keep that in mind. And lastly, we need to check the blood pressure. So make sure that all of us have the right levels of cuffs for the various ages. Otherwise, it's impossible to check the blood pressure. And the early signs are when you have tachycardia and poor systemic function, but the late signs like weak central pulses, this part itself is not felt properly, child is drowsy or the blood pressure is low, is a bad thing. Okay, now can we differentiate the three things clinically? The hypovolemic shock, the septic shock, as well as the cardiogenic? Yes, there are many pointers. So let's start with hypovolemic shock. What do you think is characteristic in hypovolemic shock? Yeah, low volume pulses, isn't it? Because there's no volume itself. So they will be cold. They are the typical ones where, it is cold, you hardly can feel their pulses, you give volume and you start feeling them. In them, usually, there is no role for inotropes. It's only about giving the volume and getting them better. So here you will have high systemic vascular resistance. Diastolic BP will be very high because they're all so vasoconstricted and they're very tachycardic. What about cardiogenic shock? It's almost the same. They also don't have effective circulatory volume because there's no cardiac output only. But the most important thing is their work of breathing is so high. They have a hyperprecordium. You can just tell that this child looks like it has a respiratory disease, but it's cold peripheries. That immediately should tell us there is something cardiac going on. Okay, so concentrate on the work of breathing, their precordium, their liver size, auscultate the chest, get a feel of how your baby is when you're thinking about cardiogenic shock. And what about distributive shock? This is the easy one. It's the typical septic shock one. You either have the bounding pulses, red, flushed kind of appearance in the toxic shock, warm septic shock type, or it is cold and typically behaving like a mix of cardiogenic and hypovolemic shock. Okay, so what are your targets in management? I know we want to manage this child, but we need to know why are we giving the fluid, to what is the end point? So you should keep some mental targets like, okay, the heart rate was high, I want my heart rate to get better. I want the mean blood pressure to come back to normal levels. I want the CFT to become 2 seconds. The difference between the peripheral and the central pulses should normalize. The skin temperature should become better. Child should start passing urine. And there should be improved mental status. And there is a thing called lactate, which we measure, and the lactates should start coming down. So, what are the basic tenets of management? First is fluids, as we all know. Next is vasoactive agent. And lastly, it is the supportive management. So, fluids, I think we discussed it. The first choice is always crystalloid. And we're looking at isotonic crystalloids like normal saline. Somebody said ringolacta. There is something called cabalite or balanced salt solution. Does anybody know what that is? So it's basically like normal saline, but the problem with normal saline is, if you look at normal saline, it's not very normal. The sodium is as normal as compared to the plasma, but what about the chloride? What is the plasma chloride? Around 110. But what is this chloride here? It's 150, right? So every time we are giving some 40 extra of chloride with each bolus of normal saline, which is not very good. So that is why people started feeling this hyperchloremia itself was causing acidosis, causing acute kidney injury. So then they started saying, especially in adults, we always copy the adults, that maybe we should not use this. We should use something called clever thing, which is balanced, which has normal sodium and a normal chloride. And in our unit, that's what we use a lot. So our incidence of AKI, etc., is very, very low. But this is more costly. So if you don't have this, it doesn't matter. All these years we've used this and this is fine. Okay, so that is crystalloids and balanced salt. What about colloids? I told you, first line, no. It is only when in certain situations when we have good monitoring. Has anyone used something called starch? Very good. Don't use it. Absolutely harmful. Now we don't use all of that. If at all, we need to use albumin. Okay, so fluid therapy we already discussed. It is 10 to 20 ml per kg, and sometimes we use 5. When do we use 5 ml per kg? Sorry? Yeah, so when we are worried about the amount of fluid that we are giving, then you use a smaller aliquot. There is no rule that you have to use 20. No, we give a little bit. See, what are we seeing for? Excellent. So we see the same thing, heart rate, pulse volume, etc. And also, don't ever forget to auscultate the lungs. Why? Yeah, why? Crepitations come in 2 situations. One is because of fluid overload, so congestion. The other thing is there is no fluid overload. Still do you have crepitations. Why do you get that? cardiac is because of the overload situation, congestion. It's because they are leaking. They're not overloaded. We've seen that in dengue, right? We would have given it very fast and then they start having crepitations. So that happens in MIS-C also. That is called as intolerance. So remember, you can have a congestion or an overload situation. You can also have intolerance. So you need to see both of these. And sometimes we need to give the same amount of bolus but a little slower. Okay. So these are the two things we need to watch out for. And we all have heard this warm shock, cold shock. Although now as in ICU people we are moving away from it, it is important for us to recognize that when we have cold peripheries and vasoconstricted system, there is no point giving a vasoactive agent which further vasoconstricts. We need to use some other strategies. So we need to probably do some peripheral vasodilatation at the same time help the heart. So it's important to see the systolic blood pressure, the diastolic blood pressure, the mean blood pressure. We know the targets now, and accordingly we need to add our vasoactive agents. So now let's look at what are the vasoactive agents. They can be of three types. Most importantly, they can go to the heart and help the heart get better. Remember the diagram we said it's a pump failure, it's a tubing failure, or it's fluid failure. So here, a vasoactive agent can go directly to the heart and help it. And what is that agent called? An inotrope, isn't it? An inotrope just means it helps the heart pump better. Give me an example of a pure inotrope. Yeah, it's not very pure, but yes, it does help in increasing the cardiac contractility. Adrenaline also helps in increasing the cardiac contractility. But what does dobutamine also do? It causes some amount of vasodilatation. So if you're having a blood pressure which is slightly low, and on that you try to give dobutamine and the blood pressure falls, then you're not achieved your target. So at that situation, we may have to combine noradrenaline with dobutamine. We may have to use the dobutamine to help the heart, but we may have to use a vasopressor. What does a vasopressor do? It vasoconstricts, exactly. Example of a vasopressor? Noradrenaline, another example, vasopressin. And we can, even adrenaline at higher doses of more than 0.3 is a vasopressor. So we need to think in which situation, physiological situation, are we going to use an inotrope, an inodilator, or a vasopressor agent. I know this is beyond the scope of this talk, but at least if we have an overview, when we are initially managing the child, we would use the correct agent. Now let's say we are resuscitating a child in our clinic or in our ER, and the child, you've given the fluid, it responded well, you've given the second bolus of fluid, and then the child seems to deteriorate. Now you want to shift the child to another center. What would you do? First fluid bolus, it improved. Second fluid bolus, it started having, again, tachycardia started rising, there's more crepitations. So what does that mean, first of all? We can't give more fluid, right? So we've reached either it's fluid intolerance or it is fluid congestion and overload situation. So here you found that the liver size also had increased a little bit. The peripheries are all cold now. So what is the next agent we are looking at? Correct, an inotrope is what we're looking at. Can you give me an example? What could we use now? We said there is dobutamine, which is an inotrope. It works on the heart. What is the next inotrope we said? NORAD is not really an inotrope. It doesn't really work on the heart. It mainly works on the blood vessels by constricting it. So that's the thing. In this child who already has very cold peripheries and the diastolic blood pressure is very, very high, that means narrow pulse pressure is there, I may not want to choose noradrenaline. What do I want to choose? Why would I want to choose adrenaline? Because adrenaline at a low dose will not only work on the heart by improving the contractility, what else does it do? At a low dose, it causes some amount of dilatation at the peripheries also. So when you're in doubt, you have a sick child with borderline blood pressures, start adrenaline. But can we start it on a peripheral line? Adrenaline is one drug which will be there everywhere, in every PHC and everywhere. Can we start it on a peripheral line? Yes, the answer is undoubtedly yes. It's there in our septic shock guidelines 2020, and we have to use it. It's nothing. We use it all the time. Central line should not be a deterrent for you to use either noradrenaline or adrenaline. But of course, we can't do it for 3 days. We use it as a temporizing measure till you're better, till the child is shifted, and till we can get a definitive line, because it is going to go anyway. So how do we mix an inotrope? This is practical. We need to know it. Because in the emergency situation, we can't go refer to the book, call somebody. No, we need to know it. Anyone knows? Very simple. 0.3 milligram per kilogram. Dissolve it in 50 ml of saline. And then you will get 1 ml per hour is equal to 0.1 mics per kg per minute. So the dose of adrenaline that we need to use is 0.05 to 0.3 mics per kg per minute. So typically we'll start 1 ml per hour or 2 ml per hour, which will give you 0.1 or 0.2 mics per kg per minute. Okay, I'm sure all these presentations will be with you all, so you could refer later, but we need to have a mental picture of what is the emergency drug that we're going to use when faced with such a situation, and we can use it in the peripheral line. Okay, so we have a choice of which inotrope to use. If the child is having cold peripheries, low blood pressure, sick child, I would definitely choose adrenaline, peripheral line, and this is the dose. If it is warm peripheries, bounding, but low diastolic, like we saw in our MIS-C child. What is low diastolic, just to reinforce? Perfect. When the diastolic blood pressure is less than 50% of the systolic. So we know that is not a good situation. We need to vasoconstrict, and which is the best agent we have? Noradrenaline, and that also is the same dose, and that will just bump up the blood pressure a little bit. After that, we hand over to ICU team, where they don't just see physiological parameters, they do a little more. What else do they do in the ICU as compared to emergency? They will not just go by the blood pressure which we are measuring, because by then the child has leaked, there's a lot of edema, we can't measure by a BP cuff. We need to actually do the invasive arterial line. Next, we need to put an ultrasound probe, and we need to see what is the IVC filling? How does the echo look? Is the cardiac chambers dilated? Do we need to cut back on the fluids? Do I need more inotrope? Do I need to mix and match inotrope with a vasoconstrictor? All these finesse in management will come with the ICU team. I don't think we need to worry about that. Our aim is to recognize the shock early, to know which agent to start, to know when to stop the fluids, and to know what type of fluids that we need to give. So what else do we do? It's not just about fluids and inotropes. Shock doesn't end there. There's a lot of other things which are happening simultaneously. Simple things like oxygen delivery. Remember, we said shock is ultimately tissue hypoxia. So just by giving oxygen through the NRM, is non-rebreathing mask, is a simple technique where we can improve the oxygen delivery to the tissues. Next, we may have to help with the respiratory support by giving a little bit of positive pressure. It could be by just simply using even a HFNC, but better by an NIV, or in most instances, we may have to even ventilate them early, especially when they're having cardiogenic shock, because you want to reduce the load on the heart. And ventilation itself will behave like an inotrope. It helps the heart work better. So the other adjuncts that we have, apart from oxygen and ventilation, etc., in the context of COVID, is our magical drugs like steroids, IVIG, etc., which Dr. Karunakan will be talking about later. So another important thing, when we have cardiogenic shock, always keep your electrolytes normal, because the borderline potassium 3 will result in problems. It will trigger an arrhythmia, and that's the last thing you want, because we have lost a child when they develop sudden arrhythmias and they just go. So it's very, very important to maintain the metabolic milieu. So our learning points: good outcome in shock is when we recognize them early. We need to know the baseline heart rate, peripheral pulses, capillary refill time, difference between the central and the peripheral pulses of the child. We need to measure the liver size, see whether they have crepitations, etc. And by the time the BP falls, it's too late. So we should not reach that stage. Always use isotonic fluids. And after each bolus, it's extremely important to reassess. We also look for intolerance and fluid overload. And when the fluid is not working, we think about using a vasoactive agent. Always ask yourself the question, is it a pump problem where I need to use an inotrope? Or is it cold and where we use to use a dilator? Or is it warm where I use need to use a vasoconstrictor. And always consider advanced hemodynamic monitoring if the resources are available, if a person is there to refer, so that it can get the right kind of care. And do not forget the role of adjuncts. Thank you so much.
Thank you very much, madam, for that very good interactive session.
ವಿಡಿಯೋ ಪ್ಲೇ ಮಾಡಬೇಕಾ ಇವ್ರದ್ದು
ವಿಡಿಯೋ ಬೇಡ, ಡೆಸ್ಕ್ಟಾಪ್ ಲಾಕ್ ಮಾಡಿ ನಾನು ಹಾಕೋತೀನಿ ರೆಡಿ ಇದೆ, ನೆಕ್ಸ್ಟ್ ಹಾಕೋತೀನಿ ಅಲ್ಲ ಅದು ಅವ್ರದ್ದು ಆಯಿತು. ನಮ್ಮದು ವೀಡಿಯೋಸ್ ಹಂಗೆ ಪೆಂಡ್ರೈವ್ ಅಟ್ಯಾಚ್ ಇರುತ್ತೆ.
ಇಲ್ಲೇ ಇರಲಿ.
ಓಕೆ. Our next topic is about management of MIS-C. Professor Dr. Karunakar BP will be talking about this session. He is professor in MS Ramaya Medical College and past president of IIP BPS. I welcome you, sir.
Thank you so much. Take it up. Yeah. One ನಿಮಿಷ. Okay. Done. I'll manage. Okay. Good afternoon, everybody. At the outset, I would like to express sincere thanks to the BBMP for this wonderful initiative to start preparation for the possible and potential pediatric wave. And I'm also express sincere thanks to Dr. Saraswati, Dr. Prashant for taking the initiative and making it possible today. I'm sure the way you people attended in the last maybe close to 2 days, it's been extraordinary. I think I must also take this opportunity to congratulate all of you for being part of the work that's been done in controlling or managing COVID in the last first wave and also in the second wave, possible for the third wave. We are all getting prepared. And I only say the work done by the government doctors has been extraordinary. There is no doubt to really tell anything more than that. What you have done, it's not been an easy task, risking your own life, your own families, and everything else you have served these patients. We also understand that people don't recognize at outset and they really try to misbehave with the doctors, but we know that what it goes working inside a COVID ward is not easily explainable actually. I must really congratulate and appreciate you and also wish you that you safeguard yourself in the next coming waves also. And we don't know how many waves are going to come up actually. 1 is over, 2 is getting over, 3rd is expected. And we know that in Japan already 4th wave has entered actually. I think it's going to last quite some time, maybe another 1 or 2 years more. So it's high time we really get up ourselves used to the so-called COVID waves actually. Now we also know that there is a lot of things happening all through practically across the country. The only discussion that's happening is that what's going to happen in the 3rd wave actually. People have already written it very clearly on the notice boards that it's going to be pediatric wave. But is it going to be really so? Not really much actually. Looking at the way the vaccination has happened, looking at the volume of exposure to the public, and practically it possibly less than 10% of the population has been covered by either by the disease or by exposure or by vaccination. So practically for me as a pediatrician sitting at and looking at potential pediatric wave, for me it looks possibly quite less likely. It's possible that we may get third wave of COVID, but where pediatric is going to be proportionately increased with respect to the amount of adults who are going to be affected actually. Unless otherwise, the government of India is going to cross at least 50 to 60% of the vaccination drive, at least 50 to 60% of the population, possibly it comes to close to about maybe 60 to 70 crores population has to be vaccinated over next maybe 5 to 6 months actually, and we know that there is no vaccines available. At least now everybody is rushing up their vaccines to India. It's a big market and government has also taken initiative. We are looking at possibly where some are going to reach close to 50% or so by the end of December. But say if the third wave is expected to hit the country sometime by about October or November, we are going to fall short of our preparation as far as addressing and stopping the third wave actually. So in that background, we are still going to see quite a number of pediatric patients developing COVID actually. You also know that in the last 2 waves, practically in the first wave, there was not much pediatric cases except in places like Mumbai and Delhi possibly. There are quite a good number of cases, but we didn't see much of it. This wave, second wave, practically there are a lot of cases reported, documented in Karnataka also actually, and the numbers are steadily increasing. And now possibly if third wave is going to be again a similar one, it's going to be a serious concern now. So in that background actually, are we ready to manage the MIS-C or MIS-C actually? So I am going to speak briefly on the topic. I must sincerely thank our previous speakers for covering all the aspects that's supposed to be looked at. It's going to be much easier for me to work on that actually. Let us look at a case actually, very interesting case. This was our first case of so-called MIS-C in our hospital. A 4-month-old child was brought with vomiting for about 5 to 6 days. We had jaundice, we had fever for 3 days. I had thrown conversion before coming to the hospital. That's the reason why the child was brought to the hospital. The kid was sick, was drowsy but was arousable, was found to have a mild icterus. There was some edema was also there. Hemodynamically reasonably on the borderline, and he had some kind of head size, phagocephaly and frontal bossing, not really much about to talk anything beyond that as far as the dysmorphism goes actually. And what we looked at in this patient, an examination patient had the icterus, beside that had some hepatomegaly, then everything else was reasonably well. So the initial diagnosis in this patient was possibly we are dealing with a case of acute liver cell failure, could be a fulminant hepatitis with mild encephalopathy. If a patient comes with an icterus with altered sensorium, practically it drops into the encephalopathy spectrum only. So in that case, 4-month-old case, what conditions you look at? Very unlikely to be in infections, though it's common to be the case in the pediatric patient. We have to look beyond the common infection where you have to look at even IU infections, not very common to cause hepatitis. We need to look at inborn error of metabolism as one of the possibilities, possibly looking at little bit change in the skull, the head actually. We also thought of genetic syndrome. But what we felt all through that, something was not fitting everything in this patient actually, neither for the inborn error of metabolism, nor for the infection, nor for the genetic syndrome. But we were really unable to really break our head, so we sent the markers and test for that. So where viral markers came normal, negative rather, and the inborn error of metabolism TMS also came negative actually, and practically we were nowhere as far as making the diagnosis. The child was started all required therapy, including supportive care, antibiotics, but child continues to worsen. And we know that this is season of COVID. Somebody even thought of it could be COVID, but we inquired with the mother. There was no history of COVID in the family, neither father or mother, nor anybody else visited the child in the family had a COVID actually. And it was really surprising for us to really look at as a possibility of COVID, but as a matter of fact, we sent a sample for the COVID serology, which came as a positive. So before that, the child started sinking, and child developed refractory shock, where we need to do cardiac evaluation, where we found the child had significant ventricular dysfunction, and basically heart was not really performing to the requirement even with inotropic support. That's the time we started thinking beyond possible diagnosis of whether it could be MIS-C actually. Even before the serology came, we thought of possibly it could be MIS-C or it could be some other syndrome similar to that. We started working on that. Fortunately, we also got the serology test immediately available over next few hours, so practically sealing the diagnosis. So look at this case where there was no patient exposure in terms of parents, relatives, or anybody else in that, but child had COVID actually. And child didn't respond to any treatment, almost about 5 inotropic supports, ventilatory support, except ECMO. Everything else was tried in this patient. ECMO, basically parents were not willing actually. So ultimately we lost this patient, and it was a very big learning experience for us. So what we decided with this case, in the season of COVID now, maybe over the next few months or maybe a year or so, every patient who comes to us, we must do COVID analysis in those patients. This is another interesting case currently taking treatment actually. A big child about 13 years who came with 4 to 5 days history of fever, rashes over the abdomen. Practically again, there is no significant history of exposure, where the diagnosis of MIS-C was considered by the referring doctor himself actually. He thought it could be the season, because you know that everybody talks, every pediatric forums are talking about MIS-C. He thought it could be a possibility, investigated. He found the markers elevated. He refers to us actually. The child is doing well with minimal steroids. And what we found in the history, that mother had COVID almost about a year back actually, the first wave. But see, if somebody is having infection almost about a year back, is it possible somebody is at risk of exposing the child who can develop MIS-C? That's what we are going to discuss. So, what we know about the case is that MIS-C is a rare complication of COVID-19 in children. And it's been the first case reported from England in a case series where they found that few children had a presentation similar to Kawasaki disease. They thought of it could be something to do with the Kawasaki disease, but when in the season of COVID, when the serologists came positive, they started connecting the Kawasaki disease with COVID. That's how it's been labeled as multi-system inflammatory syndrome temporarily associated with COVID-19. That's how it's been labeled. So that's how it's taken from there. Subsequently, the plenty of cases have been reported from across the country. And we know that currently it's an evolving disease. Not much data is available to really give firmly about what is the incidence and prevalence. We do not have much idea about it. It's also been noticed that basically it was more common in adolescents, but it's also been found that it's happening from infancy to almost up to across the pediatric age group, and people are also seeing in neonate period also. And our friend is going to speak on that actually. And it's also been noticed that by epidemiological surveys that it happened over a few weeks after somebody exposed to the COVID. That's how it's been identified as possibly related to that. So this is the definition of COVID actually. When we say it's possibly COVID, we have CDC criteria, we have WHO criteria. So practically for us, we stick to WHO criteria, where there are 6 criteria, all must be met to make a diagnosis of COVID-19. So what are those? The first one is age group, anywhere between the newborn to 19 years is the first one. The second one is most importantly, fever lasting more than 3 days is the most important entity for considerations. And we have few more clinical signs. Any 2 of them could be a part of the multi-system involvement can be taken into consideration. That includes rashes, bilateral non-purulent conjunctivitis, mucocutaneous inflammatory signs either in the oral, hands or the feet. And it could be hypertensive or hypertensive shock actually, cardiac dysfunction, pericarditis, valvulitis, coronary abnormalities, all could be there in these patients. Elevated of coagulopathy, evidence of coagulopathy, acute gastrointestinal symptom. These are the symptoms. If you have at least 2 of them, possibly you need to keep in mind it could be MIS-C also. And then of course you're supposed to have elevated inflammatory markers in the form of ESR, CRP, procalcitonin and other things. And you also need to make sure that there is no other obvious microbiological causes of inflammation, including bacterial sepsis, staphylococcal sepsis, or it could be toxic shock syndrome. That point is very interesting to say. All 3 are discussing that there could be associated infection, but what it says, there should not be any evidence of other infection also actually. And one of the most important requirement for the diagnosis is the evidence of SARS-CoV-19 infection in the form of positive RT-PCR, positive serology, or positive antigen test, or contact with the patient with or an individual with COVID-19. That we'll discuss it here only. Say, as far as COVID goes, we know that there is an exposure. right? Either after exposure, one can be either an asymptomatic one, or it could be mildly symptomatic, or they develop much varied level of symptomatology and may require admission. Actually, in those patients as of now, the gold standard for diagnosis is RT-PCR. Also, we know that it's not been very effective, but that's considered a gold standard for the making the diagnosis. Serology basically has been used as a epidemiological tools, or it's very important as far as MES-C goes. We don't go with RT-PCR, rather we go with MES-C actually, for serology with MES-C actually. The history of contact with individual with COVID-19, as I pointed out in my 2 case scenarios, practically there was no appreciable COVID exposure in both the patient, but what we are looking at now in a pediatric population where the children remain asymptomatic despite exposure may end up coming with MES-C as a presentation. That's what I'm trying to tell you, that MES-C is going to be a MES-C for all of us as far as pediatric MES-C goes actually. So it means any child comes with a symptomatology that's been mentioned in the criteria. If you find them somewhere fitting into the diagnosis, MES-C has to be entertained as one of the diagnoses, and we must work on that. So it's been thought to be basically some kind of immunodysregulations has been the reason behind somebody developing MES-C after about few weeks of exposure. What is said, it's basically an abnormal response to the virus. Basically, in view of their similarities with Kawasaki disease and similar diagnostic entities where there is an inappropriate immune response actually. But what they've also found that it's a distinct phenotypic presentation, not exactly like a Kawasaki disease or other types actually. And exact reason why it causes abnormal immune response is still not well understood, but what we think is basically a post-infectious process is triggering this possibility, has been documented by epidemiological studies suggesting that children develops MES-C after about 2 to 6 weeks after exposure to the patient with COVID or developing a COVID infection actually. That's where it all boils down to suggesting that it could be a post-exposure immune dysregulation causing this problem. So coming to the clinical features, the most important clinical feature is persistent fever. It's been seen in almost 100% of the cases. Gastrointestinal symptoms is another most important, like abdominal pain, vomiting, diarrhea, seen almost practically like in 100% of the patients. Rashes, mucocutaneous rashes is more important. There could be sore throat, myalgia. There could be edema of the limbs. There could be non-purulent conjunctivitis. So basically season is like that any child who comes with a conjunctivitis, it's not simple viral conjunctivitis. You need to keep a possibility of MES-C in pediatric patients. Lymphadenopathy could be there in these patients. You also find significant neurological abnormality in the form of headache, lethargy, confusion, could be encephalopathy, it could be meningoencephalitis, or even it could be seizures actually. There have been studies which have come out with basically looking at neurological disturbances in a patient who developed COVID-19 actually. And the respiratory system in the involvement in the form of pneumonia, or it could be ARDS in the severe forms. And of course, what we're talking about MES-C is basically boils down to cardiac involvement, where you find there could be left ventricular dysfunction, coronary dilatation, pericarditis, or arrhythmia is also very common in these patients. Patient can have shock or hypotension. There could be acute kidney injury, there could be serositis, there could be hepatitis, or simple hepatomegaly. So what is left? So practically when you talk about clinical feature of MES-C, there could be multi-system involvement. As the disease itself points out, multi-system inflammatory syndrome, you expect it to look at some or other manifestation of every system in the body. So these are some of the observations from few studies done in the first wave, where they found that approximately every patient had the fever actually. Fever is one of the most important presentation must be there was there in all the patient. As I also pointed out, gastrointestinal symptom was also seen in almost about 60 to 100% of the patient. Rash was again common, conjunctivitis seen up to almost about 80%, and you could see that there was other symptoms are also present in varying the severity. And then of course, you look at that myocardial involvement is was close to about 90%. That's where we think very strongly in terms of MES-C as a manifestation of cardiac disease actually. So if a patient comes with MES-C, you need to really keep a close watch on the myocardial dysfunction, arrhythmias, And you also look at that Kawasaki disease, either criteria for complete Kawasaki disease was met in almost about 64% of the patients. Close to about 76% of the patient had shock in this study, and there was significant amount of liver involvement, serositis, and kidney disease also. And say now, coming to the diagnosis, we will take up later, differential diagnosis. One of the important differential diagnosis we look at in this background is basically Kawasaki disease. Kawasaki disease for all pediatricians has been a known entity, as we discussed sometime, that it's one of the important diagnoses you must consider in a child who comes with persisting fever beyond more than 5 days and other clinical features. So that must be entertained in all this patient. But what is important to remember is that in this COVID season, possibly Kawasaki disease could be a manifestation of MES-C. And severe COVID is one of the differential diagnoses. How do you differentiate is basically if a patient has got acute manifestation with RT-PCR positive, possibly it's more of an acute severe COVID rather than MES-C. And as it's already been discussed also, bacterial sepsis is one of the important differential diagnoses in this patient. Toxic shock syndrome is an important one. And many times people have missed out appendicitis by not identifying this patient, giving more weightage to that. One of the important manifestation is gastrointestinal symptoms. In that, basically abdominal pain is one of the major manifestation where people have admitted, managed as a MES-C, and later they found the child is not responding, and they found that perforated appendicitis and operated actually. So a lot of things have been identified in the background of MES-C where patient has been thought to be MES-C, admitted, and new diagnoses have emerged actually. So people have identified a bacterial sepsis, people have identified enteric fever, peritonitis, appendicitis in all these patients where MES-C was a diagnosis. It means to say these are some of the important differential diagnoses you must keep in mind when you are looking at a patient with MES-C actually. It's also been that you look at other viral infection. If there is a more of a respiratory symptom, you're going to look at adenovirus, cytomegalovirus, influenza virus, parainfluenza virus. Those also need to be looked at. And people also looked at there is an association between or maybe an overlapping between vasculitis and SLE also, though they are less common. But in our setup, possibly need to keep a very close watch on Kawasaki disease, bacterial sepsis, toxic shock syndrome, and appendicitis. These are some of the important one is supposed to look at as a alternative diagnosis before or excluding them actually. So Kawasaki disease, for those who already know it, it's fine. Those who need to know a little more about it, basically, if a child presents with a fever lasting more than 5 days, one of the differential diagnoses we always entertain is Kawasaki disease. Without any other explanation, combined symptoms, basically, if 4 or 5 of these things are present, possibly you are going to look at as basically it's a Kawasaki disease, like in the form of bilateral bulbar conjunctivitis, oral mucous membrane changes in the form of injected or fissured lips, red tongue and cherry tongue and red mouth is one of the important manifestations. Peripheral extremities in the form of erythema of the palms and soles is an important thing. There could be edema, there could be desquamation. It's classic of the Kawasaki disease in the second week of presentation. Polymorphic rash also could be seen in these patients in the abdomen. They're very transient, disappears very early, and there could be cervical lymphadenopathy. So if you have bulbar conjunctivitis, mucosal involvement, polymorphic rash, peripheral hands and feet involvement, cervical lymphadenopathy, possibly you are dealing with a case of a Kawasaki disease. So if you find any of these symptoms, possibly it indicates Kawasaki disease. But what is important to remember is that in all this situation, when this presentation, there is a possibility of a concurrent infection. It's important to make sure that we rule out all of them before judging them as possibly a case of Kawasaki disease. So coming to what exactly you differentiate between Kawasaki disease and MES-C actually. So if you look at few features which possibly helps in differentiating, MES-C is basically seen in older children and adolescent as per as the available literature till now, published literature, but we are also seeing that MES-C could be seen in neonatal age group, so basically that eliminates that possibility of age group actually. But as per as Kawasaki goes, is basically seen in young infant and children. Gastrointestinal symptoms are very common in patients with MES-C, but are less common, practically not very common with Kawasaki disease. You don't entertain a Kawasaki disease with gastrointestinal symptoms. Basically, we look at as basically as an atypical Kawasaki disease or an incomplete Kawasaki disease. Myocardial dysfunction we are talking about so much, including shock, is more commonly seen with MES-C rather than Kawasaki disease. In Kawasaki disease, basically it's a coronary involvement rather than ventricular function defect actually. So where you see you do echocardiogram, you see changes in the coronary, it goes classically with Kawasaki disease. Except in Kawasaki disease with severe disease where you find a ventricular dysfunction, otherwise it's not very common. Inflammatory markers could be elevated in both one, but it's extremely elevated in patients with MES-C compared to the Kawasaki disease. And one of the important things which could help you in making either it could be Kawasaki disease or a MES-C is basically looking at platelet count. In patients with Kawasaki disease, what you find is thrombocytosis. You see platelet count running in 4 to 6 lakhs, maybe 10 lakhs, something like that. But in cases of MES-C, it's more of thrombocytopenia. That's how it helps in making a diagnosis. And coronary disease, as we know that it's very common with Kawasaki disease, but it's also been noted that in patients with MES-C also, there is reasonable amount of involvement, almost close to this one, Kawasaki disease. You may not be easily comparable. Of course, we know that in a patient with MES-C, in addition to coronary artery involvement, there could be significant ventricular dysfunction that goes more in favor of MES-C actually. And what is more important in consideration of the diagnosis is the serology or evidence of the COVID-19 test in this patient actually. If a patient has got either a serology positive or an exposure positive, unless otherwise proved, it's a case of a MES-C rather than Kawasaki disease. Even in a patient who has got a clinical features strongly suggestive of Kawasaki disease, if serology comes positive, it's supposed to be COVID-related disease rather than a Kawasaki disease itself. So that's how we're supposed to differentiate. I think basically over the next 2 months, it will be easy for us to really make a diagnosis and treat MES-C or even a Kawasaki disease. But as the time goes, when the load of Kawasaki disease comes down in the community where we start looking less and less, then we will really have a difficulty in finding whether it is MES-C or Kawasaki disease. One of the reasons that's important basically as far as therapeutic intervention goes, there is some difference in the way we manage Kawasaki disease and MES-C. That's where it's important to really you put your mind to understand what you are dealing with. So coming to the investigation, I'm sure it's been highlighted yesterday also, today also. There are a lot of guidelines have come up across the country and elsewhere. The guidelines have come up from AIMS, PGI, and we have guidelines from Vellore, guidelines from Bangalore Medical College, Ramaya Medical College, everywhere. What people have found, there are list of investigations which are possibly required to be done in patients with Kawasaki disease, or with MES-C. So what they found that, is it necessary we do all these tests, or is it necessary we can stagger them and do it? In an adult patients, we know that when patient comes to the COVID care, there is a list of tests to be done, and only patient deteriorates, we do some tests. Practically, there is a battery of tests. It's been well prescribed, and we know that when we are suggesting what tests to be done for the patient, it's been taken care of. But in pediatric patient, it's not necessary that we go as it's been recommended for adults. There is some variation. We are going to reduce certain tests what we are doing in the day-to-day practice in the pediatrics. So what we do is basically could be divided into Tier 1 test where we do initial test, and if required, then we go to Tier 2 test where we do much more inflammatory markers and cardiac evaluation and other things. So what does it comes to basically in the Tier 1 test, you are going to do complete blood count. You do serum electrolytes. CRP is an important component of the diagnosis. ESR, you are going to do it. Liver function test may be done in this patient. Blood gases, you are going to do it if required, if patient is in having respiratory distress. Of course, we may do SARS-CoV, RT-PCR or serology. Why is supposed to do this test in the Tier 1 test actually? If a patient comes with a MES-C-like syndrome, why is supposed to do RT-PCR in this patient? Yeah, one of the differential diagnosis in this patient is a severe COVID actually, right? I remember recently in one of the place where a patient comes with a status epilepticus, had fever, admitted to management and in the ICU setup, and basically RT-PCR came as positive actually, right? Patient was shifted to COVID ward, we started managing, and all the inflammatory markers gone up, and practically the consultant who was covering that patient thought whether it could be MES-C. So even IVIG was given to that patient. Almost 13, 14-year-old child with severe COVID, and even IVIG was given. Basically, there was no reasonable explanation why IVIG has been given. As I'm trying to understand and tell you that in the season of MES-C actually, people start looking at whether it could be that also. What I'm trying to clear at this point of time, If you find an RT-PCR positive with a clinical symptom, whatever you have seen in the patient, suggestive of MESI or incomplete features, possibly you are dealing with a case of a severe COVID, not a MESI. As per as available literature says, most of the patients who have been diagnosed of MESI had serology positive. Close to about 60-80% of the reports suggested they're all serology positive, not antigen positive, not RT-PCR positive. So suggesting that, as we already told in the introduction itself, MESI is a post-infectious inflammatory manifestation of a disease process where the disease occurs after about 2 to 6 weeks after exposure or an infection actually. So where is the question if you're finding RT-PCR positive actually? You have discussed in the last more than a 24 hours time now. When do you look at RT-PCR? When do you look at antigen test? When do you look at serology? It makes it very clear if a patient comes with RT-PCR positive, it's possible a case of severe COVID-19 where you are going to treat them as per that actually. You are not going to give IVAZ in those patients actually, right? So we do RT-PCR. If you find it's positive, you'll shift to the COVID side and manage accordingly. But if you find serology positive, it's basically a case of MESI. That's very important. That's why serology has been part of Tier 1 investigation actually. So after this scanning, if you find CRP elevated, it's supposed to be seen in almost 100%. It's more diagnostic as per as pediatric diagnosis and MESI goes. If CRP is elevated, ESR is elevated, in that case, possibly the suspicion increases. And if you find any one of these things, like if there is a presence of at least one of these things, if there is a neutropenia or reduced absolute leukocyte count, less than 1000 per milliliter, actually it could be a low platelet count, less than 1.5, or if serum sodium is less than 135 milliequivalents per liter, or if it's hypoalbuminemia, less than 3.5 grams per liter. So if you find elevated CRP, and ESR, if you find either one of them, either neutropenia, lymphopenia, thrombocytopenia, hyponatremia, or hypoalbuminemia, that possibly you are dealing with a case of MESI. That's how you make a diagnosis. So that's where you suspect the patient, admit the patient, and then look at subjecting the patient for Tier 2 tests actually. So what does it include, the Tier 2 test? You are going to reconfirm the serology of SARS-CoV-19. It's also been found that in a patient who are typically fits with MESI actually, the report can be negative initially, or it may turn out positive when you do subsequently. There is a scope for repeating the test, so you have to redo it. And you're going to do inflammatory markers like procalcitonin, coagulograms like PT, APTT, D-dimers, fibrinogen, and interleukin-6, all could be done in these situations. And of course, most importantly in this patient is to do cardiac evaluation. ECG is an important component. Of course, it's been observed to great extent as far as pediatric goes, but in MESI management to require an ECG, you require an echocardiogram compulsorily. You required cardiac markers like BNP or troponin 1T must be done in these patients. You also need to keep in the mind that, as we are discussing, repeatedly stressing upon the point that you need to look at tropical infection in all these clinical settings, because we see more of tropical infections becoming the casualty in the season of COVID-19 actually, and also with the MESI. So it's important to investigate for sepsis, important to investigate for dengue, scrub typhus, leptospira, malaria. Now we know that July onwards up to maybe close to end of October and November is a season for dengue, right? Fortunately, last 2-3 years, it's been really great years where there was no much of dengue fever, but we also know that dengue comes in the waves actually. After every 2-3 years, it goes to a peak and it becomes really very severe. It could be possible this year, there could be chances that there is a severe concern with respect to dengue also. So we start seeing patient of MESI, we also start seeing patient with dengue fever. It's very important to make sure that we keep an order very clearly. We need to investigate and delineate whether it's MESI or it's case of dengue fever. We know that in dengue fever, management is absolutely none. Right? We don't give anything other than fluid, no platelets, no steroids, nothing we give it actually. But if you make MESI, practically, we try everything. So it's important, in all these patients, you must investigate for tropical infections. So this is one of the flow diagram to look at how to go about. If you have a patient who comes with fever lasting more than 3 days, if he has got epidemiological link suggestive of exposure to infection like COVID-19 infection, and if there are clinical features suggestive of MESI actually. So in those patients, you need to look at possibly whether you're dealing with a MES-C. If you think it's possibly a case, the next thing you're supposed to look at is, let me see whether I can. Yeah. So if you find any of those things, persistent fever, evidence for linking to COVID infection, and clinical feature suggestive of MES-C, basically, you see whether there is any alternative diagnosis. In that case, possibly you go according to that. Or if you find there is a life-threatening situation, like in the form of hypertension, shock, or severe respiratory distress, then you need to subject the patient for both Tier 1 and Tier 2 test. That's what basically we do in emergency and critical care setting, where patient is very sick and there is already an hypertension and patient looks requiring ventilator support. We quickly do both Tier 1 and Tier 2 test. On the contrary, there is possibility of a MES-C, but child is not sick. You go for possibly a Tier 1 test only and see what happens, and then decide whether it's suggestive of diagnosis, and then you go for Tier 2 test. Otherwise, you don't have to do it. But say you see there is nothing to suggest patient is having fever, there is some exposure doubtfully, clinical feature not exactly suggestive of MES-C, then you monitor this patient and see what is the alternative diagnosis instead of considering MES-C actually. You got it? So if you have a clinical feature suggestive of MES-C, if you think there is an evidence of critical care illness in the form of shock, respiratory distress, or hypertension, you strongly consider do both Tier 1 and Tier 2 test, maybe as quickly as possible or together. Or if you think there is no life-threatening situation, maybe you can do only Tier 1 test and then decide whether to do Tier 2 test or not. But say on the other side contrary, if there is no clear evidence of MES-C despite patient running eye spiking or significant fever, you look for alternative diagnosis. But what is important point in this place is that in all children in this season with suspected MES-C, you need to consider that you need to watch over next few days whether he's going to develop other clinical features suggestive of the diagnosis. You may also consider redoing the test after some time actually. So it's going to be a little bit tricky, but what we are supposed to understand, every child who comes with fever, he has got some other systemic symptoms, possibly there is a possibility of MES-C, you need to work up those patients. So these are some of the observations from documentation. What you could see that there could be lymphopenia almost close to 100%, neutropenia is also there in almost 100%, thrombocytopenia obviously has been important feature, and you see C-reactive protein was there almost up to close to about 100%, even ESR was there almost up to close to 80%, D-dimers was there in all patients, same thing with fibrinogen, and even ferritin procalcitonin seen close to about 3/4 to almost 100%, and that's how it indicates why these tests have to be done in assessment of MES-C also. And looking at cardiac markers, there has been troponin and BNP has been seen close to about 90% of the patients, suggesting that it's important we look at those parameters. Even hypoalbuminemia was seen almost close to about 50 to 95%. And you may see elevated liver enzymes, lactate could be there in some patients. So this is basically summary of some of the tests being documented in the studies where if you have a patient suggestive of MES-C, there are a lot of clinical laboratory parameters go suggestive of diagnosis of MES-C. That's how we need to include them. So coming to the basics now, chest radiograph. We know that there has been a lot of debates, controversies, discussion as per as chest radiograph versus CT scan. And we know that all the CT scan machines which are lying idle for over the years has been doing brisk business now actually. And practically don't get slot for doing CT scan for a normal patient. It's so bad actually. But as far as pediatric COVID and pediatric MES-C problem goes actually, we don't recommend CT scan as a diagnostic entity in these patients because you don't find anything different than what you see in the X-ray. So on the X-ray also basically one of the important observation is that most of the patient had some moment of pleural effusion. That's one been outstanding in this patient. There could be some moment of patchy consolidation, focal changes, it could be atelectasis. In a very severe form, you may find ground glass appearance. But what's also important to remember that most of these children may have normal chest X-ray also. Echocardiogram. It's one of the most mandatory tests. Whom you do, whom you leave out is a big question actually. If a patient comes with suspected COVID, MES-C, you need to consider echo as one of the important diagnoses. As I discussed already, if a Tier 1 investigation is supportive of the diagnosis, echo must be done in all the patient at admission itself actually. So what we look at in this patient, you need to look for qualitative and quantitative assessment of LV function and size, assess for the right ventricular functions. You also look at coronary artery status and dilatation and aneurysms. You look at for valvular functions. You also assess for the pericardial effusions. You also look at any evidence of thrombosis. One of the important observation in MES-C is that apical thrombosis in severe left ventricular dysfunction. That's a classic as far as MES-C goes. That's one of the most strong indication for starting anticoagulation therapy in this patient. So echo test is one of the most important tests, must be done at admission if the inflammatory marker suggestive of the diagnosis, and you go from there actually. And these are the normal things you find. Depressed LV function is classical of patient with MES-C. That's what I'm trying to tell you. In a patient with Kawasaki disease, more of a coronary disease, but here is more of ventricular dysfunction. Coronary aneurysms and dilatation could be seen in this patient, but it's more of LV function that you must keep it in mind. There could be mitral regurgitation, pericardial effusion. These are the common ones you find you need to echo in this patient. ECG. As I told, it's been again like basically we don't really consider ECG in pediatrics, but it's important to remember in a patient with MES-C that with a cardiac involvement, there is a big risk of arrhythmias in this patient. ECG must be done at admission and also be done at regular interval all through the course in the hospital, and maybe even after discharge if there is a clear evidence of cardiac involvement, because they are at risk of developing arrhythmias actually. You may find a non-specific changes in the form of ST and T wave changes, and you also find maybe the atrioventricular block. There could be arrhythmias in these patients. You may find an abdominal X-ray suggestive of non-specific, maybe some free fluids, ascites. There could be ileitis, mesenteric adenopathy, or adenitis, or there could be pericholecystic edema. Very classical report you find in a dengue season, right? Any patient to send them for ultrasound, whether they find anything else or not, whether serology comes out positive or not, but ultrasound suggests there is an edema around pericholecystic area actually. So it's classic, could be seen in these patients also. They're all basically non-specific thing, but what I was trying to tell in the earlier thing that appendicitis is one of the misdiagnoses in this patient. You must really tell the people who are doing the studies that they look for evidence of appendicitis and ileitis in these patients. So this is again stressing upon, it's very important, make sure that you do a lot of microbiological tests, but what is important to remember, so I am stressing upon so many times, it's not as it's like that. Though infection has to be looked at very clearly, it's important to make sure that you are not going to do as a battery of investigation like blood culture, urine culture, stool culture, panel of respiratory viruses, throat culture in every patient to come with suspected MES-C actually. In a patient with MES-C, basically you choose the investigation as per the clinical presentation. If the patient has respiratory symptom, you do a respiratory panel workup, including sore throat, you do a throat swab, you do the viral parameters, otherwise it's not required. Blood culture, of course, is required in all these patients to decide antibiotics, you do it, but urine culture, stool culture, any other test must be decided as and when required, otherwise it's not required. One of the important observation done in the studies is that if a patient has got either EB virus, cytomegalovirus, adenovirus, enterovirus, if any of them is positive in a patient who has got respiratory system, if serology also comes positive, or if serology is not being questionable, it doesn't rule out MES-C as a diagnosis, nor it rules out a COVID-19 diagnosis in this patient. So what it means to say, even in patient with COVID-19 in children, even in patient with MES-C, there could be a possibility of isolation of these viruses in this patient, doesn't really support or negate the diagnosis or therapy in this patient. That must be kept in mind. So in bottom line is that you need to do microbiological test to identify organism. That's also important making for diagnosis and also to therapeutic decision, which we are going to discuss later. So coming to the treatment, let me open up for some kind of discussion now. How many of you have possibly have come across a lot of MES-C in your practice till now actually? Quite a lot. Yeah, quite a few of them, right? So I would like to ask you now, what exactly the treatment given? Supportive, wonderful. Steroids? What is that? IVIG also. Again, IVIG business has gone up like anything, right? It's not available in the market. Practically every drugs associated with COVID care and post-COVID care practically out of stock actually. All in the cold market. right? So it's so bad. So it's wonderful actually. I think few of you have seen the case, it's fine, but practically in places like Mumbai, Delhi, maybe most of Maharashtra, the MES-C has been seen by large number of pediatricians and treating doctors, but we have less exposure. Maybe we started seeing only now only actually. So looking at the diagnosis and the treatment protocol actually, as the diagnosis itself says, the multi-system inflammatory syndrome. It's basically management is a multidisciplinary care actually, where it starts with a pediatrician, you end up with the intensivist, then you add up cardiologist, rheumatologist, hematologist, nephrologist as and when required. So 2-3 people who are important in the management is pediatrician, intensivist and cardiologist, and of course rheumatologists are going to be in short supply as far as managing MES-C goes actually, right? We had one rheumatologist yesterday, remember? Dr. Sagar Bhattad is possibly only pediatric rheumatologist in Bangalore as of now what we understand. So the rheumatologist will have a significant role to play in the ICU actually. So, but what about rest of the people? Now the whole training program is to train each one of you to manage COVID-19 and also to manage MES-C, right? So basically the pediatrician that has to be replaced by any doctor is going to be part of the care actually. It could be pediatrician, it could be physician, it could be anesthetist, it could be any other specialist who are going to manage the MES-C situation will be the primary caretaker, and of course will be supported by intensive care setup actually. And we're looking at what is required for managing MES-C in population load in India, in Karnataka and Bangalore. A lot of discussion is going on actually. And we remember possibly we need close to about 60 to 70,000 pediatric ICU beds in Karnataka or maybe Bangalore itself actually. That's the volume of expectation as far as preparation goes. As we remember, as of now, maybe we have about maybe altogether in Bangalore maybe around 150, 200 beds, around 300 beds in the best scenario. And across the Karnataka maybe another 300. Unlikely maybe medical colleges have some beds, otherwise there are no beds available. In the event of we are going to see the MES-C being an epidemic or a pandemic in the country, it's going to be hell as far as availability of the bed actually. But we're only hoping that as per looking at the first wave and also in the second wave, most of the pediatric affected patients are mild disease or an asymptomatic. They don't end up require this support. But even in that situation, the requirement for intensive care beds is a massive in this situation. But you also remember that like we prepared BAEC and other setups in providing facility for COVID-19, it's not possible to prepare pediatric ICU actually. It's going to be a serious challenge for BBMP and also for Karnataka government to provide intensive care setup. So that's going to be a situation where it's really going to be a concern as far as managing this patient. But let me tell you, is it really going to be that voluminously difficult for us actually? Say if you see 100 cases of MES-C actually, if there are about 80 to 90% require an intensive care setup, then it's going to be hell actually. But so on the contrary, if about close to about 50 or 60 or even 70% of this patient can be managed effectively outside the ICU care setup possibly, we are going to manage them very effectively actually. That's what we are going to look at in the next few slides. So where do we admit? I was just going through the literature. 3 options are available for admitting this patient. The most important one I want to ask you, every one of you now that we are already in the grip of MES-C, is it possible to manage MES-C on the outpatient basis? Is it possible? Very interesting. Possibly no. Let's see. Is it possible to manage in the ward? Yes, absolutely possible. Of course, most of them may require ICU care also. So we are going to decide in the near future where to admit the patient. I was just going through the literature where the recommendation says the patient walks with a clinical feature suggestive of a MES-C. Inflammatory markers are marginally elevated, hemodynamically stable, could be even managed at an ambulatory services only. It's not necessary that every patient required to be admitted in the hospital. If you look at the COVID, lockdowns, you remember when patient turned out to be positive, if there is RT Nagar one case, whole RT Nagar was closed actually, right? Then comes to a stage, volume becomes so much, if somebody is positive, we started closing the roads actually. Then it comes if somebody is positive, only house were used to stick and go actually. Now it comes to the stage if somebody is positive, the neighbor doesn't even know he is positive. right? So practically now, people are living, coexisting with COVID positive ones, and of course, people are also moving around to the market also. That's the current situation of lockdown and quarantine as far as COVID-19 goes. So I am looking at a situation where if MES-C is going to persist for a longer time with the exposure and experience and confidence of managing this patient, we are come to a stage where most of this patient can be managed at a ward level or ambulatory. It means to say the focus of managing MES-C will be shifted from intensive care setup to all the other setups where you need to basically refer only sick patient to the ICU and critical care areas or high dependency area. Most of the patient could be managed in other setups actually. So, where do you admit the patient to the ICU? Any patient who comes with a hemodynamic instability like shock, respiratory distress, cardiac involvement, neurological involvement, evidence of Kawasaki disease, if patient has got severe dehydration and abdominal symptoms, if there is an evidence of acute kidney injury, hepatic injury or a coagulopathy, all these patients must be admitted to high dependency area or ICU actually. These are the same patient we regularly admit to the ICU, isn't it? Any patient who come with these symptoms, we are already admitting to the ICU, same protocol goes to suspected MES-C also. What is important here is to understand from the study which we looked at here actually, they have analyzed. Most of these patients who admitted with these patients were not admitted to the ICU. They were managed in the ward, admitted and given therapy in the ward, and practically what they found that 60 to 80% of them were shifted to the ICU subsequently. So it means to say there could be some window of opportunity to manage them earlier stage in the ward, but possibly we end up shifting to the ICU at some point of time. That's what we are looking at where pediatric intensive care research is going to be really going to be a concern as far as bed availability and treatment. We also know that luckily we have reasonably good amount of pediatric intensivists actually. That's one of the best thing that could be happening as of now. There are a lot of training programs both from RGHS, our chapter from various universities. There is quite a good number of trained people, at least in major cities there are people available, but in the rural areas it's still going to be a concern. But we know that as of now these cases are referred to major center. Some hope is there for this patient. So what we do in this patient in the ICU, recognize and treat shock. You are careful about fluid administration. Dr. Supraj already spoke to you on that. We are not going to touch up on that. You need to look at close early monitorings, may require intubation and ventilation, optimize proper oxygenation, and make sure that you use inotropes and vasopressor appropriately. And we know that some may require even ECMO support. Those things are also easily available in Bangalore as of now. So this is the bottom line. As per as specific therapy goes, we have choice of using IVIG or prednisolone. The true situation comes here, as we are discussing already, when patient with MES-C comes, either patient is in a life-threatening severe illness or the child is in not life-threatening illness which could be managed little more comfortably. So what is the recommendation now? Again, bottom line is that all these clinical features may be part of tropical illnesses we normally see. You rule out those things and then look at what to do. What it recommends, if you are seeing a patient who is not having a life-threatening disease, you start on pulse methylprednisolone therapy. The dose is about 10 to 30 milligram per kg. Give it intravenously for about 3 days actually. I repeat once again, pulse methylprednisolone therapy 10 to 30 milligram per kg intravenously for 3 days, right? Then followed by you change over to subsequently equivalent prednisolone dose that comes to about 2 milligram per kg per day. Give over 2 to 3 weeks and then taper in the same process actually, right? So use methylprednisolone as the first line of therapy in a patient who are not very sick, and consider IVIG as and when required if patient deteriorates or if there is a concern. But one thing you could remember, it's also affordability is a concern. But here it's basically exploitation comes as per as using IVIG. Normally I don't recommend in a stable patient to go with IVIG. We can manage with methylprednisolone itself. Keep IVIG for only sick patient. And all these patients could be started on aspirin 3 to 5 mg per kg per day, and then continue all this patient because there is a risk of thrombosis in this patient, require antithrombotic therapies in this patient. You had enoxaparin 1 milligram per kg subcutaneously BD for about 5 days, and then where you're supposed to basically target to keep factor 10A up to about 0.5 to 1. The facilities available, and you need to look at coronary aneurysm score, thrombosis, and look at left ventricular ejection fraction. If it is below 35 in all these patients, you need adding enoxaparin as a therapy. It means to say one of the bottom line is giving that therapy in this patient. Every patient with COVID, either mild or moderate, required to be put on aspirin. They required to be put on possibly enoxaparin if there is clinical feature suggestive of coronary involvement, thrombosis risk, and there is a left ventricular dysfunction. That's one of the important things you're supposed to remember. On the contrary, if patient is sick actually, patient is very severe, required to be in the ICU. In this patient, we are in the form of shock, coronary disease, multi-organ dysfunction. In this patient, all patient need to be in the ICU. There is no question of managing this patient outside. You start them both methylprednisolone, IVIG in this patient. It's not either methylprednisolone or IVIG. It's supposed to start both methylprednisolone and IVIG. The dose differs significantly. Methylprednisolone is going to start in the dose of 1 to 2 milligram per kg per day. It is not 10 to 30 milligram. It's 1 to 2 milligram per kg per day. IVIG give about 2 grams per kg over 24 to 48 hours. So that's how we're supposed to give. You give both of them in this patient and see the response. Of course, you're supposed to treat them with antimicrobial therapy that we are going to discuss again later, right? So if you have a patient with severe disease, you use both methylprednisolone and IVIG together and then see what could be done. One of the bottom line here is that we are talking about patient who has got shock, coronary disease, and multi-organ dysfunction where you have to use both of the things. But again, highlighting that if patient doesn't have any of those things actually, like the previous slide, use either IVIG or methylprednisolone. But we understand the difficulty with affordability of IVIG. Methylprednisolone itself is good enough in managing this patient, and we go with a dose of 10 to 30 mg per kg. That's not 1 to 2 mg. That's the pulse methylprednisolone therapy you are going to use in this patient. So what we do now, either patient is having a mild disease or a severe disease. If patient doesn't respond, what is the options actually? In both the situation, recommendation is to go with IVIG. If you already use IVIG, use a repeat bolus IVIG in these patients, and you can use a high dose of methylprednisolone 10 to 30 mg per kg for 3 to 5 days. So here it comes. The question here comes, if you're already having a mild disease which deteriorates, already received 10 to 30 milligram per kg of methylprednisolone pulse therapy, patient deteriorates, are we going to use again 10 to 30 milligram per kg is a big question. But of course, we are going to add up IVIG in those patients. But patient is already sick where you have used steroids only in 1 to 2 milligram per kg, you are definitely going to increase to 10 to 30 mg per kg in addition to the IVIG in this patient. In patients who are not responded to either IVIG or plus methylprednisolone, you have a choice of using tocilizumab, anakinra, and infliximab. Basically, these are monoclonal antibodies and interleukin antagonists. Basically, must be decided in consultation with rheumatologist actually. Availability, I don't know, but definitely BBMP is going to make it available for everyone in the system, will be available. Basically, when these things fail, you could consider using these drugs actually. Otherwise, as of now, what the literature available doesn't talk much about. As such, not a recommendation as a matter of policy, as a considered as a backup for where IVIG and corticosteroid do not work, use them actually, not as an add-on drug, right? So again, aspirin has to be continued, enoxaparin has to be continued. As we discussed earlier, you need to continue again after discharge also in this patient, right? So once you start steroids, you change over from methylprednisolone to prednisolone. That has to be tapered over a period of 2 to 3 weeks. You basically are going to relook at CRP counts, maybe other markers like D-dimers, others may be required to be done, and then you are going to decide. One of the important inflammatory markers, D-dimers, has been one of the most exploited thing. It's not been regularly recommended for pediatric follow-up or a therapeutic thing. You don't need to do that actually. But CRP is one of the important thing. Of course, it's an orphan investigation is supposed to be done in all these patients. The next question comes with respect to the echocardiogram in this patient. In all patients with cardiac involvement, once you do echo at admission, then you do as frequently as per required as in the clinical scenario. But in a patient who has got a mild disease, you need to repeat once after 48 hours and see what happens. And once again, maybe before discharge to confirm that it's not there. And then maybe you can do again once after 1 to 1.5 months later. And in a patient who has got an involvement, it's supposed to be also be done after a year to see what is happening to this patient. This is basically protocol done for Kawasaki disease. A patient who develop a coronary disease has to be put on quite significant duration of aspirin, and we modify based on the changes that happen in the aneurysms and the repeated echoes actually. If they started improving, We start tapering. If persisting, we will go for 3 to 6 months and then decide. So again, at 1 year, we're going to repeat and see that indicates possibly what is the risk of this child is having, future risk of instant or maybe young patient suffering from myocardial infection. One of the important differential diagnoses, somebody suffering from Kawasaki disease actually. So that's why it's important. We ensure that the risk of aneurysm goes off with a proper steroids and the aspirin therapy. And Dr. Supraj has already discussed, there is a few concerns in the management of fluid in this patient. She already told, we have a situation where it become a fluid refractory shock actually. Patient may respond well, there is no issue, or else there is a possibility of fluid refractory shock where you can't give much fluid, but you need to go with inotropic support. In those situations, as it's already been pointed out, epinephrine appears to be reasonably better choice compared to norepinephrine, but can be added up later. And especially if the patient has got left ventricular dysfunction, it's going to be the drug of choice as per as choosing the inotropic support. It's also been found that the patient has got a left ventricular dysfunction, it's not really been improving, BP is not improving with epinephrine alone. Milrinone plays a significant role in backing up epinephrine in improving the patient. That's one of the recommendation. Regarding the fluids, the initial stage may be managing like any other patient with shock, but once you realize that is a cardiac involvement, you need to be clear about fluids. You're not going to rush up with lot of fluid, rather you need to go with inotropic support and support the patient. And it's also important to remember if patient has got severe disease, cardiac involvement, shock, use fluid, patient is not responding, you have to go with even Lasix infusion in these patients. That we're going to discuss later. Antimicrobial therapy. We are all experts in using antimicrobial therapy. I don't so much to discuss, but it's important to remember that you give, this is one of the situations I strongly recommend broad spectrum antibiotic therapy in these patients. You go with a ceftriaxone, as it's already been pointed out. Vancomycin is another choice to cover up for staphylococcus in these patients, and of course clindamycin. So these things you can start with: ceftriaxone, vancomycin. Clindamycin could be initial drug of cocktail. Subsequently consider piptazo and maybe meropenem also, actually in a very severe patient. That's the way to go forward. If anyone has different thing, we can discuss later. So this is supposed to discuss, but what is important is to remember, you need to send all the cultures in this patient. If the culture suggests there is no bacterial infection, there is no need to continue antibiotic. So maybe after 48, 72 hours, once you get cultures, there is no evidence of infection. And if patient is also stable, possibly whatever inflammatory markers you are seeing is part of MIS-C, you don't need to continue antibiotic. But only question is there. One is dare enough to stop antibiotic? That's an individual question. Basically, it requires a lot of strong thinking and conviction that I'm not managing infection, I don't need to give antibiotics. Otherwise, people just used to give a course of cocktail for a week or so, that goes, but otherwise, you can consider stopping antibiotic if you are strongly convinced that there is no evidence of antibiotic requirement in the patient. This is what I'm telling you, the cardiac dysfunction, fluid is a concern. There is going to be fluid refractory shock. Be careful about fluids. You need to monitor this patient with repeated echo. That's what we are going to do in this patient. You also need to repeat the cardiac markers continuously to see the response. And what is important in this patient is that in all patients with cardiac involvement, an early steroids and corticosteroid therapy and basically IVIG must go in this patient. And what is important is to continuously monitor for arrhythmias. Though it's not been highlighted as per the protocols goes, arrhythmias is a lurking problem in this patient. You must continuously monitor for the arrhythmia in these patients actually. As I already discussed, you start with adrenaline, add up milrinone, then they consider adding up dobutamine and maybe dopamine also. And there is also requirement for ECMO in certain very severe patient where despite all this inotropic support, patient doesn't have a pulse, doesn't have palpable BP, practically looks cold limb, you could consider ECMO actually. So in the facilities where ECMO is available, what one can do, alert the ECMO team earlier only so that they get ready to accept the patient. And it's been basically a temporary arrangement to provide cardiac rest and support. It's available in quite a lot of places in Bangalore now. One must explore that. So only limitation for ECMO is the cost. It may cost close to about maybe 2 lakh rupees per day. It's a big concern. Otherwise, it's doable. Then respiratory support may require ventilator support. And what we important to remember, all patients require antithrombotic therapy, all require aspirin, enoxaparin. And all patients with prior thromboembolism, LV dysfunction, aneurysm require a continued therapy for a longer time in these patients. And this is the discharge follow-up. So once patient recovers, you can consider tapering the medicine and see that what can be done. So you follow up afterwards, maybe 1 to 2 weeks, maybe again 4 to 6 weeks. Do repeat CRP and echo in the follow-up. Actually look at also neutrophil lymphocyte ratio, which are good predictors of the response in this patient. ECG has to be done in the follow-up to look at what's happening in this patient. Echo we already discussed is much required in this patient. Actually, it must be done in all the patients. So this is one of the flow diagram from PGI. Of course, it's available to you. There is a lot of things are available. You can look into those things actually. So in summary, basically it's a rare complication, but it's as of now is a concern. We are going to prepare, we are preparing for that. There is a definite set of criteria to make a diagnosis, nothing much to worry on that. Cardiac and coronary involvement is a serious concern. You need to work on them, and that's where you are going to decide on the therapy. And of course, you need a multidisciplinary approach. Steroids and IVIs are going to be important therapeutic options. And of course, mortality is significantly high in this patient, in a severe patient. Otherwise, I am looking at a situation with evolving and new literature coming from abroad that a lot of patients are recovering well. So what is making difference? Early initiation of steroids and IVIG actually. The studies have also conducted looking IVIG alone with steroids and only steroids actually. What they found that patients who have been managed with a combined therapy had a much better response where the patient had quickly recovering from the fever, improvement in the basically the ventricular functions, shorter ICU stay, much hemodynamic instability. So as far as severe COVID MIS-C goes, it must be treated with both with IVIG and steroids. But otherwise, in a milder ones, you can do away with basically a pulse methylprednisolone therapy. So with this, I would like to once again express my sincere thanks to all of you. It's a lunch time, and I'm sure there is a lot of things to learn. There is scope for questions. Maybe we can open for a minute or so. We can take up anyone if you can answer question also. Thank you. Just leave them for a minute or so. Yeah. Lung ultrasound, basically what you find in this lung is basically either some amount of pleural effusion or some infiltrates, doesn't going to add up anything much to the care. So only thing required is X-ray, good X-ray. So normally as of now practice is to give for about 5 days and then change over to the oral medications for a period of time. Aspirin has to go for a longer time, maybe some 3 months, that's mandatory. Yeah. So that's what I told actually. If a clinical picture is suggestive of MES-C, if an inflammatory marker is suggestive of MES-C, but child looks stable, it's basically a mild case. The recommendation is there, instead of waiting for it to develop further thing, you treat them with high dose of methylprednisolone therapy. If you remember what I told, basically in the patients with severe MES-C, basically we go with a low dose steroids actually. In a patient with mild disease, we go with a pulse methylprednisolone therapy, where you give 10 to 30 mg per kg. So you need to give that actually. High dose of methylprednisolone is mandatory. One of the observation is that why it's supposed to be given. All patients who develop clinical features and initial laboratory features suggestive of MES-C, they're expected to go through the course of MES-C actually. If they're stable today, they may deteriorate over a period of next 2-3 days actually. That's the reason why high dose steroid therapy is strongly recommended in this patient. Only thing what we have to look at, maybe with personal experience you can learn over a period of time, is steroid alone is enough or I need to use IVIG. That's what is the discretion you need to use, otherwise steroid is mandatory. Severe COVID and MES-C, practically you know that one important point is basically that it presents sometime later, right? Basically in a patient with MES-C, it's a post-infectious situation. In a severe COVID-19, we discussed yesterday also, basically present with symptoms basically warrant significant respiratory illness, require respiratory support and shock, that's the treatment. On the contrary, look at MES-C is more of a cardiac disease actually, coronary disease. Respiratory symptoms or a disease is not very common. Rather, in most of the patient, X-ray was also reasonably normal or a patchy pneumonia where you don't require to put them on support. If at all, if they require ventilation is more for shock rather than respiratory thing actually. If patient has got inflammatory marker strongly suggestive of a severe disease, a severe respiratory illness, and with acute presentation with acute exposure history, it's more of severe COVID-19, not MES-C. right? I was telling you an example where one place where in a severe COVID-19 somebody has used IVIG. People can do things like that, but practically it doesn't work. Yeah. So we give a dose, one dose in 1 or 2 days, maybe if required one more dose. IVIG, it's a high dose IVIG, 2 grams per kg is a massive dose actually. We don't give over a days, 1 or 2 doses only actually. Yeah. Mucormycosis, yeah. There are few cases reported in pediatrics also. There is something in the newspaper also that they found it in Bangalore Medical College, that new Vajpayee Medical College also, right? Yeah, it's there. But practically the reasons for is something different. Because mucormycosis is already there, we have read through our undergraduation, all through we know it actually. Why it's happening now? It's not necessarily steroids. If that were to be the case, the children with nephrotic syndrome should have been at high risk of developing mucormycosis. It's not happened actually. Patient with immunodeficiency or patients with cancer therapy should have been there. It's not happened actually. Something else is working on that. Risk is definitely there. As of now, there are not adequate support or data to suggest how it's happening in the pediatrics, but may happen actually. And as of now, not much guidelines are available managing as far as pediatric goes, but adult it's plenty.
So most of the children they do present with pain abdomen, vomiting and nausea.
Yeah.
And you said appendicitis is one of the differential diagnoses. Nowadays we have seen that more than 100 people, they had intestinal necrosis and they had to undergo resection. Mesenteric ischemia is also one of the common. Have you come across? So how do you differentiate intestinal mesenteric ischemia if at all we come across?
See, basically,
Using steroids and anticoagulants also. If this is a presentation, how do we go about it?
see, if a patient comes with an acute abdomen-like presentation, it's quite obviously acute abdomen, right? That's what I'm telling. Even if a patient comes with severe fever where a MES-C is strongly suspected, if patient has got a significant abdominal symptoms in the form of pain, you must strongly suspect either appendicitis, that's what is more common in the pediatrics, or maybe in, like you are telling, in the adults it's more of intestinal issues actually. Both are possible, but in pediatrics it's more of appendicitis. That's how it goes actually. But otherwise, both is possible. Both is possible. Acute abdomen, it has to be looked at. And only way to look at it's not a exploratory laparotomy, it's only ultrasound actually, right? You do an ultrasound, find it out and treat accordingly. Yeah. Yeah, very interesting. That's what I missed out telling actually. See, that's one of the differentiation is supposed to keep it in mind. One bottom line at this point of time, maybe over the next remaining 6 months of this 2021, right? Possibly every case who comes with a clinical feature suggestive of Kawasaki, MES-C is a possibility. If you see MES-C, basically what we discussed. Say for example, in this situation, if serology comes negative, imagine classic Kawasaki disease, serology comes negative, then what is supposed to do? That's a concern, right? What we do in these patients, basically we give IVIG. Say if you look at severe MES-C, they also recommend IVIG actually. But here we also know that if you use in a patient with severe MES-C, you use IVIG plus steroids actually. And then you look at how the patient responds. If patient has got a Kawasaki disease, except in severe Kawasaki disease syndrome, shock syndrome, it's a very small portion of Kawasaki disease where it presents similar to severe MES-C, where there is a significant ventricular dysfunction, where you find it difficult. Otherwise, most of the patients with Kawasaki disease are basically refers to coronary issues only, coronary dilatation, aneurysms, and those things. You don't find them in shock actually. So in those patients, you're supposed to treat with IVIG and then go with aspirin, nothing else. But it requires a lot of thinking in case-by-case basis where to fit the case actually. If serology comes negative, you remember so many cases of dengue fever, we started using that serology negative dengue fever, right? Dengue-like illness. It's going to be a situation like that where you have to make a decision actually. It's going to be a serious concern in the day to come, but judgmental is the issue whether you are going to use IVIG with steroids or only IVIG. After that, of course, you have to continue them on steroids for a longer time, it's going to be same. Right? Yeah. Strongly recommended. Every patient with MES-C, as I told, it's a course where if you find the clinical picture and the investigation suggested MES-C, over a period of time you are expected to go down actually, right? In all these patients with the kind of inflammatory markers happening, there is a risk for thrombosis in this patient. It is strongly recommended for all these patients with MES-C, they must be put on the medication. See, D-dimers is very interesting thing. Basically, maximum accepted 10 times the elevation actually. Anything less than that, it's a borderline where you decide how to go about. If it's gone beyond that, it's mandatory to go on actually. If you find a D-dimer more than 5 times, you put them on the therapy actually. There's no need to wait on that. Even without D-dimers being there, you need to start an aspirin immediately, right? If it's high, you add up an enoxaparin also. It's necessary, right? Only reason because you miss out on the thrombosis in the left ventricular dysfunction patient, they end up with severe catastrophic events. You have to avoid that. Yeah. Anything else? Think about, there's plenty to think. Again, I would like to express sincere thanks to Dr. Prashant, Dr. Saraswati. You had a wonderful arrangement. I think we are doing a lot of preparation across the country. And what we could understand, this is one of the earliest one we do it actually. And hope if BBMP takes up and supports, there won't be a lot of children will be saved from the MIS-C actually. So once again, sincere thanks to all of you and have a wonderful day. Thank you.
Please be seated. 1 second. Few important announcement. Thank you, Karnakar sir, for that elaborate messages. Now I request Prashant sir to give their words about few words about the gather.
Hello, good afternoon everybody. I won't keep you too much time from your lunch. Even I am hungry. Okay. See, the only point I wanted to emphasize now is that we know why we are doing this workshop. It's mainly because of in anticipation of COVID, and let us leave that question mark whether it's going to happen or not. Knowledge is not going to fail you anytime, so take it as positively that you are gaining some knowledge, whether it is for COVID or not. Shock, ventilation, CPAP can be used in other situations also. So this is a learning experience for all of you and for us also. I mean, even I learned a lot from today morning with this excellent faculty giving such good talks, and it was really refreshing to remember so many things which we have not been doing routinely. To begin with, the reason I wanted to talk 2 minutes is the workshop which is happening today. There are few people who are responsible for it. And because of the forethought and vision that tomorrow, if the COVID third wave comes, how our doctors should be prepared rather than doing it at the last time, in the last minute. To avoid that, this was planned. There are some people who are very much responsible for it. Main is Dr. Shiv Kumar, who is the Chief Medical Officer, and Dr. Saraswati, Dr. Banu Prakash. Please give them a big hand. The amount they worked for this program is, Saraswati is sitting at the back. I think they have put in a Herculean effort to arrange this, and we should really be very, very grateful to the NIMANS administration, director, registrar, and our PRO, Mr. Chetan, who were so friendly and who were so welcoming when we came last week for the first time, because we had forgotten this physical conferences. We didn't know that whether it will be available, whether we can do. So we came with so much of anxiety and jitteriness, but they put us at ease and they said, don't worry sir, we'll arrange everything. You don't have to think. They gave us the audiovisual, they gave us the YouTube streaming, everything has been done by NIMANS. Very, very grateful thanks to NIMANS. Please give a big hand to them. And in most of the programs, there are a lot of people who will be behind the screens, who will never come in front. For this program, there was one person, one lady who was behind the screen who never came, though she was here for a brief time yesterday. Madam Tulsi, she is the Finance Commissioner of BBMP South Zone. If she had not taken the initiative and sanctioned the required amount to get all these things done, I don't think we would be having this program. And also the Joint Commissioner, Mr. Veerbhadra Swami. These are the two people in the top management of BBMP who have taken very positive role to get all the doctors prepared for this program for the COVID third wave. And also we have Dr. Veena, who is a Deputy Director of Health and Family Welfare, who was responsible for sending all the government doctors for the training. And last but not the least, I would also just say thanks to our Fisher and Paykel, General Electric, GE, and Roban Meditech, who are all arranged the workstations for you. The important thing which I wanted to tell now is after lunch, we are running just half an hour late, but after lunch we'll be having a couple of lectures which will be finishing quickly. After that, we have 6 stations which have been planned. Now the 6 workstations will be, you have the intubation and oxygen delivery that will be done by Dr. Raghunath and Dr. Karnakar. We have the ventilation that again probably they will be interchanging there, so you'll have the faculty for ventilation. And we have the non-invasive ventilation, HFNC and CPAP, management of shock and neonatal resuscitation. So there are actually 6 stations, but you can divide amongst yourself. We don't want too much of crowding, okay, because of the COVID protocol. So try to divide amongst yourself, and around 15 or 20 people. That's why we have kept it in the open hall. You can stand very far from each other. And also it will be YouTube streaming also will be happening of the workshop, and it can be seen on that also. So any doubts, or can we go for lunch? Okay, fine. Let's go for lunch. Thank you. Thank you so much.
ಹಾಕಿ ಚೆಕ್. ಇಲ್ಲ ಬರೀ ಇದ್ರಲ್ಲಿ ಪ್ಲೇ ಮಾಡ್ತೀನಿ. ಅಲ್ವಾ?
ಓ ಸರ್ ಇದು ನೋಡಿ ಸ್ಕ್ಯಾನ್ ಮಾಡಿರೋದಕ್ಕೋ ಓವರ್ಲ್ಯಾಪ್ ಆಗ್ಬಿಟ್ಟಿದೆ ಹೆಂಗೆ ತೆಗೆದು
ಸರ್ ಇದಕ್ಕೆ ಓಪನ್ ಮಾಡಿ FI ಅಂದರೆ ಫುಲ್ ಸ್ಕ್ರೀನ್ ಬಂದುಬಿಡಿ.
ಬರ್ತಿಲ್ಲ
ಅಲ್ಲಿ ಬಂದರೆ ಯೂಶಲಿ ಅಲ್ಲಿ ಚೇಂಜ್ ಆಗ್ಬಿಡುತ್ತೆ.
ಇಲ್ಲ ಟೇಕ್ ಇಟ್ ಔಟ್.
ಸರ್ ಒಂದು ಸ್ಲೈಡ್ ಬೇರೆ ಮಾಡಿಬಿಡಿ.
ಇಲ್ಲ ಎಲ್ಲದ್ರಲ್ಲೂ ನನ್ನ ಮಾರ್ಕಿಂಗ್ಸ್ ಇದೆ.
ಅಯ್ಯೋ
ನಾನು ಐ ವಾಂಟೆಡ್ ಟು ಡೂ ಇಟ್.
ಅಂದರೆ ಸ್ವಲ್ಪ ಇದಾಗ್ಬಿಡುತ್ತೆ. ಆಮೇಲೆ ಇದು ಯಾವ ಇದು ಇಂಪಾರ್ಟೆಂಟ್ ಸರ್, ನೀವು ಯಾವುದ್ರಲ್ಲಿ ಮಾಡಿದ್ದೀರಾ?
ಕರೆಕ್ಟ್.
ಇದು ಲೋಯರ್ ವರ್ಷನ್ ಇದ್ದರೆ ಪ್ರಾಬ್ಲಮ್ ಆಗ್ಬಿಡುತ್ತೆ ಸರ್. ಇಟ್ ಇಸ್ ಅ ಪ್ರಾಬ್ಲಮ್.
ಸುಮಾರಿದೆ, ಐ ಟೇಕ್ ಇಟ್ ಔಟ್. ನೋಡಿದಲ್ಲ ಚೆನ್ನಾಗಿದೆ. ನಾನಿದು ಆ್ಯಕ್ಚುಲಿ ಮಾರ್ಕರ್ ಥರ ಯೂಸ್ ಮಾಡಿದೆ ನನ್ನ ಲ್ಯಾಪ್ಟಾಪ್ ಬಂದಿತ್ತು.
ಸರ್ ನಿಮ್ಮದು ಅಲ್ಲಿ ಕರೆಕ್ಟಾಗಿ ಕೆಳಗಡೆ ಬಂದಿದೆ, ಇಲ್ಲಿ ಮೇಲೆ ಬಂದಿದೆ.
ಇಲ್ಲ ಮೇಲೆ ಮಾಡಿದ್ದು ನಾನು.
ಬಟ್ ಇದು ಕಾಣಿಸ್ಬೇಕಲ್ಲ.
ಕಾಣಿಸ್ಬೇಕು ಆ್ಯಕ್ಚುಲಿ.
ಹೌದಲ್ಲ.
ಅಲ್ಲ ದಿಸ್ ಈಸ್ ಡಿಫ್ರೆಂಟ್ ಸಾಫ್ಟ್ವೇರ್.
ಯು ಯೂಸ್ಡ್ ಇನ್ ಐಪ್ಯಾಡಾ?
ಐಪ್ಯಾಡಲ್ಲಿ ಬರ್ತಾ ಇಲ್ಲ ಇದು.
ಯಾಕಂದ್ರೆ ಐಪ್ಯಾಡಲ್ಲಿ ಮಾಡಿದ್ರೆ ಮಾತ್ರ ಇದೇನೋ ಕಿರಿಕಿರಿ ಮಾಡಿಬಿಡುತ್ತೆ.
ಕರೆಕ್ಟ್. ನಾನು ಅದಕ್ಕೆ ಐಪ್ಯಾಡ್ ತೊಗೊಂಬಂದರು. ಐಪ್ಯಾಡಲ್ಲಿ ಇಲ್ಲ ಅದು ಆ್ಯಕ್ಚುಲಿ.
ಓಕೆ. ಇದು ಕಂಪ್ಯಾಟಿಬಿಲಿಟಿ ಮಾಡಬೇಕು, ಅದೇ ವೆರಿ ಇಂಪಾರ್ಟೆಂಟು.
ಪೆನ್ ಡ್ರೈವಲ್ಲಿ ಇದೆ.
ಪೆನ್ ಡ್ರೈವಲ್ಲಿ ಇದೆಯಾ ಸರ್ ನಿಮ್ಮದು ಆ್ಯಕ್ಚುಯಲ್ ವರ್ಷನ್ ಇದೆಯಾ ಸರ್?
ನೋಡ್ತೀನಿ.
ಅದಿದ್ದರೆ ತುಂಬ ಕನ್ವಿನ್ಸ್ ಮಾಡಬೇಕು.
ಪೆನ್ ಡ್ರೈವ್ ಡೈರೆಕ್ಟ್ ಹಾಕೋಬೋದಲ್ವಾ?
ಹ್ಞೂ ಸರ್.
ಎಲ್ಲೋಯ್ತು
ಸರ್ ಬಂದಿತ್ತು. ಹಾಂ ಬಂತು. ಏನಾದ್ರು ಒಂದು
ನೋಡಿ ಬಂದಿಲ್ಲ. ಇಲ್ಲ ಇಲ್ಲ ಬಂದಿಲ್ಲ. ಅಂದರೆ ನನ್ನ ಲ್ಯಾಪ್ಟಾಪಲ್ಲಿ ಬಂದಿದೆ.
ಹ್ಞೂ ಸರ್.
ಎರೇಸ್
ಲ್ಯಾಗ್ ಆಗುತ್ತೆ,
ತೊಂದರೆ ಇಲ್ಲ. ಅಲ್ಲಿ ಎರೇಸ್ ದಿಸ್
ಮಾಡಿ ಚೂರು ಲ್ಯಾಗ್ ಇರುತ್ತೆ ಡೈರೆಕ್ಟಾಗಿ ಮಾಡಿದ್ರೆ ಇದರಿಂದ.
ಪೆನ್
ಡ್ರೈವಿಂದ ಮಾಡಿದ್ರೆ ಯಾಕೆ ಹೆಂಗಿರುತ್ತಲ್ಲ. ಅಷ್ಟೊಂದೇನು ವಿ ಆರ್ ನಾಟ್ ಇನ್ ಹರಿಯಲ್ಲ. ಅದಾದ್ಮೇಲೆ ಬಂದು ನಾನು ಡೈರೆಕ್ಟ್ ಪೆನ್ ಡ್ರೈವ್ ಹಾಕ್ಬಿಟ್ಟು ಮಾಡ್ತೀವಿ. ಇದ್ರದ್ದು NRP ಅವೈಲೇಬಲ್ ಎವ್ರಿ.
ಇದು ಪ್ರಾಬ್ಲಮ್ ಅಂದರೆ ನನ್ನ ಲ್ಯಾಪ್ಟಾಪ್ ತಂದು ಇದು ಮಾಡಬಾರ್ದು ಅಂತ ಗೊತ್ತಾಗ್ತದೆ. ನಾನು ಯೂಶಲಿ ಮಾರ್ಕರ್ ಮಾಡ್ತಿರಲಿಲ್ಲ.
ಸರ್ ಕಂಟ್ರೋಲ್ ಕೊಟ್ಬಿಡಿ, ಈಗ ಸೇವ್ ಆಗ್ಬಿಡಿ. ಆಮೇಲೆ ಕಟ್ಟಾಗುತ್ತೆ.
ನೋಡಿ ಇದು ಬಂದಿದೆ.
ಇದು ಕ್ಲೀನಾಗಿ ಬಂದಿದೆ. ಎಸ್ ಸರ್, ಹೈಲೈಟ್ ಮಾಡಿದ್ದೀರಾ ಅದು.
ಇದು ಹೈಲೈಟ್ರ್ ಇದು
ಹೈಲೈಟರ್ ಅದು.
ಇಲ್ಲ ನನ್ನ ಲ್ಯಾಪ್ಟಾಪಲ್ಲೇ ಬೇರೆ. ನಂದು ಇಟ್ಸ್ ವಿಂಡೋಸ್ ಯಾವುದೋ ಏನೋ ಗೊತ್ತಿರಲ್ಲ ಅದು. ನಾನು ಐ ಥಾಟ್ ಇಟ್ ವಿಲ್ ಕಮ್ ಅಂದ್ಕೊಂಡೆ. ನೋಡಿ
ಇದು ನೋಡಿದ್ರೆ ನೀವು ಸ್ಕ್ರ್ಯಾಚ್ ಮಾಡಿ ಇವೆಲ್ಲ ಡಿಲೀಟ್ ಮಾಡ್ದಂಗೆ ಆಗೋಗ್ಬಿಟ್ಟಿದೆ. ಹೈಲೈಟ್ ಹೋಗಿದ್ರೆ ಉಲ್ಟಾ ಆಗೋಗ್ಬಿಟ್ಟಿದೆ. ಅದು ತೆಗಿಲೇಬೇಕಾಗುತ್ತೆ. ಸದ್ಯ ಮುಂಚೆ ನೋಡ್ಕೊಂಡಿರುವ ಸರ್ ಪ್ರೆಸೆಂಟೇಷನ್ ಮುಂಚೆ.
ಐಪ್ಯಾಡಲ್ಲಿ ಇಲ್ಲ. ಐಪ್ಯಾಡ್ ಕನೆಕ್ಟ್ ಮಾಡೋಕ್ಕಾಗಲ್ಲ ಅನಿಸ್ತಿದೆ
ಸರ್. ಇದಿದೆಯಾ ಅದಕ್ಕೆ ಒಂದು ಕನೆಕ್ಟರ್ ಬೇಕಲ್ಲ ಸರ್? ಏನೋ ಇದೆ ನೋಡಿ, ಅದಕ್ಕೆ ನಿಮ್ಮದು ಕನೆಕ್ಟರ್ ಇತ್ತು ಅಂದರೆ ಕನೆಕ್ಟ್ ಇತ್ತು.
ಇಲ್ಲಿ ಬಿಡಿ ಆಲ್ಮೋಸ್ಟ್ ಮುಗಿದೋಯ್ತು.
HDMI ಕೊಟ್ಟಿದ್ದಾರೆ ಇಲ್ಲಿ.
ಇಲ್ಲ ಬಂತು.
HDMI
ಸೇವಿಂಗ್ ಇಲ್ಲನಾ?
ಕಂಟ್ರೋಲ್ ಸೇವ್ ಮಾಡ್ಕೊಂಡ್ರೆ ನೋಡು ಯಾವ್ದಾದ್ರು ನೋಡಿದ್ರೆ ಸರ್ ನೀವು ಆನ್ ಎನಿ ಕೇಸಸ್.
ಸರ್ ಅರ್ಲಿ ಇನ್ಫ್ಯಾನ್ಸಿ 44 days ಫೀವರ್, ಎಕ್ಸೆಸಿವ್ ಡ್ರೈಕ್.
ಒಂದೇ ಒಂದು ಬೇಬಿ 28 days ಬಂದಿತ್ತು.
ಲಾಸ್ಟ್ ಮಂತ್ ಬಂದಿದೆ, ನನಗೆ ಗೊತ್ತಾಗಿಲ್ಲ. ನಾನ್ ಪ್ರಿವೆಂಟ್ ರೇಟ್ ಆಫ್ ಇಂಟುಬೇಷನ್.
ಓ ನನಗೂ ಆ ಥರ ಬಂದಿಲ್ಲ. ನನಗೆ ಆಲ್ ಆರ್ ನ್ಯೂ ಬಾರ್ನ್.
ಲಾಸ್ಟ್ ಮಂತ್ 5 ಬಂತು.
ನನಗೆ 5 ನ್ಯೂ ಬಾರ್ನ್ ಬೇಬೀಸ್, ಮದರ್ ನೆಗೆಟಿವ್, ಬೇಬೀಸ್ ಆರ್ ಪಾಸಿಟಿವ್.
ನನಗೆ ಆ್ಯಕ್ಚುಲಿ ಐ ನೆವರ್ ಥಾಟ್ ಆಫ್ ಇಟ್.
ಅದೇ ಆಗಿದೆ ಇವಾಗ ನಮ್ಗೆ. ಇವಾಗ ಟು ರೀಥಿಂಕ್.
ಸ್ಟಾರ್ಟ್ ಮಾಡಿ. ಶೋರ್ ಇಲ್ಲ.
Good afternoon, everyone. We are left with only two didactic sessions, one by Dr. Prashant and the other one by Sharat Chandra. Both are related to neonatology. So to begin with, we have we have Prashant, who is speaking on MIS-C in neonates. Something rare, we are not seeing much of it, but still something which we cannot ignore. Dr. Prashant is well known to me for almost past 2 decades. He's a neonatologist. He is working at Rainbow Hospitals, Hebbal. He is a consultant at Rainbow Hospital, Hebbal. Prior to that, he was at MS Ramaya Medical College as assistant professor and consultant neonatologist. Currently, he is working in Rainbow, Hebbal. And I thank him for accepting our invitation. And I'd like to call him on to start his lecture. Thank you, Prashant.
Good afternoon, my dear senior colleagues, BBMP doctors, government doctors, Dr. Prashant sir, who is my senior and also a mentor, for providing me an opportunity to speak on a very new subject, which we have, I think, rarely seen for the last 2 years. The word itself was coined very recently, that is MIS-C in neonates. So if you look at the incidence, once I elaborate on few of the clinical symptoms, then we might realize retrospectively that have we seen cases of MIS-C in neonates. So that becomes, I was also wondering last week that have I seen a MIS-C in neonate? Probably yes, few of the MIS-Cs in neonates and early infancy were seen by us, did not pick up. The reason was it was a new disease, the symptomology was new, it was not a serious illness. Ultimately, most of the newborns who had these symptoms did recover and are healthy now. So I think all of us from my last 2 days, we are in a brisk workshop and learning that about expecting a third wave. All of us have a habit of expecting something very nice. This is, I think, one of the few occasions that we are expecting something wrong. So third wave, any wave which is related to illness, healthcare sector, creating misery for the community, including the children, is definitely devastating. So there are a lot of paper articles on, are we expecting a third wave? Will it affect pediatric group? Will it cause mortalities, morbidities in the age group? There's a huge number of paper articles. This is started only last 1 month when there was a fall of cases in the second wave in the adult population. So look at this. These are all paper articles. So these are few of the articles which did make all of us to think about the third wave existence and its relevance of in affecting the pediatric population. So there are a lot of scientists who gave a statement. There's a new research which came up saying that it might not affect. So basically, it affects, it doesn't affect is secondary. As a medical graduates, medical scientist, it is our bound duty to learn what is going to happen in the future, keep us ourselves ready in managing the children if at all we have a third wave which is affecting pediatric and neonatal population. So learning becomes mandatory even though we might get it or might not get it. So if you look at the textbook of Nelson, this is around 1999th edition, the coronavirus chapter is only 6 lines. So not even one paragraph. Look at where we are after 20 years, that we are reading hell lot of books, we are having books on COVID virus, infections and all this. So we never knew it. Even it happened with the same with the dengue. In 1997 with the Nelson, dengue fever was only a page of article. Now we came across for last 2 decades, huge number of articles. We did study well, we did manage well. So COVID is one infection which is going to create, probably has created havoc in adults. Will it create a problem in neonatal group? Let us have it in next 20 minutes. We will try to wind up. So MIS-C in neonate is a new term which was coined probably only 90 days before, which when I checked it, it was in the Feb of 2021, MIS-C-N was coined, that is multisystemic inflammatory syndrome in the neonate. This is termed to be the very rarest form, which is approximately less than 2%, and usually occurs 2 to 4 weeks after the acute COVID infection. So neonates are born, are asymptomatic or might be symptomatic. they are recovered well, and most of these come after 2 to 4 weeks with the symptoms of MIS-C. MIS-C, and if you look at the origin of the MIS-C in neonatal period, there is a new term also. I think I saw this term a month back. That's called perinatal COVID, and the next one is neonatal COVID. So the origin of MIS-C neonate can be a neonatal infection, or it can be a perinatal infection. So there was a lot of discussion on neonatal. How does a neonate gets affected with COVID, and how does it progress into MIS-C in neonates? If you look at that, the neonate can get infected anywhere between day 3 of life till day 28 days of life. That's an acute COVID infection. Around 70 to 85% of the neonates do not have any symptoms. There can be only 10% of them who will have 1 or 2 episodes of low-grade temperature or fever, 1 or 2 episodes of vomiting. Ultimately, 95% of them recover without any issues. When it comes to around 5% of the children or newborns, that is when it comes with a vague symptomology. The symptomology includes fever for more than 3 days, cough in a newborn who is around 3 weeks, poor feeding, lethargy, irritability, vomiting. Very rarely we see mucocutaneous rashes. Aspiration of milk is another very common finding, especially if the newborn is having severe cough. Shock and sudden infant death syndromes are very rare. There are only 3 cases reported of SIDS because of MIS-C. And if you look at the symptomology, most of the symptomology looks like a bacterial sepsis in newborn. So this is a very mimicky of bacterial sepsis, which all of us have treated successfully in the previous years. So we need to put it up in a very straight words. Any symptomology, either from the fever till the shock, we'll have to suspect MIS-C because of we are having an acute COVID wave for the last 1 year. So please keep a wide suspicion of MIS-C in neonate if the following symptoms appear. So the second point which I would like to tell is, how do we say that newborn can go into an inflammatory response? If you look at, there can be a history of COVID positive mother in perinatal period with RT-PCR positive or rapid antigen test positive. If you look at that, most of the, again, coming to the obstetric case, if you look at if you ask the obstetrician, they do a routine screening test of RT-PCR in before delivery. So some of them are diagnosed to have COVID positive, acute COVID infection with mild symptoms, asymptomatic or moderate symptoms. Ultimately, successfully they have delivered in the right time, and most of them go home with absolutely no symptoms. So there is no rule that a postpartum MIS-C in the delivered mother is a predisposing factor of neonatal MIS-C. So there is absolutely no evidence. So we should practically think that any obstetric mother or a mother who is pregnant who has had acute COVID infection after 28 weeks to 32 weeks can have an continuing infection or can give up the infection to the newborn, which can cause a neonatal COVID. The second important is, has the newborn acquired infection in the hospital setting, which is also very common when I think all of the doctors here have treated n number of COVID cases. So there are COVID cases, there might be COVID virus in us as a carrier, we can be carrier. So if we deliver a obstetric pregnant woman, we might transmit the acute COVID virus into the newborn. So the transmission can happen at the delivery place, hospital, from nurses, from pediatrician, and definitely from family members. So we need to keep our options wide open that acute neonatal COVID infection is existing. Fortunately, with God's grace, most of the newborns are asymptomatic and the recovery is absolutely fine. So these are one of the group of newborns who can present as MIS-C in newborn period or early infancy. That can be up to 8 weeks of life. They can present as an acute COVID syndrome. So there are 2 issues here. The acute COVID infection itself can continue as MIS-C. So there is no absolute rule that there has to be a gap of 2 to 6 weeks to show it as a MIS-C. So we'll have to think in all the way. A newborn who is infected on first week of birth with COVID virus can become asymptomatic for 2 to 4 weeks and present as MIS-C after 6 weeks. That is one point. The second, a newborn who is infected on first week of life with COVID virus can get relieved for 4-5 days and come back with an acute inflammatory response, which itself will be called as MIS-C. So there is no absolute saying that it should have a gap of 2 to 4 weeks. Sometimes acute COVID syndrome itself can continue as, symptomatically continue as MIS-C. So what is perinatal COVID? As I said, any pregnant woman who is infected after 28 weeks of gestation, up to 42 weeks till the delivery time, there can be a perinatal COVID. So there was a lot of discussion. This word which I was searching for last 2-3 days, I did get few of the studies which did mention that there are chances of vertical transmission of the virus before delivery, during delivery, and after delivery. So after delivery, I've said it's a neonatal COVID. The vertical transmission has been reported in few of the cases, but in India we have never thought of it because there are so many deliveries. There are the newborns have not been presenting in that. These are all the Western data which did suggest that there is vertical transmission. So many a times we did hear, I think we have heard from a lot of our neighbors and friends that there was an IUD in a COVID positive pregnant woman. So there was unexpected complications in the newborn. Mother had COVID infection at 32 weeks. So these are all few of the detrimental factors of having an acute COVID infection in obstetric period. So the mother, pregnant woman can have a premature delivery, can have an intrauterine death, can suffer from hydrops fetalis, this is theoretical, can have thromboembolic episodes in fetus, can have acute COVID infection, neonatal COVID infection, and definitely can progress into neonatal MIS-C. So this is as a common slide in pediatric and adult population, even in the neonatal. So there is an infection here, the portal of entry is nasopharynx. There is a huge response, that's an innate response, which is an acute response. As soon as the virus enters the body, there is a mild fever, there is little lethargy, irritability, then the symptoms subside. After some days or 2 or 6 weeks, there will be a adaptive immunity which comes into the rescue. So that's an immune response for a virus. After the antibodies are synthesized or during the process of synthesis of COVID antibodies, the immune triggers. When there is a trigger, the whole trigger starts like this. Ultimately, that leads to multisystemic inflammatory syndrome. And it is common in adults also. So there is an autoantibody that causes the destruction of endothelium. That also affects the cytokines which are released, also affects the heart. Ultimately, the systems, the cytokines which are released into the circulation enters all organs of the body and start destroying the endothelium and epithelium of the vasculature. So if you look at the case definition, MIS-C according to WHO, even in neonate, is defined as fever with more than 3 days, and there is a clinical signs of multi-system involvement, and at least 2 systems should be involved. Classically in newborn, fever is a very unrecognized chapter, because most commonly we say keep the baby warm, keep the baby wrapped. So none of them advise a temperature monitoring in a newborn, at least till 4 to 6 months. So basically it becomes very important. Any mother who has got a COVID infection in the obstetric type, you should always advise them to purchase a thermometer, put the thermometer temperature chart and ask them to measure the temperature at least once in 3 days, once in 3 times a day. So that becomes little easy for us to evaluate. Otherwise, every baby in a tropical temperature like India will be wrapped so warm that temperature will be universally more than 99 to 100 degrees. So it becomes very important. In a pediatric population, adult, it becomes easy because it becomes a voluntary exposed symptom where they say that they have got fever. But in neonate, diagnosis of fever itself is a big challenge. Please ask the mother to measure temperature at least 8th hourly. So if you look at the case definition, as I think previously discussed, all the systems are involved, shock, hypotension, and mucocutaneous disease is one of the most common. I think a few of the practitioners who have seen the cases, I saw the first case of 3 weeks neonate with simple rashes, mild grade fever. Grandparent had COVID during the time of delivery. So we did expect that it was, must be there. We couldn't evaluate because the symptoms and signs improved so well within 3 days. We did start a simple paracetamol. That means the mucocutaneous syndrome is very common neonatal because that's a rash you can visibly see, and parents also do come to us with the immediate features of rashes. Cardiac dysfunction, respiratory system can present as viral pneumonia or post-viral syndrome. GI system, vomiting, diarrhea and hepatitis. Vomiting is one of the common feature in neonatal. So excessive vomiting, more than 3 times per day, even pre-feed vomiting, you should suspect that there is some kind of immunological syndrome. Hematological disease, which we commonly see in neonatal ICU after admission, coagulopathy, bleeding, thromboembolic phenomena. And most of the common site of thromboembolic phenomena in neonate is neurological thromboembolic phenomena. So some of the babies do present with focal seizures, very brisk, very fine seizures, and they recover. They recover as a general condition, but what remnant they leave is again we have to evaluate. So renal failure, most commonly they present as hematuria because we don't measure blood pressure in neonate as a routine. So they can present as acute renal failure, and oliguria and acute renal failure is very rare because it comes as very late. These 3 points are very important to diagnose MIS-C in neonate. The first is evidence of SARS-CoV infection in the neonatal or perinatal period. This is the most important, which most of us do get it. There are around 20% who are asymptomatic mothers or asymptomatic family members who might not say that they had COVID infection. That is when we go to the next step, get an RT-PCR, rapid antigen test or serology, and if there is a contact, any household member contact with COVID positive, these 3 things has to be picked up. Even if RT-PCR is negative, rapid antigen negative, which is very common in MIS-C, anti-SARS-CoV-2 antibodies, that's called spike protein S1, S2, has to be determined, which is usually positive in MIS-C, which is usually positive and also increased, more than 20 units per ml. So antibody test has to be done for the diagnosis of MIS-C. Even if it is more than 15, they say there is some kind of infection, other than the immunized. So anyway, pediatric population is not immunized. So any antibody presence with symptoms of fever, another 2 systems involved, we should diagnose as MIS-C. So this is how what we are trying to do. We have only known this, probably lesser than this. This is the tip of iceberg. The whole thing is hidden inside. Unfortunately, we shouldn't see this part. If the disease wanes off and doesn't affect children, I think it's by the God's grace that we have passed on the 3rd wave. But if at all, if we come across a 3rd wave which is affecting children, we are going to see the submerged eyes coming up with 1 and 1 symptoms. There can be many number of SIDS coming up. There can be many number of milk aspirations with spasmodic cough. So this is what we are trying to do. We are trying to diagnose in our own way of thinking. A big elephant, person who is seeing from front will see encephalopathy, person who is seeing from side we will see acute abdominal pain. So all these are again variable because it's a new subject. If you look at the spectrum of COVID-19 related multisystem, it can be simple mild illness, it can be febrile inflammatory state. Many times we come across child is having newborn is having more than 3 days fever, little rash, you start evaluating, you do some blood test, CRP is little high, you give 4-5 days antibiotic, we think it's an infection and baby subsides. Everything goes fine and we discharge them. So that's an acute inflammatory syndrome. Probably this is a mild variant. There can be another spectrum where it can present as a completely well-blown MIS-C, where they will have a systemic symptom like cardiac dysfunction, which is very difficult to manage in newborn period. So this slide is projected here to say that there can be no symptoms, there can be mild symptoms, there can be highly severe symptoms which has got a very poor prognosis. So this is only a depiction of the systems involved. As the name itself says, it is a multi-system inflammatory disease. It can affect from brain, head to toe. So there is one saying that there are some viruses like HIV which affects almost all the organs. Okay, it is becoming like this. It affects the dermatology, it affects the blood, it affects the GI tract, it affects the CNS, it affects the cardiovascular system, it affects the immunological system. I think all the systems are affected. Ultimately, this is one reason it becomes very difficult to manage. And there's a list of investigations which we have to go ahead. It's a big list. The problem is it is expensive. I was discussing with my friend Banu Prakash, is a very good friend of mine, my classmate. So I said, if we have to evaluate the whole sector of investigation, it will cost 65,000 rupees. Are we ready to evaluate completely is a big question. Are the parents can afford to evaluate, to do a lot of blood tests and get a diagnosis is also a big question. This is definitely not answered by me. I think if the government is, I think government has supported for the last 2.5 years, probably is going to support for this also. So these are expensive investigations. If you look at coagulation profile, it's expensive. Troponin I, BNP, interleukin 6 is 2,000 rupees, interleukin 10 is 3,500 rupees. Echo, ECG, platelet count, Z score for coronary artery diameter, blood culture, anti-SARS-CoV antibodies around 1,000 rupees. So if you look at the cost, we'll have to decide which baby requires what investigation as a baseline. Dr. Karnakar sir also said there is a tier 1, tier 2, tier 3 investigations. Let us follow that investigation even in this group so that we have a baseline, we have the second line, we have a third line investigations. So what will be the laboratory abnormalities in MIS-C in neonatal period? COVID RT-PCR usually is negative. So MIS-C in any age group, COVID RT-PCR or rapid antigen test will be negative. But SARS antibody will be positive, should be positive if that person is unimmunized. In adult, in pediatric anyway there is no vaccines. So any antibody that is spike antibody S1, S2, if it is more than 15 or 20 with symptoms, then we'll have to practically think that this is MIS-C of that age group. There can be leukocytosis, there can be thrombocytopenia. If you look at pediatric population, there is thrombocytopenia, mild. In neonatal period, there is thrombocytosis. So the platelets go as high as 10 lakhs or 1 million. So that is when the blood becomes thick. That is when the thromboembolic phenomena starts. So there can be lymphopenia, the high CRP, high caprocalcitonin, high ferritin. Hematuria is one common symptom which can present in newborn period. The most of the parents do come as get the child as there is a diaper staining with blood. That's how we have to suspect fever with diaper staining with blood. It should be suspected when we are suspecting a MIS-C in neonatal period. The altered liver function test can come as high SGOT. It should be in at least 500s, SGOT, SGPT. There is direct bilirubin. Very commonly, if you go back to the neonatal unit, we do see there is indirect jaundice, which is easier to treat. When it comes to direct jaundice, not reducing, we cannot give phototherapy for those babies. If we go back and reevaluate the things, does it really goes in favor of MIS-C in neonatal time, should always be thought. So we have to keep our minds open, think all possible way, because the virus is affecting every organ possible. And liver is one organ which is easily affected in the newborn period. The reason is that's one of the safeguarding organ of the neonatal time. That's one of the safest organ. Anything goes into the body, the toxic material, the virus, bacteria, everything sees the effect in that neonatal period. So liver is one organ which will show some kind of symptomology in the form of jaundice or increased SGOT, SGPT. A chest X-ray can show bilateral infiltrates. There can be prolonged coagulation factors, that is PTAPT is prolonged, fibrinogen is high, high D-dimer, high troponin high, and high natriuretic peptide. Hyponatremia and hyperkalemia is one of the common features in a sick child who has got a shock and hypotension. The last three are common, but these are the one which are done in level 3 ICUs and NICUs. They can be tachycardia, they can be heart blocks, so we'll have to do an ECG. Echocardiography has to be done if there is a shock and hypotension. That is the reason where we'll have to look into coronary artery diameter. If the diameter is increasing, that means there is a dilatation or aneurysm. So there is a Z score which is given, that is the ratio of platelet count with coronary artery diameter. So how do we manage? As we have classified, mild MIS-C in neonate should be admitted. So here we have two groups. One, milder forms. The next one is moderate and severe forms. In the pediatric age group, milder forms can be managed in outpatient basis or in the ward. In the neonatal period, we do not have an option of ward, so we'll have to admit in a basic NICU with base facility or level 1 NICU. So we'll have to, if there is a poor feeding lethargy, we'll have to start on IV fluids. Baseline investigations like blood counts and CRP has to be taken. Monitor the vitals, which are very important. SpO2 should be more than 95%. IV methylprednisolone should be initiated once the diagnosis of MIS-C is confirmed. That means we have mild MIS-C, one medication to be given, along with our IV fluids, glucose monitoring, calcium monitoring. The only medication, specific medication for MIS-C in neonatal period in the mild form is IV methylprednisolone. That can be given with a safe ventilator because unless we rule out infection, probably by the end of first day, we will have a CRP reports, we will have to send a blood culture. By then, we will be starting a broad spectrum antibiotic, then start the child with methylprednisolone, 1 milligrams per kg per dose, twice daily for 3 to 5 days. If the child is stable after IV methylprednisolone for 5 days, that is when, if the symptoms have resided, if the blood culture reports have come negative, I think we can plan to discharge with oral steroids, that is also for 5 days. Oral steroids, we do not have much evidence to give. We can have a dexamethasone as a once daily dose for 5 days. Moderate MIS-C, here the monitoring has to be the same as the mild MIS-C in neonate. So basically we have to admit this in level 2 and level 3 ICU. The most common symptom is respiratory distress syndrome, which will require a ventilation at least on CPAP. Neonatal pneumonia should be treated with baseline antibiotics. DIC should be thought of. So if you look at the incidence, it's around most common presentation in ICU with MIS-C is as a acute respiratory syndrome or acute viral pneumonia. And here the saturations are always less than 92%. There can be persistent tachycardia, which is one of the finest indicator of inflammatory response. So basically the heart rate of newborn is around 160. Usually, that's how normally 120 to 160 is a normal heart rate of a newborn. If there is an inflammatory response and if without fever, if the heart rate is more than 160 persistently for next 2 to 3 hours, you will have to suspect mild to moderate MIS-C because tachycardia is the finest symptom of inflammatory response. It is as fine as the blood investigations. So we have to think on close monitoring of the baby. There is no medications to treat, great medications to treat neonatal MIS-C, but the monitoring becomes the priority here. We'll have to, if the persistent tachycardia, then we'll have to get it as moderate MIS, send all the investigations, baseline investigation, send for fibrinogen coagulation profile, LFT renal function test, ask for an echocardiography. ECG might be a little difficult, but echocardiography can be done. Start with oxygen, CPAP, and ventilation of blood gas analysis. So how do we treat moderate MIS-C? In mild MIS-C, we have only one medication, that is IV methylprednisolone. In moderate MIS-C, we have only two medications, that is IV methylprednisolone and IV immunoglobulins. So mild there is one, moderate there is two, severe there is three. So basically these are the specific medications we have to ask for. Otherwise IV fluids are same, IV inotropes are same, IV antibiotics are same for all the three groups. So basically antibiotics try to avoid aminoglycosides, but we not know the functions of the kidneys in newborns. Start with simple cephalosporins, a 4th generation or 3rd cephalosporins. Treat the shock with crystalloids. Methylprednisolone dose is again 1 grams per kg per dose, twice daily for 5 days, slow infusion over 4 hours. Antivirals like remdesivir is not useful in MIS-C. So there is no point in running around for remdesivir, which we did it for last 1 year. So there is no point in running around for antivirals. So antivirals do not have any use, or the safety of the antivirals in newborn period absolutely not established. So don't worry about antiviral. The second medication which is recommended is IV immunoglobulin. This is a little expensive. It's around 2 to 3,000 per gram. So it can come up to 10,000 per dose, 10 to 15,000 or 20,000 per dose. But when do we start it? We'll have to start when the inflammatory markers are very high. For example, if the CRPs are more than 100, if the ferritin is more than 1000, if the the D-dimers are increasing in trend, that is more than 1000. That means there is a moderate to severe inflammatory response. That is when we'll have to start using IV immunoglobulin to suppress that immune response. The second important indications to start IV immunoglobulin is cardiac dysfunction. If the left ventricular ejection fraction is less than 65%, which you have to specifically ask the cardiologist. Cardiologist should say, we should ask what is the ejection fraction. If the ejection fraction is lesser than 65% with persistent tachycardia, then it is an absolute indication of starting IV immunoglobulins. That is because it should be suppressed with immunoglobulins. The dosage is 2 grams per kg over 4 to 6 hours. Very rarely it requires second dose. That is usually we should await till 48 hours. First dose, the response is extraordinary. So IG has been used in moderate to severe condition, but please use it when there is a high inflammatory markers and cardiac dysfunction. So treatment of severe MIS-C, as you have seen, there were 1 medication in mild, 2 medications in moderate, and 3 medications in severe. If you look at the third medications, when do we start anticoagulation? That's the third medication we use in severe MIS, along with first and second. When do we start anticoagulation? There's an absolute indication of starting anticoagulation if the D-dimers are more than 1000 nanogram per ml, if the Z score of the coronary artery dilatation is more than 2.5, and echocardiography suggestive of left ventricular ejection fraction less than 35%, please start anticoagulation. So there are 3 indications. So these 3 indications have to be absolutely do a checklist. If out of these 3, if there are 2 indications, please go ahead and start anticoagulation in newborn. Starting anticoagulation in newborn is a double-edged sword. If we start, what are the anticoagulation we use in adults? It's the same as which is used here. Antiplatelet, ecospirin and aspirin. As all of us know, aspirin can cause race-like syndrome in pediatric and neonate. So with that risk, with that consent, we'll have to start on anticoagulation. But there is no option. Since most of the hemoglobin of a newborn is little higher when compared to adult, so the thromboembolic phenomena is little commoner compared to adult. So it is a double-edged sword. We have to take a high-risk consent before giving an anticoagulant therapy. Anywhere, the place doesn't matter, but that medication is the same. So we have to take a consent, special consent, saying that this itself can cause bleeding, especially if you are using it in a lower weight baby or a small for gestation weight. So antiplatelet drug like ecospirin, which is available as 75 milligrams, should be given at the dose of 3 milligrams per kg per day. If there is a thrombocytosis, that is platelet more than 10 lakhs, the risk is very high of having a thromboembolic phenomena. So that's very important. Coronary artery diameter, if the ratio score is more than 2.5, that's determined by the cardiologist. We'll have to think that even a thromboembolic phenomena is going to be very difficult. So avoid aspirin if the platelet counts are less than 80,000, which is also very common. So we need to have a checklist before that. So continue the aspirin oral, that's a oral, till for 4 to 6 weeks. Monitor echocardiography. Then second anticoagulant is a low molecular weight heparin, that's enoxaparin. If the ejection fraction LVEF is around 35% less, D-dimer more than 2000, please start it. The dose is 0.75 mg per kg subcutaneous dose. Very rarely people, it's only a theoretical. So do start enoxaparin subcutaneous dose. Repeat D-dimer every 48 hours. Taper the dose as per the D-dimer level falls. So what are the predictors of MIS-C in neonatal period? I think it's almost arbitrarily done. Plus all of us are getting experienced with this. So we might add up few of the things after a year or 2, or we might delete few of the things. The most important thing is the coronary artery diameter or ejection fraction. If the coronary artery diameter is smaller the size, better the prognosis. Ejection fraction is consistently more than 50%, then the prognosis is better. And the next one is cardiac MRI. This is mentioned done in few of the newborns in Western nation. If we see a ventricular edema, fibrosis and scarring, the long-term outcome of the cardiac function is poor. That means most of them the newborns with this finding can go for a restrictive cardiomyopathy. So this is one thing we'll have to be careful. So we have to prognosticate. You might have to send them with diuretics when you are discharging, or you might have to send with the oral medications. So continuing the steroids for longer time after the inflammatory process has stopped will not help. We will have to stop steroids when there is an acute inflammatory response and it comes down. It is not inflammatory response is not continuous or chronic in COVID syndrome. It is only acute for 2 to 4 weeks. That is when we will have to give steroids, taper it quickly and stop it. The effects of what we see after that is the remnant of the, not the remnant of the disease, but the effect of the complications on the cardia. So we'll have to be careful. Do not continue using steroids for more than 4 weeks. No point, but the inflammatory response has come down. So please do not use steroids. So requiring steroids for more than 4 weeks itself is a poor prognostic factor. If there is a normal neurosonogram, I think we have done our job. Basically the plasticity of the brain, even though it's good, so it becomes very difficult if there is a thromboembolic phenomenon in the cerebral artery. So we'll have to look at a normal neurosonogram. So conclusion, the incidence of MIS-C in neonate is less than 2%. Mild cases are very common. Moderate to severe cases have been reported. There are shocks, DIC and multi-organ dysfunction and also deaths. The common symptoms, the symptoms are as common as bacterial sepsis. We see fever, poor feeding, lethargy, shock, bleeding, and there are a big set of investigations we have to evaluate. Admission to the NICU at least for level 1 is mandatory because monitoring becomes impossible at home in the neonatal period. So please admit, evaluate the child on an OPD basis. If you think there is an acute inflammatory response or a syndrome, admit the child for at least 3 to 5 days to monitor the progress of the illness, then we can go ahead for treatment. Ventilation, IV fluids, there are only 6 treatment here, 3 supportive and 3 medication. Ventilation, IV fluids, IV antibiotics, methylprednisolone, IVIG and anticoagulation. There are only 6 steps, so there is no much in the treatment of MIS-C in neonatal. The most important thing is a post-MIS-C evaluation, especially when there is a cardiac finding, echocardiography finding, if there is a coronary artery dilatation. We will have to do a follow-up echo after 2 months, 4 months, 6 months and 1 year. The reason being is, as I said, they can cause aneurysm, sudden rupture and sudden infant death syndrome. So basically we will have to be careful. The outcome of MIS-C, mild case is extraordinary, but they require admission for 3 to 5 days. Outcome of moderate to severe MIS-C is poor outcome. There are around more than 200 cases of MIS-C reported in Western nation. The outcome was very poor, 80% had died in severe cases. So mild, almost all recovered. I think I end this. I thank you, I thank the organizers for giving me an opportunity. Any discussions? You're welcome. Thank you.
We had a baby this week only, last week only. 1 day old baby having severe tachypnea and tachycardia, full term baby. Of just the cold, clammy, shock-like presentation. And we admitted, we gave the supportive things and all. Incidentally, we did the COVID antibodies. It came positive by the just strip method, which is available
Yes,
in
yes.
the government setup. So how to go about it? Whether it is day 1.
Okay, so
It was
yes.
prevented and IgG antibodies were positive.
Okay.
So how to go about it?
See, this is what is called perinatal COVID. See, these are less reported in Indian sector. I think sir said it's one of the good learning. So mother who had asymptomatic COVID in the late pregnancy, that is around 32, 34, 36 weeks.
History of any COVID
I know. So it was asymptomatic probably. Asymptomatic. So viral infection, the virus wouldn't have got transmitted to the fetus, or there might be a mild virus which are less number of virus would have got, but the acute inflammatory response can start as early as day 1 of neonatal period. So basically that's an acute inflammatory response for COVID infection in utero which has caused this response. So this is actually termed as perinatal COVID. It's a new term which was done I think last month in WHO. They said perinatal COVID does exist. Is there a vertical transmission of COVID infection which is causing devastating effect in newborn period? So most of them will mimic like in severe RDS, most of them will mimic bacterial sepsis because high CRPs, but ultimately it's our duty to do COVID antibodies. If you get an IgG positive, that means there is a transplacental transmission of the antibodies. So practically we should put it as an acute inflammatory syndrome or MIS in neonatal period. So I think we'll have to do a supportive therapy, give a pulse methylprednisolone, it should do well. There are reports, there are 216 babies which are presented in first 3 days of life. 216 babies all throughout the world which were reported. So that is when they labeled it as perinatal COVID. This was done last month. So probably vertical transmission does exist. Does the virus gets transmitted? We don't know. Or does the inflammatory cytokines enter the placenta? We do not know. But there is a COVID syndrome, inflammatory syndrome in the first 3 days of neonatal period.
Methylprednisolone dose is not higher, just 1 to 2 milligrams.
Yes, sir, 1 to 2 milligrams, 3 to 5 days. Response has to be seen every day. If there is reducing heart rate, if the inflammatory markers are reducing, which has to be done every 48 hours, then at most the inflammation is suppressed. Usually what is they say is need of IV immunoglobulin is very rare even in newborn period if they come at the right point. Okay, so I think heart rate monitoring becomes very important in the neonatal period because it's more of we have to pick up the sign. There is no symptomology there in neonatal. We have to pick up, so have a monitor in the OPDs to check for the heart rate. At least feeding heart rate, if it is less than 160, it's fine. More than 160, check for fever, check for the inflammation, at least CBC and CRP. If it is CRP is high, please suspect infection along with inflammatory syndrome.
CRP was around 10 and 14.
Little high. Thank you. Thank you.
Thank you, Prashant. It was my privilege to have my classmate as a faculty in our program. We have just 30 seconds video about our hospital, that is HCDR Referral Hospital, a BBMP hospital. We have a high-tech lab and SNCO. As Prashant was talking, he told that if we better get this investigation done related to COVID, the investigations which are lined, we have started recently about doing D-dimer, LDH, ferritin levels, CRP and CBC routine for the COVID patients from the trial centers we have. From there we used to collect blood to our hospital. This one as a first tier, as Karunakar sir was telling, first tier investigations we used to do that in our lab. Just wanted to show you people that we have some little facilities which have recently started. So I'll just show you the videos. It will not take much time. This is our SNCO. This whole thing is organized by, framework, and this one was given by Prashant sir in the beginning. He has made it as inborn in the right side. This is our outborn babies. Because we get more babies from outside, we have kept this as the outborn. We have few babies now, 4 babies we have. That side is our inborn babies. And few of our colleagues were asking from urban side also that they wanted to send babies for our SNCU. We have given the number to them also. They can send. No, not this one. This is our lab. Here we are planning to do all the blood tests which related to COVID now. Henceforth we are to escalate whatever he has told, the investigation related things. Maybe not everything we can do, but around 80% of the tests we are planning to conduct blood tests here. Now I request the next speaker, Dr. Sharat Chandra. He is Assistant Professor and Neonatologist in BGS Institute of Medical Sciences. Before that, we have a small announcement. We have to respect and give honor to the people who are behind making this program happen. A few very important persons who helped us in organizing this conference and training sessions. I request Dr. Shivkumar sir to come on stage and felicitate the people. First of all, I request Prashant sir to come on stage. He is the backbone and the mastermind behind this training program, who has helped us and instructed us to how to go about this in organizing things. Though he is the main person behind this one, he gave all the credit to us, saying all BBMP people did. He is the main person who organized this. All credit should goes to him. Thank you very much, sir. Please keep doing your services, public services like this. Thank you very much. Photo ತೆಗೀರಿ. ಫೋಟೋ ಅಲ್ಲಿ ತೆಗಿಯಕ್ಕೆ ಹುಡುಗರು ಯಾರು ಅಷ್ಟು ಜನ ಇದ್ದಾರೆ, ತೆಗಿತಾರೆ ಬಿಡಿ. ನೆಕ್ಸ್ಟ್ ಅವ್ರು ಯಾರಿದೆ ಹೆಸರು, ಅವ್ರ ಹೆಸರು ಗೊತ್ತಿಲ್ಲ.
ಥ್ಯಾಂಕ್ ಯು ಸೋ ಮಚ್ ಪ್ರಶಾಂತ್ ಸರ್. ನಮ್ಮ ಎಸೆನ್ಸಿ ತಾವು ನೋಡಿದ್ದೀರಾ, 4 years ಬ್ಯಾಕ್ ಸರ್ ಕೇಮ್ ಆಲ್ ದ ವೇ. ಅದೊಂದು ಇನ್ನೂ ಕನ್ಸ್ಟ್ರಕ್ಷನ್ ಸ್ಟೇಜಲ್ಲಿ ಬಂದು ಚಿಕ್ಕದಾಗಿದೆ, ತುಂಬ ನೀಟಾಗಿ ಮಾಡಿದ್ದಾರೆ. ಔಟ್ ಬಾರ್ನ್, ಇನ್ ಬಾರ್ನ್, ಟ್ರ್ಯಾಕ್, ಸೆಪ್ಸಿಸ್ ಅಂತ ಬಂದವರೆಲ್ಲ ತುಂಬ ಇಷ್ಟಪಡ್ತಾ ಇದ್ದಾರೆ. ಡಿಡ್ ಯು ಗಿವ್ ಸ್ಟ್ಯಾಟಿಸ್ಟಿಕ್ಸ್ ಹೌ ಮೆನಿ ವಿ ಆರ್ ಟ್ರೀಟೆಡ್ ದೇ? ಓಕೆ, ಒಂದು 4 years ಆ್ಯಂಡ್ ಹಿ ಈಸ್ ಅವರ್ ಎಸೆನ್ಸಿವ್ ನೋಡಲ್ ಆಫೀಸರ್ ಭಾನುಪ್ರಕಾಶ್. ವಿ ಆರ್ ವೆರಿ ಪ್ರೌಡ್ ಆಫ್ ಹಿಮ್ because of SNCU level 2A is running very nicely. We are just going to upgrade it very shortly. So for that also we give the credit to first Prashant sir only. And also for this training program, you all know excellent topics, very crisp and also which are up to date and with all the eminent speakers. I think all of you are loaded with the knowledge and all because of the effort of, it should go to sir only, nothing else. We have just ran around, but all this wisdom and whatever to enlighten with what kind of topic, everything is decided with Prashant sir. So our heartfelt thanks from BBMP side to Prashant sir. And next our one more person where we are very having sincere gratitude is Mr. Chandan sir. Bani sir, kutkoli. He is our PRO of Non-Hands. Okay, he is so good, so lively, charming and also very smiling always. Really we have to learn from him. He really helped us to arrange the hall free of cost, and he is the one pioneer for get us the live stream link. But you can all go through this YouTube link. I think you all know the link. If you want, once more we'll announce. Years together you can see whatever happened here. No need to copy anything. All the slides are there in the YouTube with the same link. And all the credit goes to Chandan sir, PRO of NIMS institution. So and also the director and the registrar, I really thank. From BBMP said, actually our ma'am, IAS officer Tulsi ma'am was supposed to come, and our JC, both of them are very busy. So they are said, on their behalf, we are actually congratulating all of you and also the real people who are behind us, made BBMP also a good name that we can also conduct the training programs in a, almost I feel it like a conference, national conference level they have done it. And all the credit goes to Prashant sir again and Chandan sir and Niman sir. Thank you so much. And of course my one more Dr. Veena, who is from the Deputy Director from Government of Karnataka. From her effort we have got around more than 54 I think pediatrician from the Bangalore division of Government of Karnataka Pediatricians. She is on the way. She was in some meeting. So for her also there was some gratitude. We have to facilitation. Once she comes back, I think we'll give her. And our sincere heartfelt thanks goes to Dr. Veena, who is the Deputy Director in Government of Karnataka. Thank you so much. And among all, our sincere gratitude and thanks goes to all of you. Without you, the function or this training program wouldn't have been successful. Hope so that you all become the master trainer in your area. Train all the colleagues and whoever in your district or whatever in your hospital setup. And please, as our minister said, take home messages. We have to save the children from this pandemic. Thank you so much. Thank you.
Thank you, madam. We have certificates for participant certificate and faculty certificates that we will distribute after the hands-on training workshop. Now I request Dr. Sharat Chandra, neonatologist, to talk about the NRP, neonatal resuscitation. Please come on stage, sir. Welcome. Lights off.
Good afternoon to every delegate present here. First, I would like to thank Dr. Prashant sir for inviting me to this talk on this neonatal resuscitation, which is the part of everyone's life as a pediatrician or who attends to delivery. And I am pleased with the BBMP to train all doctors before the third wave, because they told it will come in August, October. No one knows actually, but they have already done a training program well ahead of that. Yeah, first coming to the definitions. This is a series of actions used to assist the newborn babies who have difficulty in making a physiological transition from intrauterine to extrauterine life. Underline all the important words. It is a series. It means it's a continuous process. There is no gap, nothing. It is a series, and it is used to assist the newborn babies at birth who have difficulty in transition from intrauterine to extrauterine life. This is the basic definition of neonatal resuscitation. And why it is essential is most newborn babies are vegans at birth, and only about 10% of babies will require some assistance to breathe. In that, only 1% will require extensive resuscitation, and only around 0.05% will require chest compression. Even less will require drugs. So basic is our APGAR score, which was by the Virginia APGAR was a anesthetist who brought up this score. So you know all this. There is a scoring is 0, 1, 2 depending upon the features. It will be like color will be taken as appearance, heart rate, reflex irritability, what is called grimace, for which has given a scoring of 1, muscle tone and respiratory effect. Total score is 10, and we have to do it first minute and 5th minute. So depending upon the score, if the APGAR score is 8 to 10, this is achieved by the 90% of neonates. Nothing is required, and baby is crying, so everyone, even the pediatricians, will be happy. This is the only incident in the whole life when the baby cries and everyone is happy. Otherwise, if the baby cries, entire even family, everyone will be crying. So this is the only place, first minute of life, and we will tell. That is the first thing we will tell to the attenders. So nothing is required. The routine care, drying of skin, maintaining the body temperature. So if the APGAR is 5 to 7, so there will be some mild hypoxia, and then we will respond with vigorous stimulation, and we will require oxygen. If the APGAR score is 3 to 4, here the problem will start. They have moderately depressed, they can be cyanotic with poor respiratory effort, and they respond to bag and mask ventilation, and they become big. If the score is 0 to, the real problem is they have been having severe asphyxia. They may require immediate resuscitation to make the baby even survive. Sometimes they may not even survive if we don't do the resuscitation. So coming to the actual NRP, so first will be preparation. The focus on the history means we have to go from the antenatal period, give an antenatal counseling if it required, and before the delivery we should know the exact history about the mother, antenatal, what has happened, any complication is there, or any significant history is there, so that we can foresee complication occurring in the baby at birth. And team briefing. This has been recently. This has been team briefing means first we have to identify your assistant who will be helpful for your resuscitation, and you have to brief and very specific role one has to play. One may be assistant, other may be the main person. And important is the equipment. As always, before prior delivery, we have to check all the equipment and see to that it is functional. So, what are the equipments? It is just generally you should have a resuscitation bed, overhead warmer which should be on 20 minutes, at least 20 minutes prior to the expected delivery. Towel, it should be dry and preheated. Stethoscope and pulse oximeter. And for the airway management, we require suction devices, bulb syringe, laryngoscope, 0, 1, and rarely if you are expecting a premature baby, it should be 0 size. Endotracheal tube sizes 2.5, 3, 3.5, and laryngeal mask airway. This is a recent recommendation by the NRP. And breathing support as face mask, PPV, oxygen gas, and feeding tube, and circulating UVC kit, intravenous kit, intraosseous needle, and drugs will be adrenaline, normal saline, and blood. So this is a new initiative. First minute of life is very important. It is called Golden Minute, and now they are coming with a program with helping the babies to breathe. It just first at 1 minute, baby should start breathing, or we should make them ventilate with a bag and mask so that they start breathing or have a good respiratory effort. So there's helping to babies breathe. Emphasis is on the assessment of each baby, providing the temperature support, and providing a baby with stimulation to breathe and assisted ventilation, all within first minute of life. And very important is we should not waste the time by calculating UPGAR to determine the need. There is a need for resuscitation. As soon as you feel the baby may require resuscitation, you should start immediately with the whatever steps you get. There is no need to wait till 1 minute, document the first minute UPGAR, then do. It's already you have wasted. That is why this helping babies to breathe has come at golden one, first minute. So these are the 3 questions we have to ask as soon as the baby is born. First is the baby is term gestation or preterm, and the baby is crying or breathing, and does it have a good muzzle tone? So if the answer is yes for all 3 questions, nothing is required, and the baby has to be shifted to the mother's side as the baby is fine. If suppose any of the questions has a no for any of the question, then the baby may require any resuscitation step as I will follow it up. For initial step in stabilization, ventilation, chest compression, adrenaline, and volume action. These are the steps which I have to do later on. So this is the flow chart of a NRP. In this you can clearly see. Yeah, this is the initial antenatal counseling as well as the team briefing. And you can see this first minute they have marked clearly. This is the first minute what we have to do. In this there are this is very important. This diamond and box. Box is a box you can see. Diamond is the where you assess. Diamond is the action line. So at first minute there are 2 actions where you have to. This is one diamond. This is the means first minute you have to be thorough with assessment as well as start whatever you want to do. And one I want to concentrate is this preductal saturation. Preductal usually we have to monitor in the right upper limb, which is always is a preductal, and the saturation target we have to meet in the preductal oxygen saturation target. At first minute it is just 60 to 65%. So if the baby has first minute preductal saturation of 65 minutes, you don't have to rush, because that is only recommended. Only at the 10th minute of life it should be 85 to 95%. So all your target resuscitation will be to achieve this target. So this one is cord management. As you all know, now it is recommended to clamp and cut the cord after 1 minute. That is delayed cord clamping. So that will be helpful for the baby because it will get extra blood, which will be helpful for the baby. And these should be done for the babies which are well good enough and doesn't require any resuscitation. If they require resuscitation, immediate cord has to be cut and baby should be taken for the further. And in preterm babies, it is very important because the delayed cord clamping will increase hematocrit, and then later on the need for transfusion is less. So these are the initial steps. First you have to provide the warmth, position of the head in a sniffing position. In this it is very easy to provide the sniffing position. Just put a shoulder roll between the shoulder so that there will be slight extension. It will cause opening of the airway and the airway will be straight enough. clearing the airway if necessary. This is now I will tell later, drying the baby, stimulate the respiration and observing the breathing activity and color. So after this, the decision should be taken depending on 2 parameters. One is the respiration. Is it good respiratory effort are there, or totally baby is happening or labored, and depending on the heart rate. As you know, it is less than 100 or more than 100, and the heart rate should be seen first initially with auscultatory method or by palpation of umbilical cord. And now they recommend that you have to have a oximetry in the right upper limb, because it will give the heart rate as well as the pre-ductal saturation, which is a target, and ECG heart rate should be monitored. So coming to the temperature control. So temperature control is one of the important steps in resuscitation, because studies have proved baby having hypothermia, the mortality has gone very high in those babies. So how to maintain the temperature? First, as soon as the delivery is anticipated, you have to go to the labor room, see any switch off the fans, switch off the AC, or any open windows are there which can cause the baby to be hypothermic. And the delivery room temperature should be maintained at 26 degrees centigrade. And after delivery of the baby should be covered. If suppose the baby is preterm baby, you can cover the baby with plastic wrapping, or that is called cling wrap, or food grade plastic sheets. And the baby placed in the baby exothermic mattress, and as well as radiant warmers. Suctioning, this is the recommendation that no routine suctioning is recommended now. Only if there is an obvious obstruction which is hindering the breathing, or when you require PPE, suctioning is advised. And if at all you have to suction, as all you know, it is first will be the mouth, next will be the nose, and mouth less than 5 centimeters the catheter should be inserted. And this is for meconium stained amniotic fluid. Whenever the baby is born through meconium stained amniotic fluid, dilemma is there whether we have to do the suction and clear the meconium or not. Now it is clear recommendation has been given. When the baby is vigorous, means the baby is crying, efforts are fine, then no need to do routine suctioning. And only the endotracheal suctioning is indicated when the baby, when you see there is evidence of airway obstruction, or else if the baby is not having respiratory effort, now they have recommended you can use the bag and mask and try to resuscitate the baby rather than wasting the time by doing endotracheal intubation and do the endotracheal suctioning. So what are the ventilatory supports after birth? Suppose the baby, which babies require ventilatory support? Those are the babies who do not breathe in the first 60 seconds after birth, and they have heart rate less than 100. And that heart rate after the appropriate initial steps. That is the tactile stimulation, and they should receive a positive pressure ventilation up to 40 to 60 per minute. And how we give the positive pressure ventilation? Either giving bag and mask or the TPS resuscitator. Now they are recommending TPS resuscitator because it can even deliver the PEEP, and the PEEP what we give will be correct, because bag and mask it is very difficult to set the PIP. And peak inflation pressure, that is what PIP, the term will be 30 centimeters of water you can give. For a preterm babies, it will be 20 to 25 centimeters of water. Suppose with this the baby has any improvement is there, then you can go to the see the baby. If the baby respiratory effort is fine, if the baby respiratory effort is fine, you can stop the bag and mask ventilation. Suppose if the baby is not having the improvement in the heart rate, which is considered as the marker for your adequate resuscitation. The resolution of bradycardia is the best marker to tell that your resuscitation effort is fine or correct. So if it is not happening, then you have to see if there is any problem with your bag and mask ventilation. So how you do this? There is an acronym called MR-SOPA. First, whenever there is a binary effort, you can do the suction of the mouth or the nose, then open the mouth and ventilate for 5 seconds. You can see the adequate chest rise is there or not. If it is not there, you can do the mask adjustment, reposition the airway, and again ventilate for 5 seconds. See for the adequate chest rise and see the heart rate is improved or not. If it is not improved, then you can increase the pressure. You think the baby may require higher pressure and increase the pressure and give, or else even if doesn't have improvement in the heart rate, then you can go for the alternate airway. All this has to be done within 30 seconds. So the alternate airway comes with endotracheal intubations. So when you do go ahead with endotracheal intubation is that when the prolonged BME, bang and mask ventilation is required or they are ineffective, and as you all know, congenital diaphragmatic hernia, it is bag and mask ventilation is absolute contraindications there. So whenever in the antenatal history, when you see a ultrasound report that there is a congenital diaphragmatic hernia, you have to electively intubate the baby if the baby is born flaccid at birth. And depending upon the weight and gestation age, you can choose the size of the tube, such as 2.5 centimeter tube for a baby less than 1000 grams or below 28-week gestation. Use a 3-size tube who are between 28 to 34 weeks of gestation and a weight of 1000 gram to 2000 gram. If they are more than 2000 gram or more than 34 week, we can use a 3.5 size tube. And if the baby is large, there is no, like we can use the 4 size tube, but very rare. And after intubations, we have to fix the tube. This is very important because too deep tube will not provide the proper ventilation, and if it is too high, it may not provide the ventilation as well as the chances of extubation, the tube coming out very high. So this is the recent recommendation. In this way, 2 parameters can be used. One is the nasotragus length plus 1 centimeter. You can measure the distance between the tragus and the nasal septum. To that, add 1 centimeter. Whatever the distance you get, that much depth the endotracheal tube should be fixed. Suppose you get a distance of 8 centimeters. For that, plus 1 you add and fix the endotracheal tube at the 9. Endotracheal tube has a markings from 1 to 15. So fix the tube at 9 centimeters. Or else, if there is one more is gestation age. Depending on the gestation age, they have recommended the position where the endotracheal tube should be fixed. So this is the one. Either of this should be used to fix the endotracheal tube. This is the endotracheal intubation. Just a photo. And oxygen administration. As you know, oxygen is a drug. 2 less is harmful, even 2 more is also harmful. So with what oxygen, if I were to require, you have to resuscitate the baby. Recommendation is for a term baby and as well as the preterm less than 35 week, we should start with the room air, that is 21%. If suppose the baby is 35 weeker or less than 35 weeks, we have to start with 20 to 30%. Here we have to have a monitor pulse oximeter, see the target saturation. If suppose you started with room air and the target saturation or not met, means you can increase the FiO2 to desired level, even up to 100% to meet the desired target saturation. Because lower target saturation, if it is for a longer time, there is an increase in mortality. And next step will be chest compressions. So when chest compression should be started, it will be started if the heart rate is less than 60 per minute after at least 30 seconds of adequate PPV, adequate positive pressure ventilation. If suppose you have not given positive pressure ventilation, there is every chance that heart rate will not improve. So it should be good enough to find out is the adequate PPV has been given. And the ratio is standard now, it is 3:1. Previously they told 15:2 and all. Now it is outdated. Only 3:1 is the ratio to give chest compression. And now they have clearly made a recommendation that 2-thumb encircling technique should be used for chest compression. And I have put a photo where the thumb should be there. Thumb should be held side by side. Thumb should not overlap each other. And this two-thumb encircling technique has proved it improves the blood pressure and less finger fatigue for the provider. Next will the intravascular access. In this any vein can be used, peripheral vein can be used, but in emergency the best vein to have an intravascular access is the umbilical vein, because it is easy to cannulate and you can give large amount of drugs or fluid and with a faster rate. Suppose the umbilical vein is not available, you can use the intraosseous route. So medications. So medications, if the heart rate is not increased to more than 60 per minute, after optimizing the ventilation and chest compression, that's the third step. After optimizing ventilation as well as chest compression, you can use intravascular epinephrine at a dose of 0.01 to 0.03 milligram per kg. The commercially available adrenaline will be 1:1000 dilution. So you have to dilute with 1:10,000 dilution. How we will do is take 1 ml of adrenaline, add 9 ml of normal saline, it will be 1:10,000 dilution. That has to be given. Suppose you are giving endotracheal epinephrine, the dose is at a higher dose. It is at 0.05 to 0.1 milligram per kg, and it can be repeated every 3 to 5 minutes if the heart rate is less than 60. And endotracheally, if you are giving adrenaline, it should not be repeated more than twice. By the time you think of giving a third time, your intravascular access should be there mandatory, because repeated dose of intratracheal adrenaline is not helpful. It will cause the pulmonary vasoconstriction and it will harm the resuscitation effort what you are giving. And volume replacement will be given only in case of suspected hypovolemia based upon the history physical examination. Suppose the history mother has some antepartal hemorrhage or placenta previa or abruptions, those are the cases that baby can have blood loss. Those patients we may have to give volume replacement. That too when the bradycardic, despite the ventilation, chest compression, epinephrine have been given. And normal saline 0.9 ml per normal saline should be given 10 to 20 ml per kg over 10 to 20 minutes. This is the flow chart. Again I have put it. This you can see. Here is the first antenatal counseling, first we are at birth. These are 3 questions which we have to be answered. If everything is yes, we can go for the routine care. If suppose no is there, then we have to see what has happened. Apnea is there or heart rate is less than 100. If it is no, if they just have a labored breathing, then we can give a CPAP, which will provide the adequate oxygenation as well as saturation can be maintained. If suppose if the heart rate is less than 100, we can go for chest compression. And this is line of action, this is line of evaluation. Line of evaluation is continuous. So this is the action line where you will give chest compression or endotracheal intubation. Again, also you see the heart rate. If it is more less than 100, go back to the line of action. If it is improved, then we can go. If it is not improved, we can go the next step. It's a continuous, I told, series, and it is continuous process, and we have to evaluate and act. And after resuscitation, baby will revive. Now very important is the post-resuscitation care. Now this is therapeutic hypothermia has come for moderate to severe hypoxic babies, and it has become the standard of care in developed countries. In India now the study have completed in middle and low socioeconomic condition countries regarding therapeutic hypothermia. Results have to publish. So, and few centers in Bangalore, they do this therapeutic hypothermia. What they do is they will cool the baby to a 34.5 to 33 degrees centigrade, and this has shown abroad that the damage which has occurred due to birth aspect can be decreased. And it doesn't mean that, next line what I put, it doesn't mean that we give the baby hypothermia, because unintentional hypothermia has to be prevented and the baby should be kept in warmer, because inadvertent hypothermia has increased the mortality. So post-resuscitation care, we have to look for the temperature, heart rate, respiratory rate, pattern, blood pressure, saturation, and very important is the euglycemia. If the baby is having hypoglycemia and they have birth asphyxia, damage to brain is almost double or more than that. So we have to maintain the euglycemia for the baby, and ABG can be done, and fluid balance as well as the neurological assessment has to be done. Which babies you want to withhold the resuscitation? Even after the extensive resuscitation for more than 20 minutes, if the baby doesn't have respiratory effect or the heart rate is less than 60, those babies, after consulting the patient and getting the consent, you can withhold or discontinue the resuscitation. And this is important, this is during COVID. COVID, you can see these guidelines have been published in new reviews recently. In this you can see this one. This is a physical barrier should be placed between the delivery place and the resuscitation. If the distance between is less than 2 meters or 6 feet. If it is more than that, this barrier is not required, but if it is there, it is helpful. And 2 persons are required for a resuscitation of baby who is born to COVID positive mother. This is the other person waiting and the other person who is seeing the baby. And this is the mask. Suppose if you want to give a bag and mask ventilation, they have told one person's difficult to hold the mask, the chances of aerosol spread is high, and the person who is giving the this person who is giving the resuscitation will be at high risk. So they recommend 2% technique to give the resuscitation, and rest all is same. Wearing PPE, everything is been same. These are the references. Thank you. Any questions?
Any questions?
No questions, I think. ಆಯ್ತು ಬೇಗ ಮುಗಿಸಿದ್ದೆ ನಾವು.
Yes, yes.
ನಾನು ಹೇಳಿದ್ದೇನೆ.
Thank you, Sharath. Now we have workstations outside. For that, we have to have some exercise and divide the hall, the number of people into 6 groups. So I would request the people here to count from 1 to 6, so that 1 will go to one stall and 2 will go to another stall, like that. So sir, please start counting from here. Please be seated. 2 minutes it will get over. Stop, sir. 1. 2. Please remember your number. Then don't ask again. Sir. 5.1 na? Sir, 6 ah? Huh. ಈಗ ಇಷ್ಟು ಇದು ಮುಗಿಲಿ, ಇರೋ ಮುಗಿಲಿ. ಹಾಂ, ಮೇಡಮ್ ಮೇಡಮ್ ಅದಕ್ಕೇನಾಯ್ತು? ಹಾಂ, 1 ಈಗ okay. Now all 1 will go to stall number 1, 2 please go to stall number 2, 3, 4, like that. Your individual stalls please go. From right side, this is the first stall. From as you go outside, once you turn to your right, that is the first stall.
Hello.
Hello. Is the air and oxygen we have to connect in the central air and central oxygen. After that, there is a two flow meters. This is one low flow meter. This one low flow meter up to 3.5 liters. Okay.
Hello.
Yeah. Okay. We'll start now. Yeah, this is the bubble CPAP. This is the blender, biomed blender. It's having a two flow meter. One is the low flow up to 3.
No crowd. If this goes into YouTube, this crowd will be short. Only 2 people here. Please, all of you move. Only 2 doctors can come for 15 minutes. Later, all of you can come back. Meanwhile, you can attend others. Self Hindi Kobi. Only 2. You have to explain with the thing. This is only for YouTube link.
Okay.
So you have to have only no crowd here. Please discuss. After this camera will move there. That time all of them come here. That is left to you. Just leave 10 minutes for this group. ಯಾರಾದ್ರೂ ಇಬ್ಬರು ಡಾಕ್ಟರ್ ಪೀಡಿಯಾಟ್ರಿಷಿಯನ್
This is the bubble CPAP. It is having a 2 flow meters. One is the low flow meter and one is the flow meter. This flow meter up to 3.5 liter. This flow meter up to 15 liters. Yes. And the FIO air. This is the air and air.
ಸರ್ ಒಂದು ನಿಮಿಷ ಮೇಡಮ್ ಅವ್ರಿಗೆ ಹೇಳಿ ಎಕ್ಸ್ಪ್ಲೇನ್
Just I will explain them. That's it.
ಮಷಿನ್ ಬೇಡ ಬರೀ ಇದೆಲ್ಲ ಬೇಕು
Doctors.
Actually, doctors ಅಷ್ಟೊಂದು ಇಂಟ್ರೆಸ್ಟ್ ಇಲ್ಲ ಮೆಷಿನ್ ಎಲ್ಲರೂ ಮೆಷಿನ್ ಕಲಿಬೇಕು
ಮೆಷಿನ್ ಡೆಮೋ ನಿಮಗೆ ಯೂಟ್ಯೂಬ್ನಲ್ಲಿ ಹಾಗೆ ಸಿಗುತ್ತೆ ಇದಕ್ಕೆ ಲೈವ್ ಡೆಮೋ ಅಂತ
ಅಲ್ಲಿ ನೋಡಕ್ಕೆ ಡಾಕ್ಟರ್ ಎಕ್ಸ್ಪ್ಲೇನ್ ಮಾಡ್ತಾರೆ ಮೇಡಮ್ ಅಲ್ಲಿ ಬನ್ನಿ ಗೊತ್ತಾಗುತ್ತೆ ಇಬ್ಬರು ಸಾಕು ಸ್ಟಾರ್ಟ್
We'll start, ma'am. Okay. This is the bubble CPAP machine. This is the blender. This is the air and oxygen hose we are connecting in the central air and central oxygen. That pressure should be 4 bar. Air and oxygen pressure should be 4 bar. If lower than that, the blender will give the alarm. First problem. Second thing, this blender is having 2 flow meters. This is the low flow meter up to 3.5 liters. This is up to 15 liters. 2 flow meters is there. 15 liters. But pediatric baby, neonatal babies is not required 50 liters. 15 liters is enough. That's the reason is 50 liter. This is the 3.5 liter. And whenever you are using this, you can switch off this.
It's okay.
One you can switch off. After that you are connecting this one in the pressure manifold. This is the pressure manifold. In this one, this is the pop-off valve. The manometer port and this is the FiO2 port. If the flow is more than 15 liters, it will pop out. It's for safety precaution purpose. It will not allow more than 15 liters for the baby life. That's the reason we provided this. After that, this is the FiO2 port. If you want to cross check whatever the FiO2 is set here, you want to cross check, keep the FiO2 monitor inside and you can able to cross check that. After the humidification is, this is the humidification part. We set 37.5 degree servo control humidifier. It will control automatically. Then it will go to the patient, baby. And this is the probe. This probe is having a flow and temperature probe. If flow is not there, this temperature, it will not get warm up. Now the oxygen is not there. That's why it's not getting warm up. And second thing, this is the heater wire adapter. In the inspirator tubing, there is a spiral heater wire is there. There is no condensation inside the tubing. No condensation. And the end expiratory, we dipped in a bubble generator. PEEP. If you are dipping 1 centimeter inside the water, 1 centimeter pressure will create inside the baby. Mainly the bubble CPAP is the important thing for interphasing. First you have to select a correct interphasing. For that you require this one. You have to check the head circumference. You have to select all 4 sizes. This one is there. 4 different sizes is there. 34. See, 36, 34. This is the correct size. This is the correct size. After that you have to attach this one.
It's okay, I'll do it.
Yeah.
So this is basically CPAP, bubble CPAP. Mainly we use in the neonates and yeah, this is a bubble CPAP unit which is used for newborns and especially in prematurity for respiratory distress syndrome. You have the FiO2 blender, so always make sure when you are using the CPAP, the blender should always be there. With this you can control the FiO2, whatever you are going to give the baby, okay? And you have the humidifier, because always whenever you are giving this using CPAP, the air which is given to the baby should be humidified. Otherwise it will cause the damage to the epithelium. And here you have the, do you have the box? Another box you don't have? Bubble generator?
I will show you, sir.
Yeah, just remove that from me. So this is the bubble generator, and we have one, this is, there will be 2 limbs in this, okay? So this is, one is the inspiratory limb and this is the expiratory limb. Now this expiratory limb will go inside this bubble generator, and as we adjust the depth to which this limb is put, you can adjust the PEEP. Normally the physiological PEEP of a baby is around 6. So you don't have to go less than that, okay? Ideally you can start with 6. Maximum we use is up to 8. If you generally use more than 8, there will be chances of pneumothorax. So it's not advisable to go above 8. So between 6 to 8 you can use, and you have to make sure that when the CPAP is connected, there is continuous bubbling. Only then it means that there is a exact seal and the baby is getting positive pressure, continuous positive pressure. The whole idea of giving this bubble CPAP is to deliver positive pressure and to expand the lungs, which would have collapsed in preterm babies. And not only in that preterm RDS, even in any other conditions wherever babies are having respiratory distress, this is something which you can use before you put the baby on the ventilator. So suppose the baby, when do you want to put the baby on CPAP? Suppose you have started giving oxygen for a baby, and the oxygen requirement of the baby starts going above 40%. I mean the oxygen saturation starts going very high, then you can use the CPAP. Now on the CPAP, if the FiO2 requirement goes above 40 to 50, that's an indication for you that the CPAP is not working, you have to go to ventilation. Okay. So basically for any sort of respiratory distress in a newborn baby, preterm, there are these masks, what you see here, they come in different sizes. So instead of this, sometimes we can use the nasal prongs also. Yeah, these type of nasal prongs can be used. Either you can use the nasal prongs or you have to use the mask. So this masks come in different sizes depending upon the size of the baby. We generally use a CPAP right from, even up to from 700 grams we can use. This is the size card. Okay. With this size card, you can measure what is the size that is required for the baby, and that particular size mask it can be put for the baby.
Now CPAP is one of the main modes of respiratory management for especially in newborn period, and what you are seeing there is a high flow HFNC. Just, can you give me the tube? This is high flow nasal cannula. So with this we can deliver oxygen at a high rate, and we have this flow meter up to 50 liters we can be given through this. The advantage of this is it gets humidified and generated, and directly the oxygen will go to the baby, which can be used with this nasal cannula. Something similar to CPAP, but the oxygen delivery is much more effective and efficient in this. And for your always in in newborn babies, we have to make sure that we should not give excess oxygen. The moment you give excess oxygen, there is going to cause ROP and damage to the eyes. So we can control the FiO2 here in this. See, this gives the temperature at which it is going. You can increase the temperature or decrease, and this gives the FiO2. So FiO2 can be increased when the flow meter is not connected. So otherwise you can increase the FiO2. So the same thing applies here also. But only difference in HFNC is, especially when we are using in the newborn period, this can be used, it cannot be used as a primary respiratory support for respiratory distress. Generally it has not been, even the studies have shown that it has not been very effective if you use as a primary respiratory support. CPAP can be used as a primary respiratory support, but this HFNC is usually used when the babies are requiring oxygen. Instead of giving head box oxygen, you can use this, or many times after extubation we use the HFNC machine. In older children also it can be used, and this particular model can be used in newborn, pediatric and adult, and the principle remains the same. And so you can keep increasing the oxygen level till that saturation whatever you achieve to get. But beyond a particular stage, then if you feel that if it is not improving, then you have to go for ventilation, either CPAP or ventilation. So, but only thing is these CPAP and HFNC both will be very gentle on the lungs compared to invasive ventilation. That is the very reason why we recommend this type of CPAP or HFNC before you go for ventilation directly. Earlier when CPAP was not there, that was we used to give oxygen for some time. If the baby is not maintaining oxygen, we used to directly go to CPAP. But fortunately, because after the CPAP has come into the market in a big way, now our ventilation incidence has come down a lot. Almost I can say around 80% of your cases can be managed with just CPAP in the newborn period, 80 to 90%. Only around 10% of them will require the CPAP. And many times in newborns, we also do that whenever they have preterm RDS, when they require the surfactant, we may intubate, give them surfactant, and then extubate and put them on CPAP. So that is also one of the modalities with which we can treat. Okay. So this is the basic thing about CPAP. I think BiPAP is with Prashant. He'll be showing the BiPAP. ಇಲ್ಲ this only the CPAP.
BiPAP machine ಅಲ್ಲೇ ಅವ್ರದ್ದು ಕಂಪನಿಲೇ ತೋರಿಸ್ತಾರೆ.
ಅಲ್ಲೇ ಇದು ಕಂಪ್ಯೂಟರ್ ಅಲ್ಲೇ ಇದಲ್ಲ.
We can go there. I'll show you the BiPAP because
yeah, okay.
ಇದು ಮೋಸ್ಕಲ್ ಬರೋದು.
ಅದೇ ಅಲ್ಲಿ ಅವ್ರಿಗೆ ಮೈಕ್
teaches how to breathe. Starting that
Okay. Quoting price is 14 lakhs. Adult, pediatric and neonatal. And if you are only choosing adult and pediatric, price will be little less.
The difference is, the difference is, the regular ventilator,
And this is
where you
fully
can do both invasive ventilation as well as non-invasive.
Yeah.
It has two limbs. Yeah, it has two limbs. It has an inspiratory limb and an expiratory limb. Whereas a freestanding NIV machine has only one limb. That means this is the only limb, and you have the mask. And what happens is, yeah, sorry, thank you. So when you have, there is a valve here. I can't show you here
So it is updated version of instrument.
because when so the machine gives a
Requirement is air and
inspiratory pressure,
oxygen
and when the patient exhales, the valve opens so the patient can exhale through it.
we never need to.
So either that valve is over on the mask or
Only
sometimes
thing
in the
you have to
circuit
take care
also.
is like exhalation valve.
So
and
this
closure.
single limb should
This
always
has to
have
be
a
safely handled.
valve,
And this thing should
because
be
otherwise
cleaned
how will
after
they
each
exhale?
patient.
Correct?
We can take
So either in the circuit it will be there or in the
with a little
mask.
warm water.
I can't show you, but anyway pictures if you have I can.
You can just wash
The
it.
valve
And never keep this thing in top water. Like we will be having two tungsten
So what
wires.
happens?
So these two tungsten wires will be measuring how much amount
Can you
of tidal
switch it
volume.
on? You can show
This
them
is
the
the
settings.
expiratory tidal volume which we are measuring.
So
Already
this
we
is-
are having inspiratory.
This is a freestanding
processor
NIV.
inside the
Whereas
machine.
this one
And
you
there won't
have
be any tubings inside the machine, so
two
there won't
limbs
be any leakage
and you can
from
put the
inside
same
the
mask here.
So we
But
will
the
be
difference is
facing
that
leakage
mask should
from
be
either circuit or
non-vented
this
mask.
So if you
Whereas
are
this single limb should be vented mask.
getting crack is there.
You cannot use a non-vented
only
mask
this
on
part we
a
have to make
single
sure
limb.
that it should
Otherwise
be
patient will
safe.
fix it. So that's
So
why
on
they
that
also have
time
something
machine
called a
will be getting this is the first one. So
asphyxia
here we
preventing
have
valves
new
also.
patient.
So that it
We can
always
select
opens up when the
adult,
pressure
neonatal
builds
or
up.
pediatric.
Because basically
Yeah,
breathing
three
in
are
and breathing
there.
out
And
through the
neonatal is
same
not a
valve.
standard feature, sir. If you record only neonatal will be there. Like
So
it
you have
is
to
an option actually.
select the proper size mask. That is the most important thing.
We
know.
can
Because
from 2
otherwise
ml
if
we
you
can
select the
ventilate.
wrong one, this is
Minimum of 2
probably
ml.
medium, no? Small one.
So we can
So this is a small full
select
face
which
mask.
type of patient we are having. And if required, we can keep the data.
So it all depends on the patient cooperation.
If
I mean,
required, and
sometimes
here we have
6-year-olds,
to keep
7-year-olds can
particular
actually
patient.
cooperate.
What type of?
I mean, newborns also you can do NIV technically. If you have a small mask, what the adult pillows, no, small nasal mask. Adult nasal mask can be actually used as a full. Yeah, see this, the newborn.
So
You can
we
use
have
it as a,
like circuit setup. So here
nasal
mostly
this thing.
you'll
And,
be using-
but small babies it is tough. NIV is always tough in a small baby.
So we can select either we are using humidifier or HME filter. So option is there.
There are straps here. You
Next
can
is like system checks. So before connecting to patient, we have to
and
check
then
like
you let
any
it show me
leakage
the
is there
button
from
because I have
circuit
not
side or
used
what.
this machine.
So this has to be performed
switch
before
it on
connecting to
and
each
then
patient.
three
So then
things
only
you
we
have
will be
to
knowing maybe chances of brand
suppose
new
let us say
circuit also
patient
will be
is
having
breathing at
leakages.
20 or 30
So
per
after
minute.
connecting,
right?
there won't be any issue.
So you want to
Yeah,
support their
everything is there.
spontaneous
Alarms are
breaths.
there.
You don't want to give them any breath.
So now,
So there is
for
something
doing
called
checkout,
S mode.
here
Can you
system
show the
check
S
option
mode?
is there. Attach the patient circuit to the
Set up.
ventilator. Occlude the patient.
So set up.
So this Y piece has to be occluded.
So see,
we
these
have
are the
to
things
pause
you have
the
to set up,
occlude.
right? So basically your EPAP.
So once you
EPAP
occlude,
is
patient detected
end
and alarm will come. So we
expiratory
can start
positive airway pressure.
we
So
can
that is
put
like your
full
CPAP
details over here.
or
All
PEEP.
tests should be passed.
So you set a EPAP usually, as I said, start with 3 or 4 and then slowly ramp it up. Not like you give 6 or 8 right away. And the second thing is your, yeah. So the ventilation mode, right? This is pressure support ventilation. That means the patient is breathing on his own. You're only supporting it. But the other one you can do. Oh yeah, I have 2 mics. Okay. And how do you say change this? Can you show? Yeah, I don't, yeah. Because I have not used this machine, so I'm just, oh yeah, this is, no, go to change the mode. The PSV to, what are the available modes on this? Just change it, yeah. So this is spontaneous, S is spontaneous. S and time, that is spontaneous / time. That means if the patient is breathing 30 per minute, it will give the support. But suppose if the patient, for example, receives some sedation or something, or he breathes only 6 per minute, you have a backup of time. In the sense, you can set the rate at like 20 or 30, so that if he falls below that, it becomes a timed mode. Yes/time mode. And then just the CPAP, without using any IPAP, just the CPAP you can do. And then the PSV. PSV is whatever he breathes, you give support. Whereas S and T is, if he is breathing okay, it is a spontaneous mode. If he breathes less or becomes apneic, it becomes time mode. Okay. And then pressure limit you can set. Okay. Pressure support, how much you want to give, for example, that is IPAP. It is called PS here, but that is IPAP basically. IPAP, not IPAP actually. This is pressure support over the PEEP, right? Yeah. Over the PEEP. So you have to add it to the EPAP is 2 and the pressure support is 4. So actually IPAP is 6. So that is how in this machine it is labeled. But some other machine it may be EPAP and IPAP directly. So here it is a pressure support over the PEEP. So EPAP plus pressure support is equal to IPAP in this machine. But in some machines you may say EPAP you have to set and IPAP you have to set separately. So it all depends on which machine you are talking about, right? So, and of course you have to set some safety things. This is the maximum pressure can go or maximum EPAP can go. Those also you can set. Anything else you want to add in your machine? Anything? No, any other features? Okay. Yeah, so the machine, some of the BiPAP machines do not have oxygen blended. So basically it works on the turbine, right? Is the turbine? Yes. Yeah. So basically it works on the turbine, it generates the pressure, right? So oxygen maybe in this machine, you can blend the oxygen here so that it comes through this. But you might have seen some BiPAP machines, you have to put the oxygen here, extra oxygen, you got to give it here, one of these ports. So whereas here you can blend it in. But your FiO2 monitors, FiO2 sensor? No sensor. So you still, you cannot see how much FiO2 is going, only you can alter it by increasing the flow. There may be some BiPAP machines have that FiO2 sensor also. Yeah, so you actually don't know how much FiO2 you are giving, but you know how much liters of oxygen you are giving. So it creates all these pressures, IPAP, EPAP, by a turbine. When you switch it on, you can. It runs on battery also. You have, right? Yeah. It's already running. It makes no sound. You can just run it and see. Makes that sound. So it is basically the turbine is the one which creates the pressure. But anyway, it leaks. We have not connected it. So you can start it. Just start for a few seconds.
Others.
ST mode ಹಾಕ್ಬಿಡಿ ಬರುತ್ತೆ ಅವಾಗ.
Does this have a water chamber?
No, this is not humidified. You can't give the humidification.
Because I've seen many different models.
Bike told ಸ್ವಲ್ಪ ಜಾಗ ಬಿಡಿ ವಿಡಿಯೋ ಮಾಡಿ.
So if I want to change the rate, I can directly go here.
Yeah, you can directly go there, sir. Yeah.
Simpler actually.
And you have to confirm, sir. Like.
But then I have to confirm.
Yeah, you have to just confirm.
You start from beginning.
Okay.
Since starting this thing, because they are recording.
Yeah, sure.
Starting from beginning when you connect to the patient.
Okay.
So start from there.
You start with that time.
Sir, you can
We start with that so that we can finish it.
It's just a basic machine, sir. Like it teaches how to breathe. Like newborn babies, like once it.
This is only for resuscitation.
Only for resuscitation, yeah, TPs.
You just go and
like PEEP and PIP will be setting like just.
So this is the test lung, right?
Yeah, it is test lung.
Okay, start from beginning.
You didn't come back to Chikbalapur.
Sorry, sir?
Chikbalapur, you are not come with it.
No,
So
sir.
this is the complaint.
Actually, I am from service side, sir.
Okay.
Yeah, okay.
ಎಲ್ಲಿ ಕೇಳಿಸ್ ಓಕೆ ಆಗ್ತಾ ಇದೆಯಾ ಯು ಸ್ಪೀಕ್ ಬಿಕಾಸ್ ದಿಸ್ ಇಸ್ ಅ ನ್ಯೂ ವೆಂಟಿಲೇಟರ್ ಫಾರ್ ಮೀ
Yeah.
ದಿಸ್ ಇಸ್ ದ ಎಕ್ಸ್ಪಿರೇಟರಿ
Yeah, the exhalation valve and flow sensors.
ಓಕೆ
So can I start?
ಸ್ಟಾರ್ಟ್ ಮಾಡಬೇಕಾ ಮೇಡಮ್ ಓಕೆ ಎಕ್ಸ್ಪ್ಲೇನ್ ವಿಚ್ ಇಸ್ ಎಕ್ಸ್ಪಿರೇಟರಿ
Okay, okay, okay. Yeah, it's here. Okay, okay, okay.
Keep it here loudly.
Yeah. So this is CareScape R860 ventilator, which was manufactured by GE Healthcare. So this machine comes with adult, pediatric and neonatal. So 3 types of patients can be used in this machine. And neonatal is an optional feature. It won't be coming with every machine, sir. So if you require a machine with neonatal option, you can purchase like that. Otherwise, like normally it will be coming adult and pediatric.
Explain this, which is the inspiratory.
Okay. So here you have the inspiratory side. This is your expiratory side.
This is the filter.
This is the inspiratory guard. So it should be always kept in the inspiratory side.
Let the consultant explain.
Okay, okay, sure.
Okay. So this is the inspiratory guard. So from here, ಆ ಕಡೆ ಹೋಗ್ಬೇಕಾ So this is the inspiratory limb which is going to the patient, and this is the Y connector to the patient. This is here we are using it as a test lung, and this is the expiratory. Expiratory goes here. So all your valve sensors will be here in the expiratory. So this will have the interrupt which will produce the determined tidal volume, the whatever settings you put. Everything is monitored from here. And in some there will be heated coil over this, which will allow the heated air to go till here, and there will be heat sensor. You don't have here, no?
Humidifier you have to add, sir.
Humidifier you will have to add. Yeah, there will be humidifier here which will be added. So humidifier which again it should not condense and lead to precipitation of the water. So there will be heated wire along with the heated coil. So then at the end of it they will measure the temperature. That port is not here. So basically they have kept the very basic ones here. Yeah, basic ones here. Those things will be there in the ventilator, which will enable you to give humidified, heated air till the trachea, bronchus. So this is the expiratory port, and this is escape valve, right?
Okay, this is expiratory flow sensor.
Flow sensor. So flow sensor is here. This can you?
Nebulizer.
With this you have a connector.
No, sir. Currently we don't have it.
Ah.
It should be connected to
Yes,
the
to the inspirator. This should be connected, and I had shown you in the presentation. So this is a nebulizer. In the similar way there will be inhalers. For COVID you should use more of inhalers, not this nebulizer. Nebulizer has been in use for since long time, but now because of COVID we are more of going away from this and towards the inhaler. So basic settings, just start the basic settings. Yeah, so these are the modes. This is volume control, pressure control. VC is the volume control, PC is the pressure control. PRVC, what happens? It controls both pressure and volume. Both are managed. In volume control, only the volume is controlled and the pressure goes according to the compliance. In pressure control, pressure is controlled, but for that pressure, whatever volume goes depends on the compliance of the lung. And this is SIMV VC. SIMV with volume control, and SIMV pressure control. So SIMV PRVC is also there. So these are all the things. We don't go to all these things. Okay, but then we usually use SIMV PC or PRVC. SIMV PC or SIMV VC, volume control, because you are just allowing the lung to breathe, and then you are doing your settings of controlling one of the parameters. Which one you are putting?
ACVC.
ACVC you want to put?
SMVC also.
SMVC. Okay. So basic parameters.
All are here, sir. FiO2 tidal volume.
Okay. So here volume control, you have to control the volume. So we will take for a 10 kg child. 10 kg child, what should be the volume? 10 into 6, 60. Put it as 60.
So I have to keep to pediatric then. Presently
Oh,
it is on
put it on pediatric because we are dealing with pediatric, no? It doesn't allow the low volumes if it is in adult. And if you don't keep it in neonatal, it doesn't allow for neonatal. Same. And when you are taking any of these ventilators, if you there will be high flow oxygen, HFOV. And HFOV sometimes in some ventilators you cannot do more than 10 kilos. So that is also one of the limitations. So you have to look at all these things. Okay. So this is pediatric now?
Yeah, it is pediatric.
Okay. So FiO2 how much you will keep usually? 100. 100 you keep. So usually start with 100. And tidal volume here 10 kg 60.
Rate we have to increase. Flow.
For a 10 kg child, what is the rate will be still more, even more than this, 25? Okay, 24, that's fine. Can you reduce it now? No, this depends on the... Okay, where is the eye time?
Inspirate.
Reduce it. That's why it will not take.
Yeah,
0.35, 3.4, it's fine. 0.35. Okay, flow. Increase it a little. Okay, 20. Peep, how much you want to keep? 5 to 6. Okay, 5. 5 is enough. Okay. Rate is 24. This is pressure support. Pressure support should be higher. Pressure support is the support on a spontaneous breath. You try to increase the pressure so that you can give more volume to the patient, because patient is in respiratory failure. He will not be able to take that much of volume. 20. Okay, right. So FiO2 is okay. Tidal volume somehow we are not getting it. Ideal 60.
60 we have to keep the neonatal side.
Okay, fine. So flow, PEEP, pressure support, rate, inspiratory time. Okay, patient synchrony, trigger 0.5 or to 1. Keep on. Trigger should be low. In case if you keep a high trigger, that means what? This much of liters per minute has to be generated by the patient so that this ventilator understands that there is an effort. If you keep 10 liters per minute patient has to generate, it's not possible. So that's why you have to keep low, usually 0.5, 1, that's how we keep. If you keep even less than that, even if the patient is little gasping, it will start giving the breath. So too low is also not good. Bias flow usually 3 to 5. 3.5. Okay, I think this is fine. Alarm settings.
Like low and high, sir.
Peak is 9 is low. Upper one, can you all see? Upper one peak, 9 is low and 45 is high. We don't want even 45. What should be the plateau I said at that 28 or 30? Okay. So when you keep PEEP and peak, then you get the plateau pressure. Plateau pressure has to be determined when you are ventilating, and that plateau pressure is the most effective pressure which determines the resistance in the airways. That's why that has to be determined. That you cannot keep it here. You keep the upper pressure and the lower pressure. Minute ventilation. Minute volume. That's fine, huh? Okay.
Expiratory tidal volume.
Respiratory rate is off.
We can turn it on.
Okay, this is expiratory tidal volume. Whenever we have set the ventilatory tidal volume, we usually see the expiratory tidal volume. Expiratory tidal volume is more guaranteed because it's coming out of the lung. There may be little bit of leak. What happens is inspiratory tidal volume is more which goes in, but then when it is coming out because of all the expiratory tidal volume is less. But then the whatever expiratory tidal volume, that is assured that it has gone to the lung. It may be little more than that, but not less than that. So the difference between inspiratory tidal volume and the expiratory tidal volume should be less than 10%. 10% of leak is expected. If the leak is more than that, you need to go for a higher size tube or a cuff tube. Okay. So here is the tidal volume. So you set the lowest tidal volume, below which, for example, if you have kept at 74, tidal volume you have kept 74. So here you keep it at 60 or 50 something. In case if it goes below 60, then there will be an alarm. So before connecting to the patient, you have to do all these settings, whatever you want, a little low and up, you put the alarms. Okay, go ahead, skip the alarm. So they do a system check to see whether there is any leak. When you press for the system check, if at all there is any leak, you will be able to detect. Sometimes, it will be happening. Most common leak will be somewhere in the tubings, either this end or that end. Okay. Can we start?
Yes. So system check you need to start?
No, start system check you.
So you can just patient circuit has to be attached. It has to be uploaded on there.
Okay. So system check they do like this.
Yeah, he showed us.
It will take little time.
How much time it takes?
Almost 3 to 4 minutes.
3-4 minutes, huh? Oh, okay.
If neonates means 3 to 4 minutes, adult means 2 to 3 minutes.
Okay. So this is it. Any questions? Anything you want to? We will now attach and just adjust and show you.
Thank you, sir.
Thank you. Connect it, no? Connect it to the system. Start. Okay. See now the effective tidal volume is no leak, na?
No, the fluorescence is having leak issues.
Okay. So this is the minute ventilation, 1 liter per minute. FiO2. FiO2, why did it become 21?
Sir, actually only
Oh, you don't have oxygen. Fine. So because we are using, though we set at 100, we are not using any oxygen, right? So PEEP is 5, peak pressure is 10. So
sorry, it is 24. It is keep on increasing.
this 10 is above the PEP. 10 plus 5 or 10 is total?
No, 10 is total.
Total. There are two types of ventilators. One which gives this upper pressure above the PEEP and one which gives the total. So you need to know your ventilator whether it gives this or that way. So that because we have set 20, there is some thing, it is not showing. So it should be actually, if it is above this, it should be 15.
20 is the pressure support, sir, like in case any trigger from the
Here it is not pressure support. Pressure support is only for the spontaneous breathing. So 20 will act only if the patient is breathing. It is a pressure support, I told you at that time. This is tidal volume. So tidal volume, we are not set the pressure. This is a volume control. So we are just want to give 75 ml. For 75 ml, whatever is the pressure generated is this. That's all. If I am pressure control, then I determine the pressure. Only thing is, even in this, if it is volume control, we have to know whether it is 10 is above 5 or total. That is depending on the ventilator how it shows. So we are not determining this. This is determined by the lung compliance. No humidifier. This circuit is all very basic one, just for demonstration years.
So humidifier will be keeping over here.
It will come here.
Here on connector will come.
So if there is a humidifier, the inspiratory will go to the humidifier, and from humidifier the another limb will go to the patient. That's all.
So trends will be
So then nowadays all this you can go back. If you are not on the night duty, you can always see. I think he was telling before we started this. So you can always go back. You can freeze all the data. You can see what time, what pressure was done. So in case if you are leaving it on a junior resident and then next day morning you are doing rounds, you can go back and analyze where the patient crashed, how many times it has crashed. So nothing can be hidden. So here you can see this PIP is here, PEEP. This is the lower pressure. It goes up like this and comes back. You can show this PV loop. Loops. No, madam. Over. I think we have done. After that, they will move. Yes, madam. Yeah. Yes, madam.
Ma'am, now we will be under YouTube link live. I'm sorry, your voice is agirutta. You have to use the mic. And Radlata,
Yeah, I'll explain and you will do, okay? So can we, they'll think I'm slaughtering something over here. At least ಸ್ವಲ್ಪ ನೀಟಾಗಿ ಇಡೋಣ. Okay. Okay, so this is the intraosseous station, shock station. I think we already learnt about all the fluids and which type of fluid that we would choose. Now we come to getting vascular access. Many a times, especially in the small babies, we don't get the vascular access in the veins. And in situations of cardiac arrest, time is precious. So we need to get the access within few seconds. So one of the useful access is called as intraosseous. Now, there is no age limit. You can use it at any age. And simple bone marrow needle can be used, or we have the Cook's interosseous needle, which is very, very useful. Now, the parts of this needle are, it's like a cannula. It has a stillet and it has a needle. So you have to click that in place. It also comes with this guard, which can be changed its position based on the thickness of the bone. So for older children, you put the guard at the back, and for younger children, you put it in the front. The important thing in intraosseous is to know the site. You are using it only for a collapsed, arrested baby. We are not using it for a crying elective procedure. So there we keep trying. But in a collapsed child where we don't have time, we use it. So obviously we don't need sedation because the child is already collapsed. Now, which are the sites that we can use? Correct. So the upper end of the tibia or the lower end of the femur is where we would use. And the best method is just below the tibial tuberosity and medially. That is where it is ideally to be used. And because that's where you can feel it on your leg also, where it has the least amount of fat and muscle, so which is easily accessible. Now the good thing is, you know that you can get it, but if you miss it and if you puncture it 2 times, it will start leaking. So you try it once, otherwise if it's not getting it, you have to shift the limb. You could use the lower end of the femur, you could use the humeral bone, you can use the iliac crest, but they are all desperate measures. Okay, now methodology, the important thing is to fix the position. So make sure the baby's limb, thank you, is fixed this way, where it is externally rotated. You have some sort of pillow kept beneath. Your nurse is nicely positioning it, and you get ready with the intraosseous needle. And this should be held like a drill, and when you hold it, you go to the position, and with a screwing motion, you have to drill it in. So the best feel is when you do it on a chicken leg. So I'm just going to take you through. For those of you who eat chicken, you know that eating the edges of the bone is much easier, chewable, whereas compared to the center, which is the cortical bone. So never put it in the center of the bone. Likewise, don't choose this. Go as much to the edges of the bone just below the growth plate. So once we hold it like a pen, we go to the edge of the bone, you go through the soft tissue, then you can actually feel that your needle is touching the bone. Holding it at 90 degrees, you go and there you get a give way. Then you know perfectly you're in the right position, and whatever you do, this does not change, this does not shake. You remove this and then you take your syringe and you withdraw. Now obviously in this chicken leg you're not going to get the blood, but most often you do get the blood. Now this blood can be used for all tests. There's no problem at all. You can do your calcium, electrolytes, culture, everything, whatever is possible. Sometimes when you don't get blood, that doesn't mean you're not in the space. The definitive indicator for being in the space is it is fixed. Then you draw up some saline and you push it. If it is going through easily, you know that you are in some space. You're not within the bone. So that's fine. Now the fixing method is you make a bridge and you fix it, or you fix it with a round plaster. How long can you keep the intraosseous? You can keep it as long as you want, but usually within a few hours it will displace. So this is an emergency line till you get in your definitive central line, till your surgeon comes and does whatever procedure. This is a life-saving line and we need to know how to do it. Okay? So one of you can try now.
When it comes to administration of drugs, can we give?
Every drug, adrenaline, blood, FFP, whatever you want, you can give it there. Pardon?
Gauges, which gauge to select?
Yeah, actually, even in bone marrow, if you notice, we have only two sizes. So whatever size you get as a life-saving procedure, you can just use it. It's just important to know that as soon as you give the give way, you stop. Yeah, you hold it like a pen, yes. Go to the edge, make sure that you've fixed the bone. 90 degree. It doesn't matter, doesn't matter. Go to the end, yeah, good. Screwing motion. Wait, try still. Let me see. Yeah, you are in. Yes, you are in. That's all it is. This is how the infant bone feels. Okay? Maybe one more person can. So maybe you can try the lower end. Yeah, but make sure you're 90 degree. This is tougher actually because it's, that must be very tough. Yeah, good. Yeah, it happens. Then we can't use that whole limb. We have to go to another limb. That's why the guard is there.
Any measures to be taken to stop bleeding when it goes through and through?
No, nothing. See, remember, you're in an arrest situation. The child in another 2 minutes is going to be declared. So you don't want that. So don't worry about minor things. That can easily, just like a bone marrow, what do? We just give compression bandage. Yeah? Ashte, thank you.
Come this side. This is the second group, no? Third group. I think second group came. All mixed up, I think. All mixed up, okay. Okay, sir. Good evening. So we have got, I think, oxygen concentrator. You have understood. This is. So this is an oxygen concentrator. This is one machine which I would like to explain, which is a new one for pediatric age group adult. This is called BiPAP machine. It's called BiPAP. So it gives pressure at two levels, when somebody is inspirating and somebody is expirating also. CPAP gives only at one settle, that is expiration. So it supports only the expiration. This supports inspiration and expiration. So this is one good thing which has come up now, which is going to be helpful, which will also reduce invasive ventilation. We don't have to intubate also. It almost gives equal effect as intubation. Okay, so this is easy to fix also. This is an interface. Yeah. This is an interface. If you look at the so we have to fix it like this. Okay. So that's how we have to. So if the leakage is minimal, then it becomes it's almost like an invasive ventilation. You don't have to intubate. It almost serves like an invasive ventilation, but it is non-invasive. This seal is very soft, and the best thing about is it also gives inspiratory flow and expiratory flow. So if the child is breathing in a shallow way, this will improve the inspiratory flow when there is a flow. So it detects, it senses the flow or a breath or amount of the air inside it, and it gives it. Expiratory also it gives. So indication, desaturation is the primary indication. If the SpO2 is less than 92%, you can connect it to the high flow, which is there, one high flow nasal cannula. This is an high flow nasal cannula, the first, but this will not give as good as this. You can connect it to this. If the saturations are not improving, then you can actually go for this. So this, the chances of recovering and improving saturation is as good as ventilation. So that is one good thing about BiPAP. So it gives bi-level pressures. It gives inspiration pressure, it gives expiration pressure. So this is one of the things. You can set, as you set the simple CPAP or a ventilator. You also have a PIP. You can set it to 20 PIP. The expiratory EPAIP is around 6 to 8. It depends on the weight of the child. For a 5 kg, you will have to fix it 8. FiO2 can be fixed here, which is at least should be 50%, 40 to 50%. And this should be connected, it's an electric supported. So connected to the electricity. It's a very small machine, handy, and the very important thing here is we do not need close monitoring of the patient. We do not need a nurse next to the patient because there is nothing here. You are just fixing here and going. If at all, if there is an invasive ventilation, we need to have a nursing station very close to the patient for tube suctioning, for cleaning of the oral secretions. But here, we do not need this. That's one of the best advantage of this. It takes around 2 minutes to set up this. Even if the child has come without the prior notification, you can connect this. So this is called BiPAP. What sizes of mask can we put here? See, there are 2 sizes, right?
Small, medium, large.
Small, 3 sizes. This is a 3. So it's got 3 sizes. See, if you can feel it and see the interface. No, you can start more than 2 years.
2 years you can.
At any age, till 60, 70, 80 years. But for adults, they have used well. For pediatric, we are started using now. You can look at the interface, it is very soft. It will not pain.
This can be used only for more than 5 years?
2 years. We can use it for 1 year, but babies might not hold it well. They might get displaced. Less than 2 years, CPAP is good, or invasive ventilation, or high flow nasal. Where is that high flow? Yeah. Listen, HFNC it's called, high flow nasal cannula. This is also good. This is also soft. See, maximum flow actually increase the flow, increase the pressure. So we start with 6 liters, 7 liters, till you reach a saturation of 92%. So it's all in your hand. For example, a child has come with saturation of 85. You have connected to this with minimum 5 liters. Saturation is not improving over 15 minutes. You make it 6 liters. It has come to 88. You make it 7 liters. Once it reaches 92%, you can stop to that flow rate. So it is not a fixed flow rate. It all depends on the child and the condition, weight of the child also.
This you just connect to oxygen or you connect to any machine or what?
So you will have to connect.
No, you can connect it directly over here. This kind of single tube you have to use it.
Yes.
So this one you can connect it over here directly. Yes, you can connect it like this and you can use it.
This is a rubber and
You said this needs central oxygen. I mean, this should
Which
be
one?
supplemented with oxygen.
No, you
Yes,
can
yes.
use this also.
Flow, this
Concentrator also.
Concentrators also you can use.
Concentrate also.
This needs central oxygen or?
So if you are using in hospital, you can use the centralized oxygen supply. If you are using it home,
If you don't have, if you don't have central oxygen.
So concentrate.
Or cylinder.
Cylinders can be used.
This can be.
Yes, yes, you have to adjust the flow
Yeah,
rate.
it has a
Big cylinder.
different modes. This is for
Jumbo
5
cylinder.
It has a
No, jumbo.
capacity
5 liters start,
10 liters.
go up to 15 liters.
So what if you are requiring more? With FI also, right? Then you have to use with this particular. You are having only about oxygen or with
Thank you.
only about oxygen. Then you have to use
Hello, this is okay. Hello, this is Neonatal resuscitation station. In this, we can see the different equipments which are required for a neonatal resuscitation. First, we will do the equipment check. One is the TPS resuscitator, stat, ambu bag mask with different size endotracheal tube and laryngoscope with 0 blade and 0 blade, and this is the corrugated tube, and this is the oxygen reservoir. This is the mask with one used for term babies, 0 for preterm babies, and oxygen is there. So whenever the baby is born, we should ask 3 questions. One is whether the term gestation or preterm. Next will be how is the baby respiratory effort, good or crying, and muzzle tone. If answer is 3 yes for all 3, we can tell the thing that there is no resuscitation required. We can put the baby on mother abdomen, give the skin scoot in care, allow for the delayed cord clamping of 1 minute, and by the time in that time you see the baby respiratory effort, see for the cardiovascular status, and wipe the baby mouth and nose if there is obvious secretions are there. If everything is fine, then you can cut the umbilical cord and start the feed for the mother from the for the baby from the mother, and baby can be shifted to the mother side. If any of the questions which are 3 questions you ask is no, we can have to start with the baby should be shifted to the warm incubator radiant warmer after informing the mother that baby may require further efforts, and cord should be clamped and cut, and as soon as the baby is received on the warmer, we have to assess the baby for the respiratory effort, how the respiratory effort are there, good or bad. Following that, we can decide regarding the need for resuscitation. Prior to the receiving the baby, we have to do the equipment check. In this, ambu mask should be checked for adequacy, and when the baby is having poor respiratory effort, we have to give the mask ventilation using a appropriate size mask, 0 for preterm, 1 for term babies, and using the adequate sized ambu bag. This is for a term baby, this is for a preterm baby, and depending upon the baby respiratory effort, this can be used. If the preterm baby, we can use cover the mask is specifically for a preterm baby. mask is 0 size, and the mask should cover the mouth and the nose, and it should not override the chin or cover the eyes. And once you seal is fine, try to give positive breaths by using the umbu bag. Give 5 breaths. Watch for the chest rise. If there is no chest rise, you have to do the corrective ventilation corrective step, which has been acronym as MR-SOPA. After 30 seconds of this umbu bag, if the respiratory effort or poor baby heart rate is not improved, then you have to go for endotracheal intubation using the appropriate size endotracheal tube, and the tube should be fixed depending upon the gestation age or using the nasotracheal length plus 1 centimeter, and the baby should be ventilated with endotracheal ventilation. And if the heart rate is still less than 100, less than 60, and you can do chest compression. Chest compression is done with 2 finger, 2 thumb chest encircling technique. In this, the 2 thumbs are placed in the lowest end of the sternum, and the other fingers are encircled around the chest and give a chest compression. That should be 90 compressions and 30 ventilation breaths should be given. Total 120 events should be given, and same time we have to keep a watch on the baby heart rate, because resolution of bradycardia is the surest indication for adequacy of ventilator effort. By the time you intubate the baby, chest lead should be placed and the baby should be put on ECG monitoring, and we should target the pre-ductal saturation for the appropriate time using the pre-saturation probe. And this is the TP resuscitator being used, which is recommended because it delivers both PIP as well as PWP. In this is the PWP valve, which will be preset. Depending upon the PEEP you set, that much PEEP will be delivered, and this is the PIP setting valve. And with this CPAP can be delivered. If you just connect the mask and connect to the baby, as the PEEP valve is set, it will deliver the PEEP. It acts like a CPAP. Suppose we want to give a breath, you can just do this. This number of times you give it, that much breath will be delivered. It will give you the adequate PIP. And this has been recommended now for neonatal resuscitation. And next, if in spite of this baby doesn't respond, have a heart rate of less than 60, you can use put an IV line or umbilical line and give it drugs, adrenaline, intravenous adrenaline or else intratracheal adrenaline. And if it doesn't respond, you can give the IV fluids. Sir, bani. 16 ಅಲ್ಲಿ ಅಷ್ಟೇ ಅಲ್ಲ.
ಇಲ್ಲ ಅಮ್ಮ ಮೇಡಮ್ ಮೇಡಮ್ ಬಸವರಾಜ್ ಬಂದಿಲ್ವಾ ಫೋನ್ ಮಾಡಿದ್ರಾ
ಸರ್ ಇಬ್ರು ಮಾತಾಡಿ
So you are at the oxygen delivery station, and we give oxygen through low flow and high flow oxygen. Low flow and high flow oxygen. High flow oxygen means there is no entrapment of room air into the oxygen, and it gives a fixed amount of oxygen concentration. Whereas in low flow, there is a entrapment of room air, which dilutes the oxygen. Though the oxygen you are giving is 100%, it gets diluted in the room air, and the concentration of the oxygen is variable. So that is the difference between low flow and high flow oxygen. Now, what are the devices which give low flow oxygen? The low flow oxygen are given through we can give it through the nasal prongs, and we can give it through the mask. You want me to open it and show? So the mask, usually it should fit snugly over the nose, and it will give a good this thing. There will be usually for an adult mask, there will be a metal piece which makes the contour around the nose, and which makes it sit snugly on the on the nose, so that you have a good this thing. This is to the strapping for the head, and the oxygen is connected at this end. You can give oxygen about the minimum supply of oxygen should be 5 liters. The reason behind 5 liters is there should be no rebreathing, so that's why the carbon dioxide which is breathed out goes out through this. The oxygen which comes through pushes out the carbon dioxide. So this is the basic mechanism of this, and 6 liters of oxygen can give about 28 to 30%, and 10 liters of oxygen can give you about 45 to 50%. If the mask is snugly fitting on the face. If not, it may give much lesser than that. So this is about the mask. Coming to the nasal prong. These are the nasal prongs which is commonly used, and it can be used between from the neonate to up to the age of 5 or 10 or any age group. But this comes with different sizes. Usually it is very small, about 1 millimeter for the neonates, and 2 millimeters for infants, and the regular one pediatric, and you get the adult one which is much bigger than this. So you can deliver or you can give oxygen through this about from 1 to 5 liters. If you give more than 5 liters, it's going to cause trauma, irritation in the nasal cavity. So you are not going to give more than 5 liters. When you increase the oxygen capacity through this, every rise in 1 liter will increase the oxygen concentration by about 3 to 5%. So if you are giving at 1 liter of oxygen, this will increase the concentration to about 25 to 26%. If you are giving 2 liters, it becomes about 30%, and 4 liters is around 35, and 5 liters you may be giving around 40% of oxygen through this. If you want to give more oxygen, then you have to switch over to high flow oxygens. The other things which we were using earlier was nasal hood oxygen, which is now out of fashion. So coming to high flow nasal oxygen, I think we have 2 of them. One is the Venturi mask and the other one is the NRM. The Venturi mask has different colors and can give oxygen concentration up to 60 to 70%, depending on the color question. This is a NRM mask. This is the restraint string. This is an expiratory valve. What you see here, both are expiratory valves. There is an inspiratory valve here, which you can see the green one, and this is the reservoir. So basically you have to use this when these things fail, and if the child is not able to maintain more than 94% of saturation. So this is when you are using NRM mask, basic minimum amount of oxygen to be delivered is used is about 10 to 15 liters per minute. So this, if it is snugly fitting, can deliver up to 90% plus the FiO2 this thing. FiO2 will be around 90% if it is used. So if it is snugly fitting. If it is not snugly fitting, it becomes again a low flow or a partial rebreathing mask. So other thing about this is it can be used easily, but the disadvantages of this is that children can be claustrophobic. It is scary. There's a big balloon sitting on the chest, so they may not like it. So, but it is a very essential thing. Most of the during the COVID season, a lot of adult patients were put on NRM, and there was a lot of good recovery with this. So we can use this. We use this regularly in our emergency department for pneumonia, bronchiolitis, and other lung-related problems. So if this fails, then we have high frequency humidified or HFNC. When all these fail, then we are left with only one thing, that is you have to go to intubation. And I think my friend Dr. Karnakar takes over.
Thank you, Dr. Raghu. Intubation is basically required for very small number of patients who are very serious actually. If patients sometimes they say they have very severe pneumonia, even with COVID pneumonia very severe, they require to be put on ventilator, then we are going to intubate the patient and put on the ventilator. We also know that there is non-invasive ventilation. We are going to use mask and ventilate. Even when that's failed, only option is available to ventilate actually. This is the hardcore ventilation aspect where we are supposed to intubate, put a endotracheal tube inside the trachea and keep it inside and then ventilate as per the prescribed settings actually. Intubation basically is a very skilled procedure. The person who is doing should have an expertise of doing it. Ideally, we practice on the mannequins and then it has to be done. So when you are trying to intubate, we decide the patient require an intubation. We keep things ready. We need medication before intubating. We call it as pre-medications. We use some medication for giving sedation, analgesia to reduce pain, and also use some medication to even give muscle relaxant before intubate, because otherwise it won't be possible to intubate. So we keep things ready for intubation. That's called pre-anesthetic, pre-intubation medications. We have to keep that. While doing procedure also, after giving all the things, then we try to intubate. There is a procedure, it's called endotracheal intubation. This is a laryngoscope actually. Different types of blades are available. This is straight blade, this is curved blade. Depending upon the age of the patient and need of the patient, we decide either we select as straight blade or a curved blade actually. If it is a small neonate and infants, we can do it with straight blade. This is a straight blade actually. This is basically, this is a two-hand handle. There is batteries inside. This is the blade for intubation and there is a light to view inside. So this has to be properly working, then only we can intubate. Endotracheal tube. Different size of endotracheal tubes are available. So this basically consists of a length of a tube. There is a markings here. It's supposed to go beyond larynx actually. So once it goes, the numbers are there here. Based on that, we know how to fix it. There is different formulas are available to suggest what size of the endotracheal tube should be selected, what length we are supposed to fix. Accordingly, we are going to fix it and then connect to the umbu bag and then see what can be done. I'll demonstrate the procedure now. So when you give him pre-medication, then use laryngoscope properly. You're supposed to hold it like this, right? Hold it here, pull it and see. And neck should be extended, not too much, little bit extension where you can see the whatever is there in that actually. And once you can able to visualize the larynx, that's the most important. Larynx should be visualized. This is how you hold the tube and we pass it through and put it inside actually. It's a skill procedure. Sometimes it's very difficult. In those cases, even backup with anesthetist, sometimes ENT surgeon. So once we put a tube inside, then we connect an umbu bag. We use a connect an umbu bag and see what happens actually. So when doing it, then we can realize that where is going inside or not. So normally if tube is gone inside, naturally lungs start expanding and then we realize both side is there. Then you look at the marking also approximately at what level its air entry is both side equal, and then we fix it accordingly. We use stethoscope and auscultate on both sides and make sure that tube is inside. So when you put the tube, sometimes it can go to measure, we target to put it into the lung, but sometimes it can go to the stomach also. So we have to confirm that it's not in the stomach, it's in the lung, and then do umbu bag and confirm it, right? And then we decide that it's inside, then we fix the tube and then start doing umbu bag actually. In an emergency, when you are doing CPR, if normally patient is not able to ventilate, breathe himself, sometimes we go to endotracheal intubation and we support like this. So on patient improved, then we know that child is requiring intubation, is not able to maintain his airway himself, he has to be put on mechanical ventilator. To that we already seen in the other stations, we connect to the mechanical ventilator, tubings will be connected here and put the setting and is going to breathe according to that. We adjust setting, we do blood gases and adjust what is the requirement, and depending upon the different types of problem, different types of settings are used, different modes are used, and we ventilate patient like that. This is about intubation and mechanical ventilation. And mechanical ventilation has been told in other stations is basically about airway and intubation. Thank you so much. Thank you.